Good morning, everyone. Warm welcome to the fifth edition of the Royal Indian Pediatric Update for Pediatricians. Let's go over to Dr. Naik and then Meenal for the Peeds gastroenterology talks. Good morning, Dr. Naik. Dr. Naik's my pediatric gastroenterology colleague, has been my mentor for years, and she's going to talk on constipation, reflux, and IBS. And I understand IBS, she's going to do it with Meenal, who's one of our lead dietitians in pediatrics. So over to you.
Thanks very much, Akshay, and good morning to the 176 who've already joined. So we're going to do a series of three talks. The first one doesn't have polls, so if you're just sort of waking up, we'll have some time. Then we'll do a couple of interactive talks, and the third talk will be a duet session with myself and my colleague, Miss Patel. So let's just get the first. Guys, when it comes to constipation, I'm probably preaching something that you already know, so think of it more as a refresher. If you're going to see children with constipation, you have to have the Bristol stool chart handy, whether it's on your laptop, whether it's on your desktop, if your trust allows you to put up a poster on the side, or if a lanyard. But I don't think you can manage constipation without the Bristol stool chart. The main thing is, what do the families mean and how do these children actually present? What we do know is that there's a variable presentation, but we also know it takes up 50% of our clinic. So it is important to try and get it right from the beginning. The majority can actually wean their medication within 1 year. So the whole point is the really boring, take a detailed history. What do the family actually mean by constipation? Is it that just they don't go very often? Is it that they pass hard stools? Is it that they pass tiny little pellets? Do they have overflow? Is there or is there not abdominal pain? Sometimes a bit of bleeding. And it doesn't take long in a history just to work out exactly what the family mean by constipation. I've noticed as years go by that parents like labels and they like a little bit more detail. So for constipation, it can be actually classified if you look up the Rome 4 criteria. And here you can see that functional constipation includes a month of two of the symptoms at least, which is two or fewer stools a week, excessive hot stool retention, a toddler sort of hiding behind the corner, a history of painful or large hard stools. You know, sometimes you get a family saying it's like an elephant's poo, it's a massive log, or if you can feel a mass. Now, in toilet trained children, there is some additional criteria. So it is worth maybe having a quick look at the Rome 4 criteria. Now, apologies, this slide is slightly busy, but the Rome 4 criteria is broken down into toddlers, which I showed already, and the older child. And again, it's two or more of the following. And there is a subtle difference in the Rome criteria for constipation or the Rome criteria for irritable bowel. And we'll be going over this in a talk later on. So again, how many stools they're having, is there a mass, how big they are. And then in the older child, you know, there is children who kind of have inappropriate defecation. And so that is also being included as a non-retentive fecal incontinence. So Rome 4 criteria for labels and to help you classify. It's also important to think really basically about the age of the child. If they are less than 6 months, constipation is pretty uncommon in a breastfed child. However, it does occur occasionally in a formula-fed child. They may be wrongly diagnosed too early to say this is allergy, this is this, and often it's related purely to the fact that they are having a rather concentrated feed and not enough water. Obviously, I put a little note that if there's blood in the stools around the age of 4 to 6 weeks with mucus, you might actually think about casmok protein allergy. And then the much more common one we see is when they start weaning. And particularly in the UK, but it is now increasing in urban areas abroad. And it's purely related to the lack of fruit, fluid, and fiber. And classically, they strain, they pass hard stools, they don't drink enough water. Um, if there is a triad of symptoms, which my colleagues will go into, then you might need to think about allergy. There is nice guidelines which are slightly old but still relevant for the management of constipation. And the only red flags I've said is abnormal neurology, which is kind of obvious, and a failure to pass meconium. There are some subtle amber flags, um, and particularly if you're worried about allergy, then you can think about double-blind challenges, or often parents will talk about family history. I had constipation as a child, and so did grandma, and so did great uncle. Um, Distension and vomiting is subtle because if you've got a large fecalith, you are going to get some abdominal distension and a bit of vomiting. The treatment. Well, as I mentioned in the babies, if they're breastfeeding, do they need a breastfeeding counselling? Have they latched on appropriately? Is it all really basics? We really want to avoid multiple feed changes, which is what often our colleagues in primary care do and rather too quickly. Um, we do need to ensure there's adequate water. And very occasionally, you might need to consider lactulose at low dose. And I would not use a stimulant in a baby under 6 months. However, in the toddler age group, there's no doubt that once we've addressed the water and once we've addressed the diet, that we need to use macrogoals. So Movicol, Moviprep. Um, and the main thing that I want to preach is using a stimulant early, particularly for those who strain, because we want to overcome that sensation. And if they're hiding their poos or they're straining, they're not going to want a toilet train. Lifestyle changes are easy to discuss, but very hard to implement. And nowadays, particularly our older children, are much more immobile, less active sports, much more into computer games, being on their laptops, on their phones. Um, and again, it's the early use of a stimulant together with Movicol, which is important, but more importantly, it's actually setting realistic expectations. If they are constipated for a good 6 to 9 months by the time they get to you, it's probably going to take 6 to 9 months to get better. Um, and you need to assess whether or not they need a disimpaction before they have their maintenance. And this will be purely on examination if they've got gross fecal loading, which is very easy to feel. The other tip is to wean slowly. There is no point saying, right, you're on 4 sachets a day, go 4, 3, 2 in a period of, 3 weeks, when they probably need weaning over many, many months. And surgical intervention with something like a manual evac is really, I wouldn't expect you to do it in secondary care. That would be once they're referred to us for really refractory signs. So what do I mean by refractory? Well, obviously red flag if there's, spinal cord tethering or you've discovered a spina bifida. And if they've optimized the dose of the stimulant and the macrogol and they're compliant, because what often happens is they do well, and then the parents think, oh, they're fine now. They're opening their bowels regularly. It's nice and soft. And then they start stopping the medication regularly. So they've stopped it too early. In hospital, we can do transit marker studies. On the left-hand side of your screen, you will see pellets all the way through the abdomen. So this is generalized slow colonic transit. But in the right one, you can see they're just all in the rectum. So this is where you've got a distal evacuatory disorder. They need much more stimulants because it's all about push. They haven't got a strong enough push. Transit marker studies can be done in secondary care. They swallow the marker and do an X-ray at day 5. and they are to stop the laxatives in those 5 days. What do we do in tertiary care for refractory? Well, we can do an ultrasound, and this is particularly for those who have an interest. And what they do, as you can see, is insert a gentle probe and then inflate a balloon, and they can measure pressures. And it's all about then behavioral therapy, toilet training, rocking and popping, um, which usually helps. We can also do peristeen washouts, and these are essentially where you inflate and the pressure, they actually reach a critical point where they then have sensation. So smaller amount, they don't have sensation, larger amount, they do. And often it's the stoma nurses who are involved in training up the families for the peristeen. And this is just, as I said, for a refractory few. We have to mention surgery, although, as I said, we're now into the small, tiny, tiny numbers. And you can have essentially a button placed, and depending on whether they've got totally slow colonic transit or it's a distal, is where you place it. So you could place it in the appendix, you could place it in the cecum. And what happens is they then sit on the toilet, they administer the medicine through the button. And so you're essentially giving them a washout, but locally rather than having to drink lots. So we know that constipation is really common. We know that it's all about education of the family, reassuring them, and managing their expectations. I've emphasized that dietary and behavior manipulation is important, and it's just to keep re-emphasizing this because you can throw lots of medication at these children, but they do need to implement the diet and the toilet training in addition. Now, disimpaction, we use Movicol in high doses. Now, if you read the guidance, it says build it up over 4 days, where you could have 2 sachets, 4 sachets, 6 sachets, 8 sachets on a daily basis. I personally think the other way around is just as good. So you go 10, 8, 6, 4, 2. There is no excuse to leave them on a disimpaction regime for more than that week. And if they haven't responded, then it means you need to start your stimulants there and then, or you can start it when you follow them up. Now, we're all tight with our follow-up clinics, so it might just be a telephone review. But the other optimal way of managing is to ensure after the first consult, another one in sort of 8 weeks' time, and then you can start spread it out. For those where you're not sure, should I be up in the medicine, down in the medicine, they may be refractory or they may not. We at the Royal London are very happy to take advice before we actually accept the referral, and hopefully you've got that locally as well. So we've done a bit of a whistle-stop tour through constipation, and Akshay, I'm happy to take questions now.
Well, thank you, Dr. Naik. Always a really popular topic and something which is bread and butter for general pediatricians like us. We get a lot of these questions. There are some common themed questions. If I may start with, there are a lot of questions about the under 6 months. The physiology, how is it different? Do you give water? Do you not give water? How much water should you give? What laxatives?
Yeah. So first of all, don't avoid laxatives. I mean, I know we very occasionally GPs might use lactulose, but I would try and avoid laxatives. It's usually in the formula fed, and as much as it might upset, the breastfeeding and the midwives, they say you don't need extra water. Well, if you are constipated and the baby's crying and straining, well, you do need to intervene. Um, and people always say, "Oh, I can't work out what volume." We're not talking measuring out, but if you really want a number, 5 to 10 mils per kilo. So it's only small amounts. And the easiest is if you make up a feed, you just add a little bit more water, so it's slightly more dilute. That's the easiest, practical way to take that forward.
Also, having done the gastro placement under you and the gastro team, the one thing I realized was breastfed babies. They do a lot of good things. They save a lot of money on milk. They will save a lot of money on nappies. They don't open bowels regularly, isn't it?
Yeah. So breastfeeding babies, if they're not straining, right? If a baby's not straining or distressed, um, majority are supposed to, poop after every feed. But it's fine if they don't. If they have a nice, soft, seedy stool and it's only a couple of times a day, heaven forbid the one that is one every 2 days, but they're comfortable and they're fine, leave them. It's the ones where, suddenly they're crying, straining, it's not colic, and there's a change in their stool. It's not the normal seedy yellow stool.
I think so that will answer the question which Shalini also has asked about, there's breastfed baby, meconium passed in the first 24 hours, but bowel frequency is actually quite a long one. 3 weeks, I think, so is a bit of a stretch, I think, isn't it? We should
Yeah, 3 weeks
think.
is definitely a little bit. I mean, every couple of days, fine. If it's a 3 week they haven't pooed, there's definitely something not right, and that would need proper investigation. That's moving into the amber flags.
Topical question again. We're getting a lot of children with neurodiversity are fed and they don't take medicines. And we got a couple of good questions on, do you have a magic answer? What should we do about managing them? Because they don't like the macro calls, for example,
Yeah,
palatability.
I know. It's that's going to be the biggest challenge. There was, and I don't know if it's still available, the chocolate flavor Movacol, which is it's a clear preparation, but it genuinely tastes of chocolate. The other thing is that most of the children who have selective eating for what or taste, there's a particular flavor they do like. So, for example, you could just add a few drops of juice if they are into blackcurrant, for example, to disguise the flavor. So you need to disguise it. I don't recommend it, so please don't take it to heart. But there are one or two patients who have said, my child only drinks milk. So what I've said is, they've diluted the milk, really dilute, because there's no point pouring milk in, and use the Movicol in milk. So what you have to do is work with a parent to work out what taste they can utilize to disguise it. Um, because there really is, and then the other way is then you may need to use an alternative such as sodium docosate syrup, which works as both a stimulant and an osmotic.
Thank you, Dr. Naik. Thank you. A couple of questions on investigations, transit markers. So Dr. Ahmed Hassan asks us about, do you stop all laxatives only during those 5 days, or what's the exact sort of thing which you would do? Uh, and would you, is there a role of continuing Movicol? That's my question, I would ask you.
So you tell them, you write the instructions. So for example, I'll make it nice and easy. Monday, stop all medicines. Friday, get your abdominal x-ray. As soon as you've had your x-ray, go back to your normal medicines.
Lovely.
And then obviously look at the x-ray fairly soon so that they can then implement the changes.
I think, Dr. Naik, there are some other questions which we can answer later on. So we could
Absolutely.
go to your next talk. Let's go to your next talk.
Sure. Okay, no hitches this time, thank goodness. So, guys, we're going to now switch topics. We've gone from the bottom end and we're now going to go to the top end. I was asked to focus a little bit on the management. We're also going to make this a little bit more interactive. So, we've now gone to 250 participants. So, welcome everyone. So, what we need to do when we think about reflux is ensure we know the difference between gastroesophageal reflux, which is a normal physiological occurrence, um, to that of gastroesophageal reflux disease. We all reflux a little, and if we all had a pH impedance probe while we ate, we would all have a bit of reflux, and that is normal. And in particular, when you're a baby and you've got vomiting from other reasons, a septic baby, a child with a UTI, always ensure that the vomiting, which is the most common symptom, is actually reflux and not something else. And reflux itself happens in all age groups. So what we need to do is focus on reflux disease. Um, red flags. So is there weight loss? Have they had food aversion because they've been getting pain all the time? Something like Sandifer syndrome, where they're really arching their back and really, really distressed when they eat, and obviously evidence of a GI bleed. So let's see, hopefully you're all there now. Which of the below do you think is not a red flag for gastroesophageal reflux disease in babies? Is it weight loss, crying, vomiting, apneas, or bilious vomiting? Jeremy? So we'll just give a few seconds because we have got quite a lot. So this is the red flag for babies. I'm then going to do red flag in olders, and then we'll talk about it. Okay, so we have got two-thirds majority saying that excessive crying is not a red flag. There's probably 2%, must be one person said weight loss. Weight loss is always a red flag in baby. So that and bilious vomiting absolutely is, you may have not heard me say not a red flag. Red flag definitely for bilious vomiting. Okay, we'll close that. So now, which of these is not a red flag in the older child? Cough, selective eating, weight loss, a hoarse voice, or epigastric pain? Let's see what you guys think. And then what we'll do is talk about the actual red and amber flags. So again, for those who are online, it was not a red flag. Thanks, Jeremy. Okay, so we've got uh selective eating. Two-thirds of you have said this is not a red flag, and only 1 in 5 have said cough is not a red flag. So let's see what we think. Thank you, Jeremy. So here are my red flags. The answer was B, because if you have projectile vomiting, obviously you need to exclude pie. Bilious vomiting, ensure there's no surgical condition. Apneas, obviously, and faltering growth. Obviously, babies cry all the time for all sorts of reasons. And although it might be a sign of reflux, it's definitely not a red flag in itself. Now, the older child, the answer was actually cough, because selective eating, although we do need to think about nowadays with the increase in neurodiverse population, but a significant proportion of children become selective eaters because they had silent, untreated reflux as children, and they've been having pain and irritability, and that's why they've gone off their food. Obviously, refractory epigastric pain, weight loss, definitely a red flag. Dysphagia, they could be developing a stricture from reflux. The hoarse voice is a red flag because what happens is the acid is damaging bits around the epiglottis and the vocal cords, and obviously a GI bleed. So, amber flags. So, as I mentioned, irritability might be part of it. A cough. Now, pneumonia, because everyone will think, oh, well, what about aspiration pneumonia? Well, if you're refluxing enough, so not from the upper airways, from the stomach back into the esophagus and then back into the lungs, um, there's probably another reason of why. So is it a neurodisabled child? Have they got global developmental delay? Have they got a swallowing issue? So pneumonia is an amber flag, I would say. And then again, a history of atopy is amber. So let's do some more polls and see whether we are managing these children appropriately. So we have a 6 week old formula fed cow and gate, and they are tracking centiles. If you want specifics, they're fine on the 25th. But after each feed, they are crying and vomiting a small amount. So my question to the audience is, what would you do in this situation? Mum's a bit worried because it's only a 6 week old. Would you immediately start a PPI? Would you give him a Gaviscon? Would you change the formula? Would you do all of that? Or would you simply be strong and reassure them? Let's see what you think. 256 audience. Brilliant. Reassure. Oh, I want to hug 3/4 of you. Obviously, slightly inappropriate. That is because that is the correct answer. Thank you, Jeremy. So the difficulty is, um, in a 6 week old, you are going to get parental anxiety, but what you don't want to do is rush in and change things. So the answer is, where possible, yes, you do want to reassure them. They're tracking centiles. That was the important thing. But then what you do need to do is for the small percentage that might be warranting intervention, what is the volume of feeding? Because overfeeding can also cause them to vomit. How frequently? And do remember that most of the babies who vomit a little have reflux and not reflux disease. However, there are some things you can use for babies if they do need intervention. Um, I'm not a fan of thickeners, but these are the lists that are available. Um, Gaviscon, some parents absolutely love Gaviscon. I personally am not a fan, and very rarely is a formula change warranted. But most of the time, what happens is parents actually have changed, the ones that you get just in the supermarket is all advertising, and it's all to do with the amount of casein and whey, and will it set in the stomach longer, and therefore they're less likely to vomit it up. Less evidence based. Um, and I would only implement formula changes, in all honesty, if there's a red flag, such as they're really vomiting large amounts and losing weight, and then you might need to give them something. The other tip is if you escalate treatment in a young baby, remember to de-escalate. Okay, let's think of another case. We've now got a 10-year-old. His height and weight is on the 50th centile. However, it was previously the 75th. He is missing lots of school because of intermittent retrosternal chest pain, and he's vomiting 3 to 4 weeks at a 3 to 4 weeks at a time, 3 to 4 times a week. Again, I'd like to know what the audience would do. Would you trial a PPI? Would you trial a H2 blocker? Would you do a stool for H. pylori? Would you, oh, I've said refer Paeds, but I changed it to, would you refer for an endoscopy? Because you are Paeds. Apologies. Um, what do you think? Treatment, H. pylori, or refer for a scope? I think we'll have to assume the GP's not done anything. Okay, so we've got a bit of a even split here. Tiny proportion said go for a scope. No, not yet, please. But 50-50 roughly, well, 49-40, stool antigen and a PPI. Thank you, Jeremy. I would say PPI first. Okay, PPI first. H. pylori causing epigastric pain and vomiting is much less common. And we'll talk about that in a sec. So all the PPIs available to prescribe have similar efficacy. The one thing is what is available according to the age of the child and whether they're going to be compliant. The easiest in the younger child is, and the cheapest, is to use a omeprazole capsule, break them up, they're like little sprinkles inside, and just mix it with a spoon of yogurt or something. However, if they can only take liquid omeprazole is getting cheaper, but there is now also esomeprazole sachets, so do bear that in mind. Um, Faztab lansoprazole is cherry flavored and it dissolves in the cheek. So if you've got kids who are not so brilliant at swallowing, you can use that. MUPS is over advertised, I think. And although it's supposed to be dissolvable, it's actually really difficult and it never always leaves a little bit down. So, for example, if they're a tube fed, don't use MUPS. Please use the omeprazole liquid or esomeprazole sachet. I have said, however, exclude H. pylori. So what I would do is they should get better in 4 to 8 weeks of a PPI. If the 8 week review, then stop the PPI for 2 weeks and then check their stool antigen. Um, but at the same time, there is sort of what, as we mentioned in constipation, dietary changes, teenagers on junk diet. Reflux is associated with obesity, so weight management, and there's going to be a lot during the day about this. And here I've just highlighted the nice guidance for the management of reflux disease in children and young people. So when should you refer? If despite the interventions that we've been talking about, they're faltering growth, I think that's absolutely appropriate. If there's a GI bleed, absolutely. If you have checked compliance, you absolutely believe this family are taking the right dose at the right time, then they're refractory to a PPI, then that means refer on. And we might consider a barium swallow if they've got dysphagia. And I know it's really difficult because we have the same type of patients, but if it's purely parental anxiety of a vomiting child or a vomiting toddler, we won't be able to reassure them more than you. You're just as good. And in secondary DGHs, you actually have better psychology support than tertiary hospitals sometimes, which is rather ironic, but true. So please, where possible, avoid simply for parental anxiety. What you might be able to do is to say you've picked up the phone and spoken to somebody and they're happy with your plan. So what do we do? What is the gold standard for investigation? Well, it is a pH impedance. And the reason it's a pH impedance is it can measure acid and non-acid reflux. What you can see is there's a probe with the marker sitting in the lower esophagus. Here's your geojunction. And we look when we take swallows and how much time it takes to clear the acid. And obviously below at pH 4 is acid clearance, but we can measure non-acid clearance. And the impedance is placed just like an NG tube for 24 hours. It's particularly important in the little ones because they are obviously under 6 months only milk fed. So a pH study alone is going to be useless in these babies because the milk will have neutralized all the acid. What else might we do? Well, as I said, if there's concerns about dysphagia, we might need to do a barium swallow. Sometimes we do it just to prove there's normal anatomy. If we've got some concerns before we scope them, because if you need to do a dilation, that needs to be on a screening endoscopy list rather than a routine endoscopy list. So you can see here we've got a barium study and there is a bit of a hold up there, but it just goes through. This is what a normal esophagus looks like. Nice smooth mucosa, a bit like you're in a lip. You can see through, no abrasions. And then here on the right-hand side, erythema, ulceration, that's good going esophagitis, which obviously needs intervention. How do we treat them? Obviously, we increase the dose of the PPI. This is where we would consider feed changes if appropriate on the age of the child. And for the severe reflux, we may need to institute, particularly those with faltering growth, we may need to institute tube feeding. Now, initially that'll be NG, but if they then continue, we may need to think about gastrostomy. And I'm just reminding you the difference between a gastrostomy, which is where the entrance is in the stomach, a GJ tube, which the end of the tube is in the jejunum, excuse me, because for the refractory ones that we see in tertiary care, we have this sort of slow escalation with a bit of a heart sink. So we've tried all our feeds, they're not working, they're still faltering growth, doing really unwell, bit of a GI bleed. So we'll go from bolus feed to continuous. If continuous G doesn't work, we might then need to go to J feeding. And if we do J feeding, if despite all of that, or they have something like Barrett's, we may need to consider a fundoplication. Just bear in mind for the globally developmental child or the neurodisabled child, we do have poorer outcomes with fundoplication, and we may wish to leave them just on Jedge feeds. So, reflux is common. Reflux disease is not and is overdiagnosed. In the tiny babies, please use reassurance and simple measures. We've talked about the red flags for when you should refer. I always am open to discussion prior to a referral if you're not sure, particularly with our waiting times. For example, you could do a barium swallow locally and let us know. And I'm more than happy to take questions for this talk.
Thank you. Thank you, Dr. Naik. Again, one of the most common referrals and patients. We have patients. So I think there are very similar theme questions. So
Yep.
Joanna and Thomas have asked this question. We have a lot of these kids who are on PPIs for a long time.
Yep.
And the moment you sort of start reducing it, the parents will say, oh, the child's got reflux symptoms again. Is there any guidelines, like if they're on PPI for 1 year, whatever, and not getting better, referral to gastro? Is there something of that sort?
Yeah. So the issue is, are they well on their PPI? And so if they're getting breakthrough symptoms on a PPI, fine. The other thing is that if they've been on a PPI, I think more than 4 months, if you just stop it immediately, you will get an automatic rebound. So what I would suggest a tip is, you give them, if they've had a slightly protracted course, that's fine. But then for a month, do it alternate days. If they don't have breakthrough symptoms on those alternate days, then after a month you can stop it. The other issue is reflux is so common that there are some who are what we call PPI dependent. So they're absolutely fine, 6 months, you wean for a month, they're okay, you stop, 2 months later, they're back on. Restart the PPI. And I would say if they're PPI dependent and still having symptoms, that's the indication.
Thank you, Dr. Naik. A couple of questions similar themed on, are you a big fan of these milks, which are comfort milks, anti-reflux milk?
Um,
And we don't have any sort
I
of affiliation with
declare,
any milk companies.
so
Yeah.
in front of a dietitian, I declare no conflict of interest. Now there is a bit of, as I mentioned earlier, the physiology about some of these milks just stay down longer. I'm not a huge fan of them. And I'll be honest, I'm not even sure if they're a bit more expensive than standard formulas. But most of the time with the babies, if they're thriving, then don't bother. What most parents do is change the feed because they're worried about a couple of vomits. Vomiting itself is not an issue. And the ones that have the red flags, well, then you're going to probably want to instigate a proper change of feed together with your dietitian.
I think there are some other questions about domperidone and famotidine, which we can answer later on. So I think
Sure.
your next talk, the IBS one, is also going to be really exciting, and you got Meenal with you. So let's crack on.
Yeah, lovely. So what we're going to do now, guys, is we're going to move over to irritable bowel syndrome. I'm going to go through a few of the classifications. And then we're going to go through a couple of case studies, and Minal is going to give us the magic answers about them. So let me just share my screen. And I've got too many talks open. Here we are. Oops. So, as I mentioned, welcome to Manel, my senior pediatric dietitian and colleague at the Royal London. So we're going to define irritable bowel. We're going to use a few case discussions, and then we're also going to end it with the role of FODMAP or low FODMAP. We're back to the Rome 4 criteria. And in case you haven't worked it out, the Rome 4 criteria is all about neurogastroenterology. Nowadays, a lot of families, parents, and health professionals like going on about the gut-brain axis and the microbiome disturbing the gut-brain axis. Absolutely fine. And what you can see here are the functional disorders of the gut according to the Rome 4 criteria. And I'll ask you to fast forward down to...
Sorry, Dr. Naik, they want you to be in presentation mode. Your slides, some of them can't see them. So maybe just put it on play, the slideshow.
Thank you. I'd like you to fast forward down to numbers G and H. So these are the functional disorders of the toddler and of the older child. So here we have the Rome 4 criteria for irritable bowel syndrome. Now, obviously, I've just put the adults there for comparison. And what you can see for the child is that the group of specialists who developed the Rome 4 criteria have said that it has to be, just think about the last 2 months and do they have these? We've got abdominal pain, at least 4 days a month, with, can you see it says with one or more of the following? Is it related to defecation? Has there been a change in stool? The pain does not resolve once you've treated the constipation, and there's no other reason for it. Yeah, so that's quite important. And here you can see we've got a classification of irritable bowel, where C is irritable bowel with a bit of constipation. D is irritable bowel with a bit of diarrhea. M is where it's mixed. Hopefully you can see pictorially. And U is unclassified, where i.e. they've got irritable bowel with pain and no real major stool issues. So let's take a classic case, which I'm sure will be familiar to the audience. Minal, we've got a 10-year-old boy. There are no red flags, but he really does have chronic recurrent abdominal pain. He has had quite a few investigations already, which are all normal, and we've tried to reassure the family, but he's missing school. We've given him a bit of Buscopan, and the parent says, is there any role to change his diet or the role of probiotics? Over to you.
So there is a role in using probiotics. We know from like the FODMAP diet that bifidobacterium lactis can improve abdominal pain. There's evidence in adults to suggest that it can significantly help reduce it. In terms of practically getting that into the diet of a child, just yogurts that have probiotics, and that particular strain is found in the Activia brand. So just incorporating that into the diet every day can sometimes help with the abdominal pain that they're experiencing. Once we've done a detailed diet history, also if there's any other high FODMAP foods or that they're having a high intake of a particular type of food, we can look at that. So we would always consider lactose as well if that didn't work. Also, some patients might have high amount of fructans in their diet, so we might recommend just taking out single fructans rather than an entire group of foods, just because it would be quite restrictive for children. So like if you wanted to start with, the easiest ones would be things like garlic or onions if they were reporting problems or had a lot of that in their diet when you did a diet history.
Brilliant, Manel. That's really really clear. So here you can see what we said. Take your detailed dietary history. That's really key. Obviously, a food diary is going to be really helpful because if you don't know what they eat, you're not going to be able to start withdrawing. Okay. And I hope you all learned about Bifidobacterium lactis and to consider fructans. I'm sure there's going to be quite a few questions on that. Okay, let's take another patient. So this time it's an 11-year-old girl. There's a family history of Crohn's in maternal aunt and paternal uncle, but they've had, because of that, a normal upper and lower endoscopy already. And so we think, oh, you know what, this is just functional. We're going to just give a bit of loperamide. Parents, again, want to know, is there something they can do diet-wise? And just to show, to re-emphasize, the stool chart for Bristol stool chart and the range of diarrhea to constipation. No.
So for this patient, they'd need a detailed diet history once again, and look at whether there's any correlation between specific foods and the diarrhea that the patient is having. Whilst doing the diet history, we would assess for total fibre intake, and if the patient has a high amount, then we would consider a reduction. However, highly unlikely in children to have a very high fibre intake. In this age group, heading into the teenage years, assessment of caffeine intake is really important. So along with having fancy coffees from Starbucks, they could be having energy drinks as well. So caffeine intake may be excessive if they're having a high intake of those. So advising on removal of those from the diet. Once again, if they could have we could take out lactose in the diet. So if there's a correlation when the diet history is taken that there's either a high amount of dairy or that they're finding not long after having dairy, that you could cut that out if that's causing their symptoms. If those didn't work, then you could consider reducing the fructose and the polyols in the diet. Again, depends on their intake. If they're having a lot of intake of fruits or vegetables, then looking at the fructose would be useful. So cutting out the high fructose content fruits to begin with, rather than everything altogether. And polyols, so they could be having high amounts of sugar-free gum. They could be having lots of fizzy drinks that contain sweeteners. So just assessing the diet for those and removing them one by one as opposed together if parents are very keen on doing dietary changes.
That's brilliant, Manel. Thank you so much. And I think it is important, you know, particularly the caffeine in the teenagers that you mentioned. And there are one or two families who do go a bit excessive with fruits and vegetables, and that actually has the adverse event. But hopefully the audience, you'll realise that this is actually a little bit more complicated than you would think, and therefore, what's the tip? Get your dietitian involved. Okay, let's get another case. This time I've got a 5-year-old, Manal, who's got chronic constipation. I've optimized my Movicol and my stimulants. They are taking them. They are a fussy eater, but they're tracking on the 25th centile. And again, what can I do with the diet?
So once again, diet history is going to be really important here, with a focus in particular on fluid intake and fibre intake. So just ensuring that they're adequate fluid intake, and we wouldn't include any fluid that is given with the laxatives, ensuring that they're having the extra on top of that. In this age group, you'd want to try and ensure that they're having 15 grams of fibre, just to help with their bowels. So just to give you an idea, an apple would be about 5 grams if they're having the skin. A banana could be about 3 grams, and then a slice of bread or a Weetabix biscuit will be 2 grams. So that with additional fruits and veg would be easy to achieve in someone of that age group if they're a good eater. Obviously, if they're a picky eater or a restrictive eater, then that may not be so easy. There's no real evidence to suggest that prescribable fibre supplements have an impact on these types of patients. There's some evidence in adults, but nothing really in paediatrics. We would recommend trying to include kiwis in the diet because they have been shown to help with constipation symptoms. In particular, the amount of stools improve, and the straining has been shown to improve with the kiwis as well. And again, trying some probiotics. The NICE guidelines do say that probiotics can have an effect on constipation. So that could be tried. The other important thing is a lot of patients these days are sedentary. They sit watching the TV and playing video games. So discussing activity levels and trying to increase them. The NHS suggests 60 minutes of activity for someone of this age group if they're normally fit and well. If they've got a neurodisability, you'd recommend 20 minutes every day. But in discussing with the parents that having some form of physical activity daily will help with their bowel management as well.
Brilliant, Minal, and I'm sure the audience didn't know about the kiwis for sure. Now, one of the things that we get asked about quite a lot is all about the FODMAP diet. Now, Minal, we're not in the same room, which is unusual for this talk, so you're going to have to tell me when to change the slides as well. But just to remind everyone, I'll leave it for you to talk through what is FODMAP and when should we implement changes with regards to it and how it works.
So this is obviously what FODMAP stands for. I'm sure you've all seen this before. So it's looking at fermentable foods, your oligosaccharides, so pulses, wheat, garlic, and onion, the disaccharides that cause a lot of bowel disturbances, so lactose, sucrose, maltose, monosaccharides, generally fruit and honey, and then your polyols, your sweeteners, and your fruits and vegetables. Next slide. So how does it work? So in terms of the FODMAP diet itself, so it's a 4 to 8 week period of food elimination where all of those groups will be cut out together. And then foods are introduced individually within their group. So you'd introduce a group for like 3 days and then have rest days. This is hopefully to identify trigger foods and try and eliminate them permanently to help manage the symptoms of IBS. However, it does take a very long time to complete. So you're looking at about 3 to 4 months for the whole process to be completed. And obviously input from a dietitian is crucial in that point. There is an estrogen paper on FODMAPs in children. And essentially, there isn't really any evidence for the use of FODMAPs in anything except IBS in children. And even then, there's only some evidence that this works. So in children, we generally would not do the full FODMAP. We would recommend a low FODMAP, but just removing single components to begin with, unless they were really keen to do the full lot. But again, we wouldn't really consider it unless they were teenagers. The estrogen guidelines also state that they need to, obviously all organic causes need to have been ruled out, and they must not have any selective eating or restrictive eating or any kind of eating disorder behaviours before you would recommend a diet like this. As I said, it is very restrictive, and if the patient that you're trying the diet on is vegetarian or vegan, it is very difficult to meet your protein requirements through this diet, just because lentils and legumes, they're restricted to X number of tablespoons per day, and dairy is also restricted to begin with. So that would need to be considered in terms of if it's suitable for the patient. In terms of actually putting it in place, it is very expensive. So if you chose to do a FODMAP diet, the dairy itself, the non-dairy equivalents would be double the price of cow's milk equivalents. The bread is also 3 times more expensive than normal bread. Pasta and rice obviously would be normal price, but it does cost quite a bit extra for the time that they're on it. In terms of planning, it needs to be planned and thought out. So if you're out and about, you can't just go into a shop and have something for lunch necessarily or for breakfast. You need to have planned things and taken food with you. For example, if we went down to the hospital canteen today, chances are there would be very little that you could eat. You could probably eat a potato, a jacket potato, and that would be it, but probably not with a suitable filling. So those things need to be considered. It would reduce the gut flora, just because the variety of the fruits and vegetables are restricted. Okay, yeah, so this slide just shows what is allowed and what isn't allowed. So the dairy initially is alternatives, and then you add in lactose free if tolerated. You are allowed meat, eggs, and some cheeses, and all the wheat that you eat must be gluten free. So that will be a challenge in terms of taste, consistency, and price for children in particular. The breads don't have the same consistency, so that could be difficult from an acceptability perspective. Limited fruits and vegetables. For most of the children, this will be fine. They're not generally big fruit and vegetable eaters, but if they have specific ones that they do like, then this could be problematic for them. So should we actually use the FODMAP in children or not? As I've said, we don't tend to try it in anyone that's kind of below teenage years, just because it will have an impact on their growth. It goes on for 4 months, which is a long time to restrict calories, vitamins, minerals, those kind of things. So I wouldn't really recommend it in anyone that has got growth problems to begin with. That for those patients who are restrictive eaters, and parents would really need to be committed for the length of time that it goes on, the 4 months. They need to be able to commit to the whole process. There's no point in doing it for a month and then stopping. You wouldn't see any of the benefit, and you wouldn't be able to identify any foods that will be problematic for these patients. It would require significant dietetic input. You're talking about initially 1 to 2 hours to go through everything, and then probably weekly phone calls on top of that, and then a little bit more time intensive when foods are being reintroduced, just in terms of explaining to parents how we would do that and how to get the patient to accept it, given that they've not had it for some time. So really only use it in those patients where you really think it's going to make a difference, and ensure that you've got dietetic input available, just because apart from the physical restrictions, it can psychologically have an impact on children, restricting the large numbers of foods from their diet.
Thank you, Minil. That was an amazing chat about the FODMAP diet. I learn every time. And I think we've probably got a minute or so, Akshay, just for quick
Yeah, we
questions.
can have a couple of common themed questions. So, Meenal, first question was specifically, do they need a gastrodietitian or any dietitian trained in IBS? My guess is the latter, isn't it? You're not going to get a gastrodietitian.
Yeah, so ideally you want a dietitian that's done the FODMAP course to be able to do this. However, if you're referring into the NHS, you may struggle with this. Also, a lot of community dietitians may not accept referrals for IBS, just in terms of knowing what staffing pressures are like. Most places will only take referrals for faltering growth and allergy, so it would depend on your local criteria. But yeah, anyone that's trained in the FODMAP should be able to assist.
And then some common theme questions. So Dr. Darling, so Susie, she asks us about any particular brands for probiotics and how long would you give probiotics? Dr. Goyal asks this question.
So like I said, for the abdominal pain, so we'd use the yogurts that have the Activia. If you're talking about constipation, I tend to use BioGaia just because it's easily available on Amazon. It's in liquid form, and they've got some studies to say that the constipation does improve with those. But generally, it can be anything that a parent's able to afford, because some probiotics are quite expensive, so you just want to advise them on a probiotic that's got multiple strains in it, if they're limited on what they can buy.
Yeah, and always make sure that at least it's got the bifidobacteria. Otherwise, there's no point.
Perfect. And then one question which I've always found interesting was, resources for parents. I use that ibsdiets.org, and I found a FODMAP list and other things. Is there something, and there's a question on it, and is there something you would recommend, any sort of online resources for clinicians to give to families, just information wise?
So there are some nice tables that just highlight what are the low high FODMAP foods and the high FODMAP foods. That's probably the easiest resource to give to parents, rather than something that's got a lengthy written part to it, because it's very visual, and then the children can look at it as well, and they can be like, oh, I can have this, but I can't have that. Obviously, the recommended resources that we recommend are from Monash University. But yeah, just if you do Google it, like, there are diet sheets that you will get with the red and the green. So that's probably the easiest thing to give to parents.
And my guess is this is very challenging. We're seeing a lot of IBS symptoms now, in general pediatrics, where we know they don't have anything else. They go to GPs multiple times, they come to us. And resources wise, it's really one of those things where trusts need to start educating increasing the budget for your dietitians to go on FODMAP diets, because courses, because that is really important, and that is something which will make a difference. But I think maybe that's where we leave with this thought, to help improve the budgets and everything. I definitely think that makes a difference.
Yeah, I think if you've got a high percentage of children on your caseload that are presenting for this reason, then having a look at reallocation of resources if possible, because then it would reduce your workload. You could effectively discharge them to a dietitian.
Lovely. Dr. Naik, Meenal, thank you. Amazing as always. And see you later on in the day, Dr. Naik. And let's go to the next talk.
No worries. Thanks. I'll answer the question.
Thank you, Dr. Naik. Thank you. So, well, I sincerely hope all of you have enjoyed. We've got 250 plus delegates. More of you will be joining in the afternoon. So the next couple of talks are really very interesting as general pediatricians. It's my pleasure to introduce Dr. Sarah Boutros. She's our general pediatric lead, deputy lead for safeguarding, and she's going to talk on CSA and the role of general pediatricians. So over to you, Sarah.
Thank you, Akshay. So yes, I'm Sarah. I'm a pediatric consultant at the Royal London. I also am the clinical lead for the Sunrise Hub, where we see children who've been sexually abused all across Northeast London. So quite a large population of children. So I'm going to be talking to you about sexual abuse and what our role is. So the main first big message that I want to get across is that sexual abuse is common. It's incredibly common, in fact, and estimates say that between roughly 1 out of 10 children or 1 out of 20 children are impacted by sexual abuse by the age of 16. And that's based on adult surveys where adults are being asked about what their experiences of childhood are. So it's incredibly, incredibly common. We know that the vast majority of those children will never tell anyone, and only a small proportion will tell an adult or another child or a professional. We think that sexual abuse is as common as physical abuse, but all of us are dealing with physical abuse on the wards on a relatively frequent basis, but worry a lot more when sexual abuse is considered. Children who are neglected are 5 times as likely to be sexually abused, so there is a strong link with neglect. Disabled children and children in care are also at significantly increased risk of sexual abuse. And the current estimates are still that about 50% of cases happen in family homes, so intrafamilial sexual abuse. But an increasing number of children we see are experiencing sexual abuse perpetrated by other children, so peer-on-peer abuse, and that's an increasing concern. The other thing just to highlight is that children, if we look at sexual abuse in general, in the general population, children are disproportionately affected by it. So they are 40% of recognized victims of sexual abuse, but represent only 20% of the population. So you can really see how much this affects children and how common it is. And we are seeing children who are sexually abused on a day-to-day basis in healthcare. We just don't know it. The average time it takes a child to tell a professional or an adult that they have experienced sexual abuse is about 7 years. So that's the average. Obviously, some will never tell anyone. Some will tell someone right away, but the vast majority take quite a long time to feel able to tell anyone. So just take that into consideration. And really, the reason why the official numbers are so much lower than the estimated numbers is that really sexual abuse thrives in secrecy and silence, and it's a perpetrators will often use shame and coercion and grooming to stop children from speaking. Children will not necessarily have the words to tell us what's going on. There's, particularly with intrafamilial sexual abuse, the shame and fear and the emotional abuse that happens with it can really stop a child from being able to tell anyone about what's going on, especially if it started when they're very young. They will really struggle to find the words and to be heard. And we know that particularly when there's intrafamilial abuse, that families will all, it won't just be the perpetrator who's sort of perpetrating the secret. There may be the non-abusing parent may get a sense that something's going on, but choosing to ignore it. Other adults in the picture. So it really thrives in secrecy. And the more people feel shamed by sexual abuse, the more it's going to be silenced. And we need to be able to speak about it and be clear and just reduce that shame and stigma. So, how does sexual abuse present to us in pediatrics? I think we can talk about a few scenarios and common cases that I come across all the time. So the most obvious will be a child or a young person that comes to ED or comes to a clinic and says that they've just experienced sexual abuse or that they have experienced sexual abuse in the past. So that might be a sexual health clinic or it might be an ED. They present after an acute assault. So that's in some ways the easiest scenario that they've told us what's happened. Our role is really to just listen to what they're telling us, document it, and then we'll talk about what we need to do next. Then there are the younger children who are non-verbal or just about verbal, where a parent presents with them worried about some signs and symptoms or worried about things that they have said. And here it can be really, really tricky because children, particularly younger children, their language is not clear. And sometimes we can put our adult interpretation into things they've said that are not necessarily what they meant. So it's really important to ask what exactly the young child has said or what they have shown or what they've displayed. We've had a scenario a couple of years ago where a child came home from nursery and told the mum that she had a scratch around her genital area, and mum asked her what happened, and I don't know exactly the word she said, but she said something around the wand and a man and being poked. And I think the parent understandably went into was really worried and made a lot of assumptions about what might have happened. She came to ED, and between the ED triage, the ED registrar seeing the pediatric registrar seeing, the history had changed a little bit, like Chinese whispers, and it became a very different story in the morning. And the child during the night, because these are always presentations late in the evening or at night, the story had become sort of quite worrying of sexual abuse. And I was called in the morning for advice on what to do. And I said, just go back to what was said first. And when they went back to what the child actually said and asked the child what happened, it was a very different story. So you can see how adult thinking just added little bits to the story and it completely transformed. And in fact, they were all playing, no one was undressed, and one just scraped her body and it came near her genital area. So very, very different response. So just go back to what was said, because we can really add our own interpretations to these things. But equally the same, children will often give us lesser disclosures as a sort of testing the waters. So if a child tells you something that sounds like it could be sexual abuse, we really need to document what they're telling us, and always be open to the fact that it may be a first sort of starting to try and disclose something. So just bear that in mind. The other thing, thinking about physical signs that might present to us. So you might have the child who's presenting with genital symptoms, like bleeding, pain, discharge, and we will talk about the differential of some of these. None of them in isolation are diagnostic of sexual abuse. There's a large differentials, lots of medical reasons and abuse reasons. So we will go through some of the differentials there. Obviously, a child who presents with a sexually transmitted infection or pregnancy, particularly under 13, that's sexual abuse pretty much by definition. And the other physical presentations we may have are things like children who present to the hospital with lots of unexplained symptoms, so signs of distress, children who have new onset of incontinence, urinary and fecal, and I had a really depressing case of a child who developed urinary and fecal incontinence. She was 12. And she was being seen by the GP and pediatrician, and it was several months before she was able to tell anyone about the horrific sexual abuse she was experiencing by her father. So it can be really, really extreme. So always think of it in the differential. In terms of emotional signs, we know all the children and young people present with emotional dysregulation, with mental health concerns, alcohol abuse, etc. And just to bear in mind that most children who've been sexually abused, or a lot of children who've been sexually abused, will describe, or their adults will describe, a sudden change in behaviors. And often that's most apparent in schools. And if you're having a professionals meeting or strategy meeting and the school saying the child has gone from being a really good student to suddenly really struggling or being a troublemaker, then we really need to think of what has changed, what has happened. So these are just some of the examples of ways children present to us. One of the places that would be really useful if you ever have cases and want to get some more advice on how to handle it, the Centre of Expertise for Child Sexual Abuse has a lot of resources, one of which is the Signs of and Indicators template, and can be really, really helpful when we've got a slightly grey case to just look through that template and think about what signs the child's displaying. And how indicative it is of sexual abuse. So, if a child or young person comes to us in any setting and tells us that they've experienced sexual abuse, this is all sort of fairly obvious, but it's just important to just say that it's really, really important to just stay calm and really listen and validate their experience. Children will, so I just said that a lot of children will give a lesser disclosure and wait and see what professionals' response looks like and what their carers' response looks like before deciding whether to say more or not. So if we respond in a slightly panicked way or ask them a lot of questions or just respond in a way that makes them close up, then that opportunity can be really lost. So it's really important to just listen. We're not there to do the police's job. So we're not there to ask exactly what happened in a sort of significant level of detail. We're not there to ask, when we need to just ask medically relevant questions, have some idea about safety. So timing of when the last assault was, are they still in contact with the perpetrator? Do they feel safe right now? Who have they told, etc. When we're asking questions, really, really important to ask open questions and non-leading questions. This is really important, particularly for police processes, but also for the child to be able to tell us what's happened and for us not to lead them into a certain path. And be really mindful that once a child tells us about sexual abuse, they completely lose control of the situation. So they may have held onto the secret for years and years, and they've sort of managed to control what they're living through. And suddenly, once they tell, their perpetrator, parent or step parent or uncle or peer gets arrested, their family unit gets disrupted, things get spoken about in school, they may lose a sibling if all the siblings are perpetrators. So all sorts of impacts that are really, really difficult. And it really does affect the whole family, the whole community. So be really mindful. Don't tell them that everything's going to be straightforward and okay. Some children do regret telling us what's happened. And it's really, really upsetting when we have that the response has been so, they suddenly lose control. So what happens is we call social care, we might call the police. They have to speak to lots of different people. They get told they need all these things done. And it's really, it can be really, really traumatic, that in itself. So be mindful of it. Be clear and explain to children and young people what will happen next so that they can get some sense of control and some sense of understanding about what to expect. So, what do we need to think about when we think a child's been sexually abused? So the most important thing is the immediate health needs. And I'm always stressing this because people, when a young person presents with a history of acute assault, suddenly most people worry about what safeguarding processes need to happen and worry about contacting a local sexual assault referral centre. But really, we need to first focus on the immediate healthcare needs. Is there any injury? Do we need to look at any cuts, bruises, manage those? Particularly, well, for girls, emergency contraception is incredibly important, and missing that can lead to a child becoming pregnant, having an abortion, or having a child at 14, etc. And we've had some cases, and it's really, really traumatic. So please, please think of emergency contraception. Hepatitis B vaccination, particularly for the children, the older children who've not had the vaccination program that's now in childhood vaccines. HIV post-exposure prophylaxis is actually rarely needed. If you need, go on the CHIVA guidelines, pediatric sexually transmitted infections. It goes through the risk of HIV, and really the only scenarios where HIV is a significant risk is a stranger assault, gang rape, anal assault. So these are the three most risky scenarios. For most other types of rape and assault, the risk is actually fairly low because the background prevalence of HIV is now incredibly low. So just bear it in mind. There are, for some older young people, they may choose to have HIV post-exposure prophylaxis because they just can't deal with the stress of the what if, even sort of 0.5%. So just have those conversations and then contact your local sexual assault centre. In terms of emotional support, it's a lot of what we already said in terms of providing reassurance. If they're acutely suicidal, self-harming, obviously involve CAMHS. Consider, depending on where you work, and if you have ISVAs, then do refer to ISVAs and specialist services. So for North East London, it would be our service, but I'll explain that in a minute. And then think of all the safeguarding processes. So ensure that they're in a place of safety, that they're not in contact with the perpetrator, refer to children's social care. And then the question that always comes to me is, do we call the police or not? So under 13, so up to the day they turn 13, children cannot consent to sexual activity, and any sexual activity under that age is considered sexual assault, and that is mandatory reporting to the police. So we need to do that and be really clear, particularly for the 12-year-old, although it's an unusual scenario, but a 12-year-old who thinks that they've had consensual sexual activity with another 12 or 13-year-old, it can get a bit tricky, but that is considered a crime. Over 13, it gets a lot more muddly. So there isn't mandatory reporting as yet, and I know a lot of it is likely to come about, but it hasn't come in yet. So at the moment, it is up to us to work with young people, children's social care, our safeguarding team, to try and think whether police need to be spoken to or not. If there is ongoing acute risk, so if it's a parent and the child's meant to be returning to that home, then we're almost certainly going to ring the police because that child can't return to the family home. If it's a person in a position of trust, so teacher, counsellor, carer, doctor, nurse, etc., obviously we need to also inform the police and LADO. If it's a stranger assault, it's considered higher risk and you would ring the police. For a lot of the peer-on-peer abuse, or a young person who's met someone on Snapchat, maybe older, and they don't want to tell anyone, they don't want their parents to know, we have to work with the young person. We have to try and find a way to keep them safe, not re-traumatize them, and slowly build trust and decide whether police need to be rung or not. Ultimately, if a child and young person doesn't want to speak to the police, ringing the police anyway and having uniformed officers turning up to your ED or your ward to take a statement from a young person who doesn't want to speak to them is not going to lead to anything. The police won't be able to do anything without a statement from the young person. Just ringing them to tell them because we're worried they might assault someone else is not going to lead to anything and will not prevent further sort of that perpetrator from keeping on sexually abusing others. But as I said, there are scenarios where the risk is higher, like someone in a position of trust and a stranger assault, where we would really ring the police. But it's always a conversation, and they're not easy decisions, and we have to. And for some of those decisions, we have time. So it's not often an emergency that you need to ring that moment in time. We can take the time, follow up the child and work through it. Work with an ISVA if you have one, and they're really, really helpful in sort of supporting children with police processes. Now, you will notice I haven't included anything around forensics in this slide because often we, as pediatricians, you might really, really worry about the forensic samples that might need to be taken, particularly for an acute assault. But actually, forensics are not your top priority. And these three things are the first things that you need to consider. Forensics are important for some children, young people, but the reality is the vast majority of sexual assaults will not fall within the forensic window. So I'm just giving you this slide with an estimate of the forensic windows, just for guidelines, so that you understand why a lot of things fall out of the forensic window. So for prepubertal children, the forensic window for almost all assaults is less than 3, so it's up to 3 days. Post-pubertal children, it can be up to 7 days, sometimes a tiny bit longer. So it will depend a little bit on a variety of things, like have they changed clothes, showered, etc., and what kind of assault it was. This is just a guide. It's not set in stone, but it just gives you an idea of roughly why a lot of things fall outside of the forensic window, and also why that's not really the priority. The priority is, so if you have a child who's bleeding, don't worry about whether you're going to sort of impact forensic assessments. Really, controlling their bleeding is the priority. So what's the purpose of, why are there services like ours? Why do we provide CSA health assessment? Obviously, the immediate aftercare in terms of STI testing, etc. Really, a lot of what we do is providing children with reassurance, and there's the forensic evidence that gets collected. There is also really good evidence that early intervention after a trauma or disclosure can significantly decrease long-term post-traumatic disorders. So it's really important that once a child has told us, even if the event was 7 years ago, that we then put the support things in place. So my service does non-acute assessments, so non-forensic assessments. And people often ask why we do medical examinations, why we see children, why we offer genital examinations. And it's a holistic assessment. It's there to reassure children, to explain to them what their bodies look like, to tell them they're healthy. And it's not there to prove or disprove that abuse has happened. I can't look at a child's genitalia and know what has happened, but I can pick up signs of that can be consistent with the history they've given us. It's only done with consent, so there's no point referring a child who doesn't want to see a specialist service. And it shouldn't really be the one thing that determines outcomes of safeguarding procedures. And the other thing that's really, really important is that when I do genital examinations, it's not an internal examination. It's not invasive. It's not traumatic. So all of these things that sometimes are said in strategy meetings, we really need to counter. That is not the case. It's a visual inspection for the most part. It's there for reassurance, and it's guided by the child and young person. And the vast majority of examinations I do are normal. That's not because sexual abuse is not happening. It's because a lot of sexual assault might not cause injury. Injuries might heal completely and leave no marks whatsoever. And we can, so bodies heal very quickly. So there isn't a single sign that tells me that something has happened. So a quick note on sexually transmitted infections. They're not common at all. Thinking about the age of the child is really important because it will be important in terms of considerations of different modes of transmission, whether it could have been a vertical transmission or something else, or whether it's a consenting sexual activity, or whether we need to consider abuse. So just think about these things. In terms of the types of infection, gonorrhea and chlamydia are probably the most likely ones that we see and most closely linked to sexual abuse. The ones that cause a lot of panic and a lot of issues are genital warts and herpes in particular. There there is really quite conflicting evidence in terms of their link with sexual abuse. And some of the evidence say that children with those infections, 50% of them have been sexually abused. I think that's not very good, not necessarily very good studies, but this is the evidence we have. So they cause a lot of panic. Essentially, the guideline is if you have any of those infections, refer to children's social care. First confirm the infection. Make sure that we've got the correct things. So get dermatology, get ID, whoever you need to confirm the infection and swabs. And then they may need a child and family assessment through children's social care. But sexual abuse should be considered, but it's not the only way that these infections can happen. And with hepatitis, there's not really much evidence about whether it's linked to sexual abuse or not. Now, I've got a few slides of some pictures. I think I have still 5 minutes. And we'll think about some of the genital symptoms that can present and their differential. So the commonest thing I see quite frequently is blood in the underpants. So thinking about the little child and the differential for this, obviously we know in neonates you rate crystals and withdrawal bleeding, etc. And with toddlers, we often see, we might see genital bleeding either as an endocrine condition, but also things like skin disorders, so severe eczema where there's a lot of itching. And the other common thing is lichen sclerosis, which I have seen a number of, and thinking in teen and as well as precocious puberty. And teenage children, thinking about their periods, any other gynecological disorders, as well as sexual abuse. So there's a wide range of differential. To think about, and then penile discharge and pain, again, often neurologists will be really helpful, but think of infections and sexually transmitted infections. So I've got two.
Sarah, big thank you. It's a very sort of a topic which lots of us are not confident, and there are some of those sort of things as a guide, what to do when particular things happen. Also common things like vulvovaginitis or labral adhesions. Again, we see them quite a lot in general pediatrics. So a big thank you. And I think there's just one question about under 16, do they have any particular clinics with regards to sexual health? Because, and if that's a sort of concern, where do they go?
Sure. So most sexual health clinics nationally would see children from the age of 13. That's definitely within London and wider region. That's my understanding. The reason they don't see under 13s is because it's sexual activity is illegal. But the vast majority with consent will be seen after the age of 13. Different if the reason they need sexual health screen is because of a sexual assault, then the best place to do that would be in a specialist child sexual abuse service, so a service like ours. There are loads nationally. They don't exist in every single area, but they exist in most areas where we provide acute and non-acute health assessments and would do the STI testing, etc. Most STI testing is not an emergency, but it's important to think opportunistically when a child presents of whether left and center, and that sometimes happens. If a child's saying to a professional, I've experienced sexual abuse a year ago, a lot of professionals panic and send them to the GP, to A&E, to a sexual health clinic, and then they're like, oh, there's a specialist service as well, and they will have seen so many people. So it's important to know your local pathways and try and do the urgent things first, but otherwise there are specialist services that can deal with all of it.
Thank you, Sarah. Yeah, thank you. I think there might be just a couple of other questions if you don't mind answering, and then we'll move to the next talk. Thank you. Well, the next talk is by Dr. Giles Armstrong. Giles is our clinical director for specialist pediatrics, general pediatrician. He does A&E, also safeguarding leads. So lots of hats, Giles. And he's going to talk on factitious illness. Over to you, Giles. And Giles will be okay with time. I think so even if you run 5 minutes into the break, we'll be fine. You've got a break after you talk.
Yeah, we'll finish for the break. Don't worry. Anyone who's feeling the need for a cup of tea or coffee, I can lengthen or extend this talk as need be, so we will be fine. So, this is when to suspect and how to manage factitious illness. And what we're going to cover is the evolution of the terminology because it has changed over the years, our current understanding, and then when to suspect it and what to do. So, firstly, the terminology. So, this has evolved and changed since it was first identified. In the UK, and I would stress that the terminology is country specific, there is no international single definition of this phenomena. But in the UK, the term Munchausen syndrome by proxy was first coined in the sort of last quarter of the 20th century. And for those of us who started practicing medicine then, that's what we were taught it was called when we were training. And that's what we were advised to look out for. This then was altered in the first years of the 21st century, the last few years of the 20th century, into the term we're probably more familiar now, which is fabricated or induced illness. And this was the term that the college used in its first couple of guidelines around how to manage this phenomenon. However, we then began to realize that the fabricated or induced illness, stroke Munchausen syndrome by proxy, both of which described a phenomena where the parent was actively harming the child, didn't really encompass all the patients that were being seen within this framework. So we were seeing a lot of patients who might be better described as having medically unexplained syndromes. Now, this is a terminology that's predominantly used in adult medicine, but certainly around the same time the college was looking at FII, we were looking, the Royal College of Psychiatry was focusing on the terminology of medically unexplained symptoms. And the concept here is that the patient is not responsible for the fact that their symptoms are not explainable medically. And there is something more complex going on in the psychosocial holistic model around illness. And this then, these two concepts merged together until we came up with the current terminology, which is the Royal Colleges of Pediatrics preferred terminology, which is perplexing presentations. And this encompasses everything that came before it. So it encompasses the hard end, what used to be called FII or Munchausen syndrome by proxy, where a parent is actively, maliciously fabricating illness in their child. And I'll give you some examples of those later when we're talking about what sort of things are covered within that framework. But it also includes some of the more common things we see where perhaps parents are over anxious and that's driving inaccurate reporting of symptomatology at home because they're quite keen to get something going on and don't quite understand that sometimes over egging the pudding can in itself be harmful. If we look at some of the other terminology that's used in the literature, interestingly, in the USA, one of the most common forms is medical child abuse. And the interesting thing about this term is that, of course, when we're talking about these patients, when they come to physical harm, the majority of time, the physical harm is caused by medical professionals. It's the unnecessary medical procedures. It's the unnecessary medical investigations, which may be painful phlebotomy that's unnecessary. There may be ionizing radiation that's unnecessary. There may be a general anesthetic for a procedure that's unnecessary. But the actual abuse is carried out at the hands of doctors, not intentionally. The intention is the parents, but the actual practice is by the medical professionals. And so this concept of medical child abuse is an interesting one from a linguistic perspective around where does the locus of control sit within these families and within these patients. And we are partly responsible for the pain that these children suffer. The other thing that's used more internationally is factitious disorder imposed on another. Now, this is a DSM-5 diagnosis. However, it's currently only a DSM-5 diagnosis in adults. So you have to be over 18 to sustain this diagnosis. And this is essentially adult patients being gaslit by normally romantic partners, but sometimes family members into thinking that they are iller than they actually are by sometimes deliberately faking results, by faking symptoms, by suggesting that people can't do things they're actually capable of doing. Not surprisingly, that concept has been extended into the pediatric arena, particularly again within the USA. Although at the minute it's mainly used around late adolescence as opposed to early childhood. Whether this will be something that will become more, obviously the DSM undergoes various reviews. We're on version 5. Who knows? But it is interesting that we haven't settled on a single international version of how to describe this complex set of phenomena. So our current understanding, and this has evolved with the terminology. So the Munchausen syndrome by proxy was first described in 1979. That was the first published paper on this concept. And the focus at the time was very much on induced illness. So this is parents who were actively poisoning their children, suffocating their children, the real hard end stuff that was associated with quite significant harm. It was strongly linked to parental mental health issues, and clinicians were advised to be on the watch for it. The RCPCH, which came into being as a college in 1996, but obviously succeeded the British Paediatric Association, issued its first guidance on this topic in 2002, and at the time was still referring to Munchausen syndrome by proxy, but within the next review had moved to the terminology of fabricated or induced illness. Initially, in those first two guidelines, the focus was very much on this same cohort, this concept of the children who were being actively, intentionally harmed by their parents. But by 2013, actually, there was an awareness that there was, as we've talked about in terms of the terminology, that this didn't capture all the patients that pediatricians were looking after. And so they began to talk about the spectrum. And for those who can remember the 2013 version, it actually divided it into types, and it talked about type 1 through 5. And it talked about the fact that some types were more related to parental anxiety, some types were more related to parental fixed health beliefs, and only a small percentage were related to the true, what used to be called Munchausen syndrome by proxy. That was then succeeded by the latest guidance in 2021, and that's still the most current guidance issued by the college. As you can see, the gaps between guidance are roughly sort of 6 to 7 years, so we're probably a little way away from a new one just yet. This did away with the concept of the various subtypes, but instead did explicitly differentiate between the fabricated or induced illness, where the parents are actively fabricating, making things up, versus the perplexing presentation. And this is now the latest model of addressing these patients, is to try and work out which one you're dealing with. And then there are very different strategies for managing both scenarios. And this is important because the previous cohort, the 2013 guidance, suggested a one-size-fits-all model of managing these patients, which often was a little bit clunky because the process for managing FII, as we'll see in a second, is quite full on, necessarily so, but didn't always work well with some of the more, what we would now term, perplexing presentation patients. So what do we think drives it? Well, we don't know for definite. There are a number of papers published on this, but it's quite difficult to find, as you might imagine, parents who are willing to talk about what was driving their behavior. But we think there are essentially two spectrums of driving behavior. One is around fixed or erroneous health beliefs about the child's condition. So they think that the child is sicker than you think normally. That can be driven by anxiety. It can be driven by the parent's own understanding of medical topics, or indeed their own health experience. And we do see cases where we have intergenerational perplexing presentations where, you know, grandma's got an unexplained reason why she's in a wheelchair, and mum's got an unexplained reason why she can't work, and the child's got these funny symptoms that we can't explain. Sometimes it can be more to do with very fixed health beliefs. So if you think about some of the anti-vaccination phenomena, where you have parents who will not engage in discussion with you because they have a fixed belief that vaccines are inherently bad, but you transpose that to a concept around why their child has tummy pain, or why their child has difficulty in breathing, or any of the things that we might commonly see in our general pediatric service. And then running parallel to that is that there can be gain from the parents for pursuing medicalization. Now, that can include financial gain, and certainly within the UK, the disability living allowance, sadly, is rife with potential abuse in this context. But actually, in the vast majority of cases we encounter, it's got nothing to do with financial gain and has all to do with the parents' own self belief and their sense of self as being an inherently important person by advocating for their child. So you might find that a parent, for example, gives up work, which may well have been unfulfilling, to become the primary carer for their child, who may or may not need a primary carer in that sense. So that when we talk about gain, it's wrong to think of that as being a purely financial gain. And that's quite important when we have conversations with partner agencies, because one of the most important thing about this cohort is you are not going to be able to fix it by yourself within health. This has to be managed as a multi-professional condition. And part of that is explaining some of these concepts to agencies that might be less familiar with the concept of non-financial gain. And really importantly, both of these spectrums can exist within the same case. So you may have some fixed health beliefs around what is, what is tolerable pain, for example. People come from different backgrounds, but I certainly would have not missed a day's school because of ill health unless I was moribund and in bed. My mother would have had me up and out the door and straight to school. I have friends who I went to the same school with who only had to cough twice and they'd be off school for the day. So we know there is a spectrum of parental health understanding. And then you might get some sense of self-worth for being one who's advocating for your child and looking after them, so that you can have both in the same case. So running in perpendicular to both of these parallel spectrums is also the consider the impact of parental mental health. And this is difficult because what's most important is that it's not our role to diagnose parents with psychiatric illness. However, if when we're having conversations with families around what we think is wrong with their child, and if they're really refusing to accept it, and particularly if there's any sort of strange magical thinking or a night's move thinking, anything that might suggest that there's a mental health aspect, then we need to be raising that when we move into our multi-agency discussions. And it's actually normally the GP who is then the point person who takes a lead on parental mental health, which may or may not require a full mental health assessment. And that can only be stipulated by a court order, but we have had cases where that's been needed. So what are the effects? Well, obviously, there's the direct immediate effects. There's the unnecessary tests and procedure. There's the repeated hospital appointments and admissions, and the impact that has on children who are frequently of school age. So if you look at when most children experience PP and FII, it's pre-primary and primary. By the time you get to secondary, children generally have more locus of control themselves to step away from this process. There are often limitations placed on daily life. We've got children who've been, parents have told school they can't go in the sandpit for no reason whatsoever, but they're denied going in the sandpit with their peers because their parents say that they've got some weird immune thing, which is not the case. And sadly, death is associated with these FII cases in particular. It's rare to occur outside of FII, but it definitely occurs within FII. So that is one of the recognized complications. But there are also indirect and delayed effects. So we know from survivor stories that there's real problems with emotional and behavioral disorders. And effectively, it is long-term emotional abuse from a carer. And there are some powerful memoirs out there of people who survived some of these conditions as a child. The good news is there is published evidence that says if we recognize and intervene, then actually children can avoid some of those long-term emotional and behavioral disorders. So recognition does alter outcome. And that's part of the reason why I give this talk. So when do we suspect it? So if we look at the child, first of all, one of the things to be wary of is reported signs that are never, ever, ever observed. A poor response to standard and second line treatment often. So, the child whose parents say, oh, they vomit all the time, doctor, and they're on, first and second line antiemetics or PPIs or whatever, and it's not making any difference, except we've never seen it. Now, the difficulty here is, of course, that most pediatrics is outpatient driven. Most children will not have any signs in outpatients because it's a snapshot view. But we need to be cautious when we see children with sequential failure to respond to standard treatment, particularly when it's reported to be having an impairment of the child's life, such as multiple days missed off school, restricted activities, use of mobility aids unnecessarily, etc. And one of the things we would think about in this scenario is actually admitting the child for observation before we potentially go to the next level of treatment, particularly if that treatment is going to involve any more drastic procedures such as insertion of feeding tubes, surgical procedures, etc., etc. The parents also have a phenotype. So one of them is insistence on repeating investigations that have already been proven negative. So, the child's had 3 MRIs, but they want another one, with no real logical reason behind it. So it's one of those sort of fixed beliefs. A classic one is new issues are reported as soon as the old ones are resolved. So you go through one set of speciality consultation, treatment, etc. You get to the end and you go, oh, and by the way, doctor, he's had this funny limp that I haven't seen before. And so you refer very nicely to your colleague in rheumatology who starts the whole thing again. And then a really interesting one is lots of missed outpatient appointments, but multiple emergency visits with flare-ups of the condition. And when you try and sort of gently encourage them back into the outpatient visits, they swear blind they'll come and then never come. Also reporting resolved issues as live. So you're seen in clinic A, you're told the good news, you do not have condition A, you go to clinic B and you tell the clinician in clinic B that you still have condition A. And it appears on your letter from clinician B. And again, we're very good at listening to parents as pediatricians and faithfully writing down what they say and putting it in our letters to GPs. But sometimes it's worthwhile just getting a sense check. Multiple opinions. So, hospital shopping, sometimes multiple hospitals involved in the same child for different conditions for no obvious reason. And then the final one is complaints against everybody. So as soon as you suggest that perhaps everything's all right, you get complained against and they go and find another hospital because they don't actually want to know that everything's all right. They want to know that something is wrong. So we're going to split this up in what to do into FII and PP. So the FII is much rarer than PP. So in our hospital, I think in a decade, we've probably averaged between 1 and 2 cases a year of active fabricated or induced illness. We have seen salt poisoning, we've seen exogenous insulin administration, we've seen PN lines being actively cut. We've got at least one case of almost certain suffocation that wasn't quite caught on camera. The patient was having the VT for query seizures. So, you name it, we've had almost all whole gamut, but we get about 1 or 2 a year. They are much, much rarer. They involve clear, active parental deception. And to give you an example of what I mean by that, one of the cases that I mentioned was part of a serious case review, and not the child we were looking after, but another child was seen at a neighbouring hospital. And the mum booked the child in, who I think was about 7 or 8 at the time, into the emergency department with a painful wrist. And then the child is very clear that she then took him into the toilet, wrapped his wrist in a towel and hit it with a hammer so that it was properly painful by the time she was actually seen by the doctor. You need to be aware of the fact that this parental deception can be absolutely as blatant as that. So there's nothing that you can't think of that may not cover this scenario. It does pose a potential immediate serious harm to the child's health or life. Salt poisoning is potentially lethal. Suffocation is potentially lethal. And if it's identified, so if you suspect this, you need an immediate, and by that I mean, doesn't matter whether it's 11 o'clock at night, an immediate discussion with your safeguarding team, an immediate referral to police and social care. You will have to think about things like evidence preservation. So for the salt poisonings that we had to make sure that the bottle of formula that the family had was sent to the lab with a chain of evidence, which you wouldn't normally do from the perspective of being a healthcare provider. But if we don't have that, it can't be submitted in evidence in court. So call the police early if you suspect this. And then really importantly, you do not confront the parents until there is a safety plan for the child and any siblings has been agreed. You will need help and support with this. Seek it from your seniors or from your safeguarding team or from your duty social worker, but it is rare. PP is much commoner. And the really important thing about these cases is they need a single lead clinician who should be supported by the named doctor for your organization, but is not normally the named doctor because there's too many of them for the one clinician to hold. Really, you need to clarify what the child's true issues are, and you normally do this by convening a professionals meeting. It may require an inpatient admission, as we've said, to observe objectively things that are reported. Parents should be informed of the perplexing nature of the case and the need to clarify. We are open and transparent. We don't understand why your child is still having leg pains despite all the investigations being normal. We need to bring them in hospital and we need to look and see what's happening. We'll need to get physio involved. We'll need to potentially do some more tests. We'll get them seen by a specialist, and together we'll try and work out what's happening. But we don't have an explanation for it at the moment. And really importantly, when you do get to the point of working up your rehabilitation plan, it needs to be joint with education, because for many of these children, the lack of education is part of their impact. Referral to social care in these cases depends very much on the parent's response to the plan, unlike the FII, which is obligatory referral. If the plan is followed and the child is normalized, then you don't need to make a referral. And often there's an anxiety thing about it. And sometimes that admission and that holistic MOT reassures families and they're able to move on and normalize. If they either explicitly say they're not going to agree to that, or they implicitly they say they're going to, but then actually just duck and dive, then at that point you need to make a referral to social care as neglect. And you're going to need to keep good records, and you're going to need to make sure you've explained things to the family in writing, so that when you then turn around 6 months later and say, we said we need to do all these things, you've done none of them, social care understand that, yes, they've got a clear record that you did try to do those things. Any questions?
I think, so Giles, there are a couple of questions which have come through.
Yeah.
And Joanna sort of asked a question about, us as health practitioners. Have you had much experience in parents using functional health practitioners found on the internet and managing the medical interventions they suggest? And often parents have more confidence in them.
Yes. So this is not uncommon, again, in these scenarios that alternative practitioners are used. Similarly, Nicholas just put in private opinions as well. I think it's really important that you factor that into your multidisciplinary meeting. And we've certainly, for private practitioners, have invited those organizations to the professionals meeting because they need to be part of it. Most private organizations will have a safeguarding lead, even if the individual practitioner is less clear on it. With the holistic practitioners, that's obviously much more difficult, but it's important to listen to what the parents are saying and then explain why you think it is or isn't the case that helps. It's often around the fact that there's an unmet need in terms of unanswered questions is the rationale for it. So yes, we do see them, and it can be challenging. I'm just going to say somebody's put, do we refer without parents' permission? We never need permission to make a referral to children's social care for safeguarding concerns. We would always inform them, but we do not need permission. So we tell them if we're going to do it, but we don't.
That asked the reverse question, isn't it? She's saying that some of the parents say, my child's very well, I don't want to give a medication, or there are lots of them who will say vaccines and other things. It goes on and on. Where does this end?
Yeah. So if you've got a concern around, so that's not really FII normally. That's more sort of medical neglect, which is a different talk. But the context there is that you would normally start by seeking a second opinion, which should be an external second opinion, not from your department. So the parent knows that it's a truly independent opinion. And then if that second opinion aligns with yours, then you would make a referral to social care over neglect if you thought it was going to cause significant harm. And of course, the threshold for making a safeguarding referral is always, is it going to cause significant harm? And then the final
one. Got a good question. Yeah, she's talked about the sort of parents and mental health disorders, and where do we go with, if we think that's the issue, referrals wise, how can we help facilitate this?
So almost always what you'll find is that your psychiatry services will not accept a referral from you. They'll need to come from the GP. It's a kind of a process thing, but you're not the parent's doctor, you're the child's doctor, and actually you're not going to be the one who's going to be receiving the follow-up referral information. So we always go via the GP in that scenario. The only things we've occasionally done is when we've had parents who clearly been having an acute psychotic episode as an inpatient, then we have spoken to our local hospital-based acute crisis teams. Although even then, you often find that they're not actually authorized to practice outside of the emergency department. So you then have to try and persuade the parent to go downstairs. So it can be fun, but it's not a common occurrence. I think we've probably had no more than two truly psychotic parents in the last decade I can think of. It's a relatively rare process, thankfully.
It's an interesting one. We all have been dealing with a couple of these cases at the moment at the Royal London. And the thing which I found useful, and I think so you've got a lot more experience, is I now take a nurse or a nurse in charge with me when I speak with these families. Documentation, also consistency of note writing and the message which we give helps a lot, doesn't it?
I think having a second person present is really, really, really helpful because you often find parents will say that's not what you said, and having somebody else present, nurse, resident doctor, doesn't really matter, but somebody else who can sit there and go, no, no, that's exactly what he said. And then the other thing I would say is that in these cases, following everything up in writing that's explicitly sent to the parents, that's in black and white. Because one of the biggest problems we find with these cases is that by the time you've got to making a referral to social care, when there's been really poor engagement, one of the first things the families will often do is say, "But that's not what was explained to me, doctor. You know, the doctor didn't say that. Oh no, I definitely would have done that if the doctor had told me that." And so it's really helpful if you can have this black and white letter sent to the family, confirm that the family received it, and in fact, email to the family if that's something that you can do, because then you know they definitely got it. And when you next see them, so you got that letter I sent you that talked about what we were going to do. Yes. Okay, good. I'm glad we can document that. Because that has been one of the biggest holdups we've seen is where families deny point blank that and nobody's ever explained to them this isn't a medical problem and that the child just needs to do his physio and start walking. Families can be very selective in their recall when it comes to these scenarios.
Well, I think you've got a few fans already, Giles. So many thanks to you. And there's one more question if you can answer, and we'll take a break. And a big thank you. We all come back at 11:20 with allergy and cardiovascular talks with Dr. Kirsty Stewart, who will be your host and moderator. So see you all at 11:20, and thank you, Giles.
Okay, so welcome back, everybody. Hopefully you're now fully caffeinated and have had a quick break. So the next two sessions are going to be on allergy and then on the cardiovascular system. So to kick off, it's my pleasure to introduce Anthony Aston, who's paediatric consultant in allergy, to give us a top-to-toe score of how we deal with milk allergy. So go for it, Anthony.
Thanks, Kirsty. Okay, so fingers crossed this will work. Guaranteed it will have a microscopic problem, but give me a second. And is it showing up, Kirsty?
Yeah, you can see it.
Perfect. Okay, right. So yes, my name's Anthony. We've got a lot to cover, and there will be questions in the next one. So we're going to talk a little bit about milk allergy because milk allergy is the most common. Food allergy in children, so there are guidelines and stuff, so we're going to kind of try and run through things. The first time you tend to run into it is from the family say, well, this is the problem, isn't it? They've been Googling and whatnot, or there's a bunch of symptoms and you have to think, well, is milk the problem? The most common things that we're going to be thinking about are things like lactose intolerance or a milk allergy, but obviously this is just one part of the differential. I'm obviously going to talk about this part, but you need to consider all your options. You know, we are also general pediatricians about these kind of things. We're talking about symptoms. So what symptoms do we actually mean? So if you want to go to the nice guidelines, they talk about gut symptoms, which is a wide variety of pretty much anything and everything. Obviously, we know as general pediatricians as well that some things can present with multiple different symptoms. So you get reflux with abdominal pain, food refusal, vomiting. You can even get it with the acid reflux causing the congestion because babies don't get hay fever, and coughing and wheezing. So again, you know, we know this is general pediatric stuff. But what else are we talking about? We're talking about skin. All right. Now, the obvious stuff is urticaria, angioedema, things like that. But unfortunately, again, eczema creeps in with us, and we'll talk a bit about that as well, because unfortunately, suddenly every single rash in existence becomes an allergic one, even though we know that there are childhood rashes out there. So it is a thing, and I'll talk again a little bit more about some things I think we can help in terms of sorting it out or making it a bit easier for ourselves to try and kind of work out what's going on, but that's a little bit later. And what it doesn't help is that unfortunately the food companies are actually promoting that we and the public start thinking that these kind of things are all to do with milk. It doesn't help matters. But there we go. And then on top of that, we also got to think about respiratory symptoms. Some we've already covered already. But all these kind of things are supposed to be potentially associated with milk allergy. So that's just great because these things are insanely common. So how in the hell are we supposed to decide that this might be due to milk? Okay, good point. So go back to our main list of suspects when there's a problem. We'll start with lactose intolerance. Yeah, no, okay, it's not an allergy. We all know it's an enzyme deficiency. It's not an allergy, and it only produces digestive symptoms. I'll talk a little bit more about it in a minute, but I'm sorry, it is a red herring, all right? If a baby has come to you with the symptoms you're being describing, unless they're just gut symptoms, it's really not going to be lactose intolerance. And we're not here to talk about the differential diagnosis, we're here to talk about the allergies. So what I'm talking about is IgE and non-IgE. And I want to be clear, non-IgE is not intolerances. If you want to go all the way back to medical school, an intolerance has nothing to do with the immune system. This has something to do with the immune system. Right. So we've got our happy, cheerful, completely coherent historians who haven't been Googling everything or looking everything else like that. Okay. So what I basically mean is obviously we take a history, but we take it with a pinch of salt because they might not be the best historians in the universe. And then we try and find what symptoms they're talking about or signs they're talking about, and we try and group them because we're trying to work out if this kind of matches up with what we might expect with an allergy. Unfortunately, this does mean we have to roll back to pathology in medical school again. So type 1 hypersensitivity reaction involves a mast cell, IgE sticks to the outside, antigen comes along, cross-links, degranulates the mast cell. Okay, fine. All right, that's as far as I'm going to go back. The point about it is that the symptoms that you have are defined by the contents of a mast cell. And the mast cell degranulates. It doesn't wait 2 weeks like a time bomb and explodes. It degranulates when you come into contact with it. So this is quick. Now, it can produce a single symptom, say just a rash, or it can produce lots of symptoms. And we and you cannot predict that. You can only just realize that what the encounter they're talking about had several of these factors in there, symptoms in there. So going back to congregating all the symptoms. So we can talk about IgE symptoms. So these are the ones that are definitively come from the degranulation of the mast cell, and they happen quickly. Okay, so we can start with the simple stuff. If it's anaphylaxis, it's anaphylaxis. It's a clinical diagnosis. You do not need to run any tests to diagnose anaphylaxis. The tryptase will, I know, but you can. It's a clinical diagnosis. And these symptoms are consistent and they're acute. So if Johnny drinks his glass of milk on Monday and then vomits, but drinks his glass of milk the rest of the week and doesn't have any problems, then it's not an allergy. It's not an IgE allergy. And if they don't have it, then they're fine. It's as simple as that, because the food protein is destroyed, and if you're not exposed to it anymore, then you don't have a problem. So within 24 hours, the food protein is all gone. So you can't keep having reactions if you're not eating it and it's not in your system. Okay, so I have to touch on this one. So non-IgE. So we've talked about type 1. This is type 4. It is the only cell-mediated hypersensitivity, which means it's slow. Yes, I put 3 to 4 hours. It can actually be the next day or even a couple of days later. And it doesn't involve the mast cell or IgE or anything else like that. What it does is it makes the symptom or condition that's already there worse. So your constipation gets worse, your eczema gets worse, your mucus production increases. It's very kind of slightly more nebulous kind of symptoms. And because there's no mast cells, there's no histamine. So there is no urticaria, no swelling, no wheeze, unless it gets from the reflux. So if Johnny eats his peanut butter sandwich and 1 week later he develops a rash and swelling, it's not to do with this. Now, we can then congregate the non-IgE only symptoms. And of course, they're not so kind of distinctive. So how do we take these very common symptoms and say, oh, I need to be a little bit worried that there might be a problem? Well, it's not rocket science. If there's loads of them, then there's more likelihood. So if the kid has got allergic proctocolitis and significant reflux and eczema, then yeah, there is a good probability that there's some sort of allergy, non-IgE mediated allergy making things worse. Again, not rocket science. So going back to the simple stuff, so if the kid has got faltering growth and they're only drinking milk, well then maybe milk is the problem. As I said, if there's lots and lots of possible non-IgE mediated symptoms, then your threshold to kind of potentially think about that goes down, so more likely to be a problem, and you haven't found anything else. So as dumb as this sounds, you know, when you see the child in A&E with a little bit of blood in the stool, yeah, check the anus to make sure it's not an anal tear. I know it's silly, but it does happen. Because these guys aren't going to tell you, sadly. Of course, nothing's ever that simple because we have symptoms that can fit into both categories. So how do you tell these ones apart? Well, it's not rocket science either. It's all to do with timing, okay? So we talked about it briefly. IgE, boom, you get an acute rash, acute symptoms, acute itching, whatever. With the delayed one, this is aggravating a condition that's already there, and it happens hours later. Now, obviously, when you think about it, if you are continuously eating the food you're allergic to, you're going to be continuously getting the symptoms. And given the kind of age range we're talking about, that's difficult for them to protest and say, please, can you stop feeding me the milk? I'm having allergic reactions all the time. However, you have to remember that we're still looking for the same kind of symptoms. We're looking for urticaria, angioedema, that kind of thing, that it will be happening every time they say having a bottle of milk. Now, yes, it can be aggravating the eczema. I mean, any IgE mediated reaction is essentially like punching the eczema in the face, but you will be seeing other things as well. Now, it is absolutely fine to not be sure, because if this was easy, I wouldn't exist. So if you aren't sure, then treat them. Treat them as you would do if you weren't worried about milk allergy. You know, if there's reflux, give them a PPI. If there's eczema, well, treat the eczema, and so on and so forth. So it's not, again, not rocket science. This is not going to cause them a major issue if you haven't picked up that there's a non-IgE mediated allergy. That is something that you're going to find a little bit later on. So if they're unresponsive to the treatment you've just given, then consider that there might be an allergy present. I don't know if Kirsty appeared to tell me I'm running out of time, but I'll carry on. So I'm going with look at my allergy testing lecture. I don't have a lot of time to talk about it at the moment, but bottom line is you don't need to generally do this because it won't generally help you, okay? And I know it's a bit weird for an allergist to say that, but it's an expensive test because it's 19 quid per food tested. So 10 foods is 190 quid. So it's not cheap as chip stuff. It is limited. It's got very limited specificity and sensitivity. You may be surprised to know there's a significant risk of false positives. So you're going to make potentially the wrong diagnosis and falsely, unnecessarily restrict. And it's possible that it can be wrong, even if it is negative. So this is why allergy is history-led, and this is why we do tests, but we do them and look at them with a degree of caution. And there is no relationship severity. The number can be huge. It doesn't mean anything like that. With non-IgE, as I said, the clues in the name. Why would you do a specific IgE test for a non-IgE problem? So don't. So if you think it's a delayed problem, do not run these tests. It's like x-raying your foot when you've had a head injury, okay? Pointless. And often, as I've just said, they will be falsely positive and so the only validated test is you take it out and you put it back in again, which sounds not complicated. It's easier said than done. Of course it is, but you're supposed to take it out for somewhere between 2 and 6 weeks. The duration depends on the severity of the symptom or condition that you're dealing with. You're looking for improvement when they're off it, and then you put it back in even if they improve, because what we're looking for is they get worse again afterwards, and that's how you make the diagnosis. Of course, we live in the real world, and none of the families want to put anything back in once they've seen some improvement, and we can live with that, but we'll deal with any kind of long-term issues down the line. Now, exclusion is not just about diagnosis, it's the treatment as well. And of course, don't worry, we're not talking about polls on this one, but the point is you've got to deal with the plethora of weird and wonderful formulas out there that you kind of go, what the hell is this about? You're usually lucky if you've probably got local guidelines where they make deals and you can do this one for this and whatever. But the first thing to talk about is lactose-free, okay? Just no, okay? Now, the reason I'm saying no is because when you look at it, primary lactose intolerance, which is the most common, is when the lactase enzyme falls off, and it happens in adulthood. The earliest you'll ever see it is in people who are 2 or more, okay? Secondary, which we're all familiar with, you know, you've had gastro and then you can't tolerate lactose containing milk. That's very common, you just get better. And the congenital one that screws us all over is actually incredibly rocking horse poo rare, and is due to a gene defect. So you have absolutely no lactase, which means that you are a phenotype where you have profuse diarrhea all the time, whether it's breastfeeding with the lactose in it, whether it's the bottles with the lactose in it, it's profuse diarrhea. So the ones with a bit of an upset tummy and so on and so forth, they do not have congenital lactose intolerance, all right? It's not that. And the other thing, I know I'm going to overrun a little bit and I don't care. We have to talk about this. Do not make mothers who are breastfeeding go lactose free. It doesn't do anything. Again, I'm harping back to medical school way too much. But if you look at biochemistry, well, obviously the other half of the population make lactose, okay? We make it from glucose. So taking lactose out of a breastfeeding mother's diet does not stop her producing lactose in her breast milk. So why would you put her through that? It is pointless. Yeah, right. People come to you and go, oh, I want to put my child on goat milk or, you know, buffalo, whatever. Don't. It's basically almost certainly going to react because they're very, very, very similar. So we do not use other mammalian milks as alternatives. And I've already said you don't do lactose free, but the other reason you don't do lactose free is because it's got exactly the same amount of allergic cow's milk protein as normal milk. The only thing that's missing is the sugar, not the allergic protein. You'll come across soya, and yeah, I mean, it's there. General recommendation, don't give it below the age of 6 months because it's got a female plant hormone in it. We don't really know what it might do if it's the only thing you're eating. The other problem with it is about 50% of people who've got the delayed milk allergy will have a problem with it, less so with the IgE. But, you know, in certain circumstances, we have to give it a go. From the prescribed milks thing, well, there are 2 main groups. There's the extensively hydrolyzed, where essentially the cow's milk protein has been chopped up into peptides. And as a result, most children who have milk allergy should be able to tolerate it. But not all of them, and that's why it's a trial of treatment. And if they fail it, then the next step will be the amino acid-based formula, which, as the name implies, being chopped down to amino acids. So more broken down, so less likely that the body is going to remember that this has got anything to do with milk, and therefore more tolerated. So You would use an amino acid-based formula if you failed with extensively hydrolyzed, or you may go straight to it if you're really worried that the person has a severe non-IgE mediated allergy, horribly faltering growth, and you just don't want to pussyfoot around. Okay, Kirsty, I see you. In terms of the extensively, it's going to be the mild to moderate ones. And just remember that there are 2 of them that actually contain lactose. The rest of them don't. And the reason they do that is to try and make them microscopically more tasty, because it's horribly bitter stuff. Okay, all the others, no lactose, if you're still worried about lactose intolerance, I mean. These things taste disgusting. I have tried them. They are disgusting. They are absolutely like the milk you've left in the fridge for 6 weeks. Okay, absolutely. No human being, adult human being, would have this voluntarily. And so, understandably, their parents don't want to feed it to them, but you need to warn them that, first of all, it may smell and taste disgusting to them, but babies have very immature taste buds. The other thing you have to warn them is it might cause some loose stool for a few days, and that's perfectly normal as the gut gets used to it. You can look on the slides later, but this is a few examples of things you can do to make it taste a little bit nicer, to try and make sure they take it. You can mix it over time if it's with their normal formula, if it's a non-IgE, but it's also about supporting the family and making sure they persevere, because most babies will do it. However, above the age of about 9 months, they're developing their taste buds. It's going to be more of a struggle, but it's what we've got. Okay, what have we got to actually help you? Well, there are guidelines. There's the International Milk Allergy and Primary Care Guidelines. It's very likely lots of your regional ones will reference this. It has summarized both the diagnosis, the investigation, and the management in 2 slides, which you can definitely have a look at. And also, it's got important stuff of recipes for the families, but also, particularly with the delayed one, because this is not for IgE-mediated ones, for the delayed one, it tells family how to gradually put dairy back into their child's diet. Yes, there are other things out there. The BSACI is the British Society for Allergy and Clinical Immunology. So yeah, it's the national allergists. There are good charity websites with good information, Allergy UK and Anaphylaxis UK. And I'm sorry for the dash, but the next one's quite long as well, but we're going to summarize. So with the IgE mediated ones, you can have a single symptom or multiple symptoms, but they're all related to the degranulation of a mast cell, and they are acute, minutes generally after eating the food. You can use tests if you want to, but more often than not, you can probably diagnose it just from the history alone. But yes, skin prick testing or specific IgE, neither is necessarily better than the other in this case. The non-IgE is going to generally affect the gut or the skin. The only diagnostic test is the exclusion diet that we already covered. You don't run blood tests for this or a skin prick test for this. And then with the lactose intolerance, it does not involve the immune system. It is an enzyme deficiency. So the way you diagnose it is you don't do these complicated breathing tests and everything else for older kids. You just put them on lactose free for a little bit, and their symptoms should improve really quickly. But just to kind of touch a little bit, I know we mentioned kind of allergic procticulitis, the blood in the stool, that kind of thing. If you see that, that's only with non-IgE, and it's more common, but not completely, with breastfed children, okay? So neither IgE nor lactose intolerance will have any rectal bleeding. And please don't sell this as colic, okay? Colic is a whole other ball game. And when you're looking at this from a timeline, we know that colic gets better from about 3 months onwards, and reflux gets better when we start giving them solid food. So again, an improvement or change could be expected anyway. And seeing that improvement, if it's also around the time you change the formula, could be due to just normal progression rather than a response to treatment. So again, this is why the guidelines talk about reintroduction. We talked about the dietary exclusion. Just be careful. Some families go totally down the rabbit hole and start removing everything from both mum and baby's diet. And you've got to remember, if mum is taking dairy out of her own diet, she will need to either use an alternative milk, or she will need to take some calcium and vitamin D supplements. Otherwise, she will develop early osteopenia. And remember, if you're trying a formula it's like trialing a medication. If it hasn't worked, then stop it and try something else. We talked about lactose intolerance. As I said, it's rare in babies. It's take it out. If you really need to, you can put it back in, but usually they just get better. Non-IgE, we've talked about this as well. You take it out, you put it back in, you're looking for a change in the symptoms. IgE is usually just history, but you can do tests if you want to. And just have a look at your local guidelines. They should be pretty straightforward in telling you which deal they made with the company, so what you prescribe. And don't forget about reintroduction, because they're not stuck with it forever. In fact, 50% of people will grow out of the milk allergy by the time they're 1, 90% by the time they're 6. So there is a good chance the person in front of you will grow out of it. Oof. Okay, sorry, don't know how far I went off, but Kirsty, how are we doing?
It's now 1:45, so you've probably got 40 minutes.
Perfect. Any questions you want to bring up now?
I think some of them, you've covered some of them. I think it'd probably be better to deal with them at the end, if that's okay.
And I will try and answer any questions that are put online. If I can make all this stuff work. So, bear with me 1 second. So, ping, and ping, and ping. Okay. Is it coming up?
Yep, can see it.
Perfect. Okay, so some of the stuff I'm going to come through with this one, I have covered a bit with the milk. I just want to reinforce it. Now, this is just going to be a run through, all right? This is going to touch on points through a patient journey that you may run into on the ward or in outpatients. And hopefully this will kind of spark some discussion as well. So if you have a fancy phone and want to try and do some of the questions, there will be this QR code appearing when we do the questions. But if you want to do it now, you can do it now. And as I said, just watch some of the videos. We're not really going to talk too much about allergy testing, but we are going to talk about anaphylaxis because it's a little different these days. So we've got our young lady, and we're going to start from when she's a wee little winky. But she originally presented at 7. Sorry, not originally. She presented to you in clinic at 7 years old, and unsurprisingly, school would like us to investigate her allergies. Okay, not uncommon. So the parents tell you they're worried about these things, and you take history. She previously had eczema, no other significant atypic symptoms. So the dairy history is previously, when she was a baby, she had blood in her stool. She was breastfed at the time. She was otherwise growing, bit of constipation, bit of colic. Nothing to find on examination apart from a little bit of rash, eczema, and nothing around the bum. So we're not going to strain ourselves too hard. What do people think? Oh, sorry, that's not right. What do people think about this? So bear with me 1 second. Computers. Right, that's not doing it either. Okay, so let's reset this. Right, let's try it again. Please submit now. God, I feel like one of those quiz shows. There you go. So on the side, it's 4-week-old, eczema, breastfed, reflux, constipation, blood and stool thriving. I feel like I should have some music going in the background. Okay, I know we've got a lot to cover, so I am going to stop. I know there's loads of you out there, and we'll do more with the next one, okay? So, understandable spread. And what did I say? I said, starve mum. So, and we kind of covered that before, because we know that allergic proctocolitis is more common in breastfeeding mothers. We are a breastfeeding friendly NHS, so we don't really want to start putting them on a formula if we can help it. And as long as we give appropriate advice, we're not going to harm mum by making her go dairy free. Now, it's not a bad thing to say wait either, but more often than not, the parents are freaking out, so they feel like they need to do something. I think the only thing I always tend to say to the mums is, you're not poisoning your child. This is an extremely common thing, and they will grow out of it. But what I would probably do would put mum on a dairy and soya, actually, free diet. Because allergic procticulitis is really just a kind of very transient, minor thing. Maybe it's a mucus there as well. We don't really understand why just that end of the gut is affected, why it's more common in breastfeeding mums, but it is what it is. So you might see it in the first few weeks of life. Even I've seen it in the first couple of months of life, but it's a condition that will resolve on its own with time, even if you didn't make mum go dairy free. Again, we've muttered about this already because this covers what you would do. And as I said, we're breastfeeding friendly. This does kind of touch on a little bit of something that's come up as well, because we always get asked, well, how can I prevent any of this happening? Well, actually, you can now. So there were 2 studies, the LEAP and the EAT study, which have basically said that early introduction of peanut, and I don't mean peanut, I mean smooth peanut butter, and egg can actually prevent you from developing those allergies. For those high risk, it can reduce it by as much as 80% with peanut allergy. So we've been trying to push this out with the health visitors and the midwives as much as possible, but these are internationally recognized guidelines. This is not some kooky allergist in a dark room. I mean, we are kooky and we do live in dark rooms, but this is global, and particularly in Australia, they've done amazing stuff with it. Right now, so what's the problem with milk now? Because you've talked about milk, so what's the problem now? Well, she has it in her cereal. She has it in her ice cream, and she's still telling people she's allergic to dairy. Okay. So we'll come back to that. So fish, the parents are worried about fish. And of course, we ask, well, why are you worried about that? Because when she was 2, she got eye swelling and a rash. And she woke up in the morning with it, and they had dinner with fish the night before, which she'd eaten before. And everything was normal. This is the rash they've still got on their phone. A bit of congestion. That was about it. So, dun, dun, dun. Oh, no, open that up. Right. So you might miss the first one. So if you don't see the result, then come up. There's nothing wrong with asking for more information. I always like as much information as possible. I harass other hospitals and everything. It's a good thing nobody is saying, I don't know why I'm on the course. That's always good. Okay. People are changing their minds. Numbers are going. I didn't realize the numbers could go down. Okay, I'm going to stop it because we limited time, but thank you. Okay, so most of you want more information. All right, I understand. So you get some more information. The rash lasted 5 days, spiked a temperature, got a cough, and was promptly diagnosed with a fish allergy and has been avoiding fish ever since. Does anybody want to change their minds? Because I'm going to allow you to. Well, that was stupid of me because I gave you all the answers. Seriously? Somebody thinks it's a fish allergy? Okay. Well, I suppose that's why you're here. Cool. Thank you. Yeah, I'm gonna go with it's a viral illness, and I'll explain why by talking about how we take history. So there are tools how you want to do an allergy history. Again, you can check out which one you prefer. I'm going to talk about the eaters one. It's as good as any. So what it basically says, there are aspects to your history that you're supposed to check. So you have to check that the patient was exposed to the food that you're worried about. Okay, that is hardly rocket science, but okay, makes sense. So they're exposed to it, and then is it one of the common ones? Because common is common. Now, from that perspective, there are differences. As I said, milk is the most common allergy in children, whereas peanut is in adults. But you can see otherwise, a lot of them are very common foods that people eat on a general basis in kids. So 90% of these food allergies are caused by these foods rather than the goji berries they had imported from Brazil, which, yes, I have had people ask about that. So common is common. Timing. So we've already talked about this in the other one. If it's an IgE, it's a bomb going off. It is an explosion of mediators pumped into the circulation. This happens quickly. And we talked about this already, okay? Generally within minutes, but can be up to about an hour or so later. You need to know the pathophysiology again, because we've already touched on this, and I said we're going to rush through it. It can go as one symptom or multiple symptoms, as we've already said. And so again, do these symptoms fit with what you'd expect from a degranulating mast cell? The environment, this is less so. I mean, because these days you can come across anything anywhere, but more common when you're weaning, because this is the first time you encountered it, or if you've gone away or bought some takeaways and got contaminated with something else. Usually if people are doing their own cooking, they know what they're cooking. And as I said, right back in the other lecture, it happens every single time. But please remember, it is not what we were taught in medical school. It is not the same reaction each time. If I'm allergic to milk, I drink a glass of milk on Monday, I may get a rash and vomit. I may drink a glass of milk on Friday, and this time I start wheezing and my face swells up, okay? Now, if I drink a glass of milk on Wednesday, something will happen, but I do not know what kind of reaction I will get. But something will happen. Yes, okay, we do get taught about this a lot, the family history, the personal history of allergic disease. But please remember, there isn't a gene out there. So just because dad has a peanut allergy does not mean that all his spawn will have peanut allergies. There's nothing like that. It's a bit more like that two-hit hypothesis we used to learn. Yes, if the family have allergy, an atopic condition, doesn't even have to be a food allergy, atopic condition, then the lifetime risk of their children developing an atopic condition is higher. It is not this obsession that people seem to have that their child is exactly like them and is going to develop exactly the same foods and exactly the same severity. It is not. There is so much geographical component. This is why, for example, in Japan, there's so much fish allergy, because they eat a lot of fish. So where you live makes a big difference about which allergies you develop. So when you are thinking about a food allergy in a person, we're coming back to JP. So she ate her fish. It was the next morning she developed symptoms. She got temperature. The rash lasted several days. She hasn't had the fish since, and she's got eczema and possible milk allergy. And then there's no family history of anything significant. So if we apply it, shock of shock, she was eating it. It is one of the common ones. However, the symptoms happened the next day. It occurred at home, which is common. It wasn't weaning, which means it's less common. This was a contamination. We don't know if it's reproducible because he hasn't had it again. And it is not typical for an IgE because it all happened the next day. She developed a temperature. People don't get temperatures with food allergies, okay? That's infections, not food allergies. And yes, she does have eczema, but the rest of the family is non-atopic. And just because I like using graphics, if we add it all in, then how does this balance out? Well, it comes down to basically it doesn't sound like an allergic reaction that's IgE. So we're not going to call it an IgE-mediated allergy. We can't be 100% sure. Well, I am, but it's not. It just doesn't fit with the pathophysiology. And then, okay, and we touched on this, intolerances, all right? As I said to you before, intolerance does not involve the immune system in any way. It's usually an enzyme deficiency, so it won't affect your eczema, it won't cause you a respiratory problem. I don't care what other people say. It's a digestive problem only. We've talked about this. The symptoms take more than 2 hours for non-IgE. Yes, a lot of the public call this intolerance. It's not what we call it, but a lot of the families understand the concept of this, because in a lot of situations it can eat a certain amount and you go above it and you get symptoms. But as I said, because it's non-IgE, there's no urticaria, angioedema, or anything else like that. Now, we know urticaria is incredibly common, more common in children, but that's because of various different things. And often it is accompanied by some swelling, but you can have swelling on its own, and it's global. Again, big shock. But there is a differential. We get a lot of times the referrals, okay, they got an urticarial rash. Yes, and what makes you think that's got anything to do with allergy? Because there is a differential diagnosis. It will happen with infections. There's stress-induced hives. There's so many things that could be a cause of it. Yes, it's useful to be aware that it's there, but is it necessarily automatically an allergy? No. Useful things, again, you can take a longer look at this later, but the difference between an urticarial rash and urticaria, and again, yes, I appreciate this is perhaps more in the realm of people who do this on a regular basis, but the bottom line is this: if you are having an allergic reaction from an urticarial rash causing urticaria, it will last hours. It will not last days. Why? Because the food protein is destroyed in less than 24 hours. Usually, because of the histamine release, it's very itchy. It does not leave marks. Vasculitic urticaria does leave marks. There can also be because there's been inflammation of the skin, there may be some scaling that happens a little bit further down the line. It is not uncommon to get some swelling with an allergic reaction. It's a bit less common with a more autoimmune process. You don't get temperatures, as I said. You can get temperatures in more autoimmune kind of conditions because you have systemic inflammation that's activating the more cytotoxic side. Obviously, you can be ill and have an allergic reaction, but often these people are ill and will have the urticarial rash. The bottom line is, quite often we get phone calls and everything else about this. Somebody needs to take a photograph, because people calling it an allergic rash doesn't help. Now, she's worried about nuts. Nuts is very, very common. It's one of the top allergies, particularly in adults. So she's back in A&E. This time she's 3. Query, cough, cold, runny nose. No preceding cough or cold, though. She was at home. All of a sudden, cough, wheeze, facial rash. She's given this and put into the waiting room. It happens. I've seen it happen. Then poo hits fan. And we already knew about this. So she's got worse. She's now moved to resus because she's got difficulty in breathing. She is coughing and wheezing more. Salbutamol has not made any difference. The rash is now all over her body and the lips are swelling. Sats are dropping, but she's tachycardic and a little bit hypertensive, but there's no hypotension. And now we get that little bit of information that we really could have done with before, which is mum says she ate the chocolate with nuts 10 minutes before the symptoms started. So, putting it to the history, do we really need to? So she ate something with nuts. She rapidly developed cough, wheeze, and facial rash. She has been avoiding all nuts up until this point. And we know she's got the history of eczema and possible allergies and no family history. So yes, common, acute, can't reproduce it because the first time she ate it, and it is typical. So unsurprisingly, this thing says she does have an allergic reaction. I mean, look, I know I'm teaching you to suck eggs, but I just have to show our working with this one. Right, so I don't know why it's jumped ahead like that. No, don't know why it's jumped ahead. Apologies for that. Now, the point about all of this is that I am now going to start talking about anaphylaxis because we need to. All right, this is the thing that scares us. And there are lots of different guidelines out there. They're all very interesting and wordy, and they all say the same thing. Yes, it might kill you. Great. So that's going to scare the living daylights out of anybody, and understandably so. So again, hardly rocket science. We know that anaphylaxis is a severe allergic IgE-mediated reaction. Duh. But what is less clear is that anaphylaxis has its own spectrum of severity. So the term anaphylactic shock is not interchangeable with anaphylaxis. It's not rocket science again. There's shock. So it is at the severe end. You do not have to have shock to have anaphylaxis. Okay? And I can't walk into a room and immediately say what is happening to the person is anaphylaxis. I need more information too. Okay? Nobody can do this. So which person in this room is having anaphylaxis? Okay, I see you, Kirsty.
About 10 minutes, Anthony.
Yeah. So more information because you just can't tell. Now you've got a bit of history. This person's eaten the chocolate bar, started coughing, got stridor, and then he's got swelling and urticaria. Whereas this person had vancomycin, has now turned red. Okay. It's obvious. The one on the left is the one who's having an allergic reaction, whereas the other one is just having what used to be called Red-Man syndrome. And this is the bottom line about anaphylaxis. It is a clinical diagnosis. It is the ABC. It is compromise of the airway, breathing, and or circulation. So it's right back to APLS, ALS, all that stuff, okay? A and B compromise is more common in food allergy. Circulatory compromise is more common in drug allergy, but you can have an intermingling of all of these, okay? I appreciate that some of this is very subjective, okay? The difficulty in swallowing, a little subjective. The swollen tongue thing, I've had enough children stick their tongue at me to kind of go, it's tough. Unless it's like the textbooks, it is going to be quite tough. But the persistent coughing, they can't catch their breath. The wheezing that they can't really fake, all that kind of stuff, that's anaphylaxis. The Resuscitation Council have this nice bit where they kind of summarize the severity issue. So have a look at it when you can. But as I said, it's the airway, breathing, and circulation problems. Of course, there's an algorithm. There's an algorithm for everything, and we'll use it in a second. So going to this young lady, we know she ate the chocolate bar. We know she's got some skin signs. We know she's got some respiratory signs, which means we know she's got anaphylaxis. Again, it feels like I'm teaching you to suck eggs, but if you're not sure, some of these algorithms can help. The kicker, however, is that the rash and the swelling is not conclusive. 10% of cases have no hives. So even if they do not have any skin symptoms, they can still have anaphylaxis. And as we touched on with her, antihistamines will not stop you getting anaphylaxis. You will still get anaphylaxis, okay? It will mask the symptoms somewhat, and I'm not saying don't give it, but it's the timing that's important here for having reassurance, all right? Now, at this point, if your head is not exploding, it soon will be. This is another thing from the Resuscitation Council guidelines, all right? So this is how long it takes an allergic reaction to kill you. Now, admittedly, that's very dramatic, but the point I'm trying to make is that it will take a bit of time. So if you look at food allergy, it can take up to 45 minutes for it to fully blast you and cause major problems. Now, that's important because if this young lady is brought into A&E rapidly after eating the food, then there may still be a bit of time before it comes up to the full whack and does what it's going to do to her. And so just be careful with the ones who were presented very quickly. You know, the one that said, oh, 4 hours ago, I ate my chocolate bar and then I got a rash. They're not going to develop anaphylaxis sitting in the waiting room. The one who had it 30 minutes ago, it is a risk and you need to keep an eye on them. So of course that comes to management. We gave her intramuscular adrenaline. They gave her intravenous chlorphenamine, intravenous hydrocortisone. She wasn't doing so great. The blood pressure started to come down. Her conscious level started to go down a little. But remember, okay, you can give a shot of adrenaline, but that's not the end of the story, okay? It is boosting your natural adrenaline. It works quickly, but it disappears from your system within 10 minutes, okay? That's the same for everybody. And that is why the algorithm tells you to give more, okay? She got a second dose. After 5 minutes, she got blasted with salbutamol. Still not doing great from that point of view. In fact, her blood pressure's dropped a bit further, as is her conscious level. She's now wheezy, face swollen, all that kind of stuff. So now she's even more compromised. Hopefully this will work. Right. Okay, guys, what do you want to give her next? I really need music going on with this. Cool. Okay. I'm conscious of time, but thank you guys for answering. And to be honest with you, with most of these, you're not wrong. Okay. It depends the environment that you're in. And I'm going to talk about what I mean by all of that. So she got more salbutamol. She kept on getting oxygen, but her blood pressure is now in her boots. She is looking even crapper in the nicest possible way. So we know what's happening. She's becoming extremely vasodilated. She is becoming hypoxic, hypotensive. She's going into shock, okay? And we know this because we know generally what happens when you have severe anaphylaxis. So this is a study where they actually stung people with a bee and they looked at their heart rate and blood pressure after they got stung. So if you look at the sting that was there, afterwards, their heart rate goes up, blood pressure goes down, and they get the dose of adrenaline and everything's fine. Yay, that's what we wish would happen. Well, that's not what's happening here. This is what's happening here. So this is another patient in the same study. So they got stung and the blood pressure goes down, the heart rate goes up, they get their dose of adrenaline, doesn't make a ton of difference. So they get another one and another one and another one and another one. And the yellow one is when they get the infusion of adrenaline. So this person has utterly decompensated, okay? The adrenaline is just not enough as intramuscular shots to keep them going. And we do know who these people are. We do, because they are the ones in the newspapers. But in clinic, we don't know who they are because we can't tell the difference between one person and another. The tests don't tell you. Nothing tells you, which is why it feels sometimes we're giving out adrenaline like sweeties, okay? Now, the Resuscitation Council recognized these people in the 2021 update. So they made changes. No more chlorphenamine, no more IV acute steroids. Definitely give intramuscular adrenaline, but there is now a new algorithm for refractory anaphylaxis, okay? And that is defined as they haven't responded after 2 doses of IM adrenaline. And this is what it looks like. And you guys who wrote about fluids and IV adrenaline, yes, that's what this is. But if you don't have access to IV access, then yes, you will be giving more intramuscular adrenaline and definitely calling somebody to give you a hand. But the point is, this is no longer the purview of PCCU or PICU. This is what we are supposed to be doing in A&E with giving an IV adrenaline infusion. And this is all the stuff you need to know in terms of how to do that. The other thing that's useful just to know also is that the observation periods after having anaphylaxis have changed. This makes managing them in A&E a lot better, okay? Your decision-making process is a lot faster. With a lot of them, you just have to watch them for an hour. Because remember what I said, they have an allergic reaction. If they're going to do something horrific, they're going to do it generally within an hour. You saw the graph from before. Just to be clear about it though, the Piriton has been removed, the chlorphenamine IV, IM has been removed because it causes hypotension. And you already don't want to cause hypotension if somebody who's already hypotensive. The other weird one is with the IV steroids. Now you can give them once resuscitation has been completed, but for some reason, the statistical analysis said if you gave them acutely during resuscitation, whatever the severity of presentation, they were more likely to end up in intensive care. Don't know why, that's just their statistical analysis. So again, look at this when you have the time, but this is just the risk assessment in A&E as a decision-making process, because it makes it easier. It really does, and can improve things in A&E. As I said, we already know who these people are because they always make the news. I know we've got a little bit of time left, so I'm going to kind of dash through. So the last thing she was worried about was wheat. She is having she's gassy and constipated. There hasn't ever been an acute reaction. There's a nutritionist. I don't want to go there, but there we go. And she was told that she's intolerant to wheat. However, she is growing. She's still got wheat in her diet. So very quickly for people, who wants to say, based on that limited information, do we think this young lady has an IgE-mediated allergy, a non-IgE-mediated allergy, celiac disease? And I like it. Yes, clearly somebody wants this all to end. Yep. Again, apologies. I'm conscious of the time. So yes, I'm glad nobody thinks it's an IgE-mediated allergy. I really am very glad of that. Okay, so yes, if we apply the things to her, she eats it. These symptoms are not IgE-mediated. It's still in her diet. And yes, she's got all the history and everything else like that. But the point is that this is not an IgE-mediated allergy, so you can apply this to it. Don't get me started on these alternative tests, okay? Please don't. They're insane, okay? I'm very sorry. They're insane. They are not validated. There's no evidence base behind them. They are a waste of money, okay? The families, if they want to spend it on that, but please don't make any medical decisions based on these tests. They are not worth the paper they're printed on. We've already talked about what is a useful test. So we've talked about this already. And this is what you would do if you were seriously considering that this might be a non-IgE mediated one, after obviously you've checked for celiac disease. We've already talked about these things, the milk ladder, but there are other ladders if you wanted to gradually reintroduce these foods into the diet for delayed symptoms. Again, not the immediate ones, because that's dangerous. And these are relatively readily accessible, or you can talk to one of your dietitians. They're sure to have some of these kind of things in their bag of tricks. With this young lady, we've now decided about the dairy. Well, she's blooming drinking it, okay? So whether she had allergic proctocolitis or not, she's eating it, which means she's fine. Again, history beats everything. So I wouldn't even bother doing a test on her, okay? If you're really that bothered that it's contributing to something else, say her eczema or whatever, you could take it out for a few weeks, but quite frankly, no. From the nuts perspective, okay, she had a reaction. She ended up with anaphylaxis. She's not eating it. We just need to make sure they're safe, okay? Do they have the adrenaline pen? Do they know how to use it? Do they have enough of them? And that's another lecture you can have a look at on the thing. And make sure they have an allergy management plan, which is free. And again, if you look at the other talks, it's in there about where you get it. But anybody who's had anaphylaxis needs to see an allergist at some point. Doesn't mean continuously, but at some point. For the fish side of things, look, it didn't fit with a fish allergy, IgE-mediated fish allergy. She's not eating it at the moment. She can eat it, okay? She never had a reaction, as far as I'm concerned, so they can put it back in the diet. I see you, Kirsty. And then we talked about the wheat. It just doesn't fit with anything. If you want to think it's a non-IgE after you've ruled out celiac, then take it out for a few weeks and see if the bloating and everything else gets better. Then put it back in and see if it comes back. We've already talked about allergy testing. It's poop. So we won't talk about that anymore. But in summary, when you're looking about all of these things, as we've talked about originally, which is you've got to consider, does this fit with an IgE or non-IgE? And that's the starting point's always got to be the history. Urticaria doesn't automatically mean IgE. And Yeah, I use tons of general pediatrics in my clinic to try and persuade people that actually what they're talking about has got nothing to do with allergy at all. Be aware that the adrenaline guidelines have changed, that most places have updated, but double check that yours has updated to the new guidelines, which means no chlorphenamine, no immediate IV steroids, and that they know about the refractory anaphylaxis pathway. Yes, we know everybody feels like it's the root of all evil and that test is going to do answers, but it's not. Okay. And remember that you can talk to your friendly neighborhood allergist. We know that you struggle with limited services in district general hospitals. You've got limited tests, no skin prick testing. You can't get them to try the food in hospital safely because you don't have that. So just stick with common sense. If it sounds like a duck, walks like a duck, it's a duck, and then so it's an IgE mediated allergy. You can potentially join your local allergy MDT virtually and put it in your job plan. You can talk about resources because skin prick testing is a lot cheaper than specific IgE tests, and find out what your dietitians are happy to do because they may want to develop their aspect as well. With the adrenaline pen, you need to know how to administer one because you're going to have to teach them, and you can get free trainer pens for the public and the health professionals from the manufacturer's websites. You can do it in clinic and give them out in clinic. And as I said, recognize anaphylaxis because you're going to be teaching people that they need to give the adrenaline pen when they recognize anaphylaxis, and just be aware that the guidelines have changed. Ugh. Right, there is stuff after this which you can read. But if any of the questions touch on it, we can go through. How long we got left, Kirsty? It was like negative
Amazing.
5 minutes.
Two minutes, maybe a couple more for some questions.
Okay.
And there's quite a lot in there. So if you could answer them afterwards, that'd be great.
I will.
But there's a couple that I've just picked out. So one of the questions very early on in the beginning was, do you use the COMIS score for CMPA kind of assessment and management?
No.
No. Okay.
It was created by a food company, and no, I don't.
And then another one was ketofen and sodium chromoglycate use for non-IgE mediated.
Okay, someone's been doing some reading. Okay, so the person who is saying that probably needs to join the GAP Society, which is the Gastro and Allergy Pediatric Society, which is run out of Imperial, but it's virtual, so we can join it, because this is a very difficult area to manage. There is very little we can do apart from the exclusion challenges, and you're not wrong to ask about these medications. There is some evidence base that ketotifen and or sodium chromoglycate, which is weirdly licensed for food allergy, can help in these kind of situations. The ketotifen is thought to be a weak anti-TNF alpha, so it reduces inflammation a little bit, but remember, it is a first-generation antihistamine, which means it causes sedation. So yes, you can use it, but I tend to prescribe it at nighttime, particularly in the slightly older kids, and I tend to use it more in the younger ones when their gut is just such a mess that their life is just miserable. Everybody's life is just miserable with that, and then hopefully they can grow out of it over time. But the other thing you'll find fun is persuading your GP to prescribe sodium chromoglycate, because it's freaking expensive when it's not an inhaler. Oh, and the other thing, ketotifen, you can crush the tablet and you can get it as a liquid. The reason I mention that is because sometimes you struggle to get it in one form or the other. So you don't have to throw your hands up in the air. If it's just tablets, you can crush them and dissolve them and give them that way.
Brilliant. Thank you. That was really interesting. Like I said, there are quite a few other questions. If you don't mind typing some answers, that would be
okay. Really quickly then, the other slides which you can look at on the PDF, it talks about and it's my opinion, just to be clear, my opinion, because we get, I'm sure you do too, get a lot of advice and guidance queries. And all I am suggesting is some very basic suggestions to make it easier for both GPs and us to answer these questions. And the second thing that's on there is a few slides about the adrenaline thing that you squirt up your nose, the Uronefi. It is licensed in the UK, but Understandably, given the current financial situation, there is a lot of dragging in terms of getting it on formularies, but it does exist. I mean, at our place, I can only prescribe it on an individual basis, and it's not part of the ICB formulary, but it is coming. And while we're waiting for more data, real world data about it, the BSACI, the allergist group, has said that we will likely be looking at a situation where the patient gets one of these Neffys and an adrenaline pen in case they're one of the group that might not respond. And this is all a bit theoretical at the moment. But right now, it's still mainly the adrenaline pens. Fine.
Brilliant. Thank you very much, Anthony. Thanks. Perfect. So next, we have Chetan, who is the PEC at North Middlesex and also honorary nephrologist for the hypertension service at Evelina, who's got 2 talks, one on ECGs and one on hypertension. So I think we can crack on. That would be great. You okay?
Thank you, Kirsty. I will very quickly just share my slides and crack on. Are you able to see this?
Perfect. Yes, thank you.
Thank you. So yeah, thank you for a kind introduction, Kirsty. So yeah, and as we said that because Kirsty, you yourself are a very popular PEC. So if there's anything that you feel is wrong, please pitch in. So yeah, let's start with this, guys. I just want you guys to very quickly go through this QR code to see whether your Menti is working. So if you could just very quickly get this Menti. And only to check, let's start with the first question, which is, why do you guys do ECG in children? My request would be that you guys, because you will be seeing the questions on your phone, keep the phone ready so that we answer, and we won't wait for everyone to answer, but we're gonna go with something. So let's have a look where we are going. So we are going with this kind of word graph there. You could see chest pain, palpitation are the top ones coming, syncope, arrhythmia. So yeah, well done, well done. Coming to palpitation before chest pain, because the chest pain appeared a bit bigger there. In fact, if you come across a patient with palpitation, it appears that of all the patients that you see, perhaps 15% of them might have some form of arrhythmia, and most of them are going to be SVT. So palpitation has a positive predictive value of around that part. Now this old small, actually it was a conference poster which had shown that we have a lot of inconsistency in how we take history for a patient who comes to us in any for palpitation. Do we ask their family history? Do we really get to the bottom of what is happening and how long has it been happening? So there is need for our history taking to be a little bit better when it comes to palpitation. This is an old paper from some time back, so I hope things are improving, but 10 years now. So, but I guess the amount of palpitation that we are seeing may remain pretty much the same. And only for a visual, quick revision of what happens in the heart, slightly different from muscles, is this rapid depolarization. And I've just written those cations on the other side so that you know that which ones are active, but you could see rapid depolarization followed by prolonged depolarization, which is primarily calcium. And then you have rapid repolarization. So this is how the action potential within the heart muscle works. And if I were to superimpose it on top of an ECG, you could see how the ECG will match to these different events that are happening during the muscle action potential. So clearly, if there are issues with specific parts of these channels which are involved in those influxes of potassium and calcium, then you would see abnormalities on those parts of your ECG, just to keep it very simple. And now coming to chest pain, if I have to present only one slide on chest pain, this is what is going to be, that if you were to have so many patients of chest pain, about 25 to 50% of them are actually musculoskeletal, and half of them are finally idiopathic, so we don't even know why they have. This is followed by respiratory causes of chest pain, which includes pleural causes, pneumonia, pneumothorax, going down to acid reflux and gastroesophageal reflux. I had a lovely talk by Dr. Nayak on that. So, and we are coming down to cardiac, only 0.6 to 1%. So only 1% of chest pains are actually cardiac when it comes to pediatric population. And you do have some risk factors, although, that if a child has got chest pain, but they have a history of a particular problem, then you might think this could be cardiac in the sense if they have had trauma to their chest, if they have previously had cardiac surgery, if they have some form of hypercoagulable state and you're thinking of pulmonary thromboembolism. But you have other things like sickle cell causing sickle chest, and you have other things. So Kawasaki is one thing that would come up here, that if a child has previously had Kawasaki, or if you are aware that they have some form of coronary abnormalities and they come with chest pain, then yes, indeed, your chances of that being a cardiac is much higher. So I would wish you guys to now tell me. So there is a 12-year-old girl who has presented to you with chest pain. Maybe start looking at your mentee, and this is the ECG on that girl. So have a look at this ECG. A 12-year-old girl comes to A&E, examination is normal, and she has chest pain. What do you think? And I'm gonna give you about 15 seconds. I've got timer on here. Let's move on. Okay. So we got about 77, 80, 82 responses going on. Yeah, okay. Let's see the answer. Well done. Very well done. Yes. So yeah, so coming back to this ECG, this is a normal ECG. It really does not show much. You can see the sinus rhythm, which is the lead to right at the base. You could see a normal axis and a transition of QRS from V1 to V6. There are no ST changes, and this CG appears to be normal. The P wave appears normal, and looking at it, the QT interval appears normal. Now, why would chest pain happen in a cardiac situation? You're talking about pericarditis, you're talking about myopericarditis, and all those changes are going to come on the ST and the T segment. So the minute you have chest pain, you're looking at that part of your ECG. Let's try this one. A 15-year-old person has come with fever, cough, and chest pain. So this one has got fever, cough, chest pain. And let's see his ECG. That's the ECG. And this is real ECG. This is actually last week's ECG. Don't go by the quality. It's my camera. "15-year-old, fever, cough, chest pain." And the story actually is that they had this all going through the December time, and the fever and cough settled by the time they came to me. But this was the ECG done at that time when they were having it. Let's go with the answers and see where we are. So yeah, we can see wave inversion comes up very on the top, pericarditis, ST depression. Once again, going back to the ECG, yes, it's showing global T wave inversion. It's showing ST depression globally. So all the leads are showing ST depression and T wave. The minute you see that, you are indeed worried. So I was equally worried about this patient. That 2 weeks back, this is what was going on with you. 2 weeks later, we did another ECG on this person. So when they came to me, this is how the ECG looks. Same girl. You guys want to see the ECG more? Let's go with answers. So it's pulling towards normal and long QTC. Sorry, that's the ECG. So this ECG is a recovering ECG following somebody who had myopericarditis. So you could see that the QRS appears to be slightly ever so wide and it's not very crisp. And then you can see that the ST depression, which was there throughout, appears to have started to normalize, and the T waves have started to come up and have become positive. But there are still areas where the T waves are quite flattened. So if you look at lead 3, you could see that the ECG appears pretty much flat. Even if you look at AVF, inferior lead, you could see that the T wave is not really appearing to be as prominent. So this is a recovering ECG following somebody who had myopericarditis. So yeah, some few of you guys indeed get wide QRS, which is what they are showing. And the ST segment continues to be a bit abnormal, but in light of the fact that this is a second follow-up ECG, so it changes. So history and perspective of why you are doing an ECG becomes very important rather than a spot ECG. This ECG, if you see on the first time, is abnormal. But because I've seen a 2-week back ECG, I feel very reassured that things are improving. 10-month-old child, upper respiratory tract infection, parents have brought, unsettled and crying. That's the ECG. 10 months old, upper respiratory tract, unsettled, crying. Once it hits around 75, 80 responses, I would open it. We got 90 responses this time. Indeed. So yeah, I think the ones, so this is indeed supraventricular tachycardia. But people who have felt that this is sinus tachycardia are not grossly wrong because this child is unwell. However, there are markers which suggest that this is supraventricular tachycardia. And if you look at SVT, the closest differential is indeed sinus tachycardia in a child who is unwell, who is febrile, who is dehydrated, and they are very tachycardic. But the difference between an SVT and a sinus tachycardia at that rate is that there is loss of beat to beat variation, because in SVT, you do not have beat to beat variation. And in some of them, you will lose the P wave characteristic. So here you could see that the P wave is pretty much gone. This is just a very flat, straightforward, a very fast, narrow complex tachycardia beating rate of about 200 to 220. And we have those cutoffs given from our APLS, 180 for bigger children and 200 for 200 for younger infants. Now, SVT is quite common in infancy. SVT can happen idiopathically in children who are in infants who are unwell, who have had milder infections, who are running temperature. Not necessarily it means that they have a aberrant pathway and that it would happen again. However, they indeed need follow-up because you want to make sure that they don't have any aberrant pathway. So SVT is the answer for this one. Coming to the next one. Recurrent palpitation, 14-year-old man. Mother also had palpitation for that sake. However, my slide actually appears to be slightly gone to a neonatal bradycardia type of thing, but so maybe I should just check what's going on. No, so it's okay. We'll skip this one because we can't see that, but it's not neonatocardia. Feel free, give the answer to this one. So this is what you're seeing, 14-year-old man, recurrent palpitations. Mother also has palpitations. And I've just put the circles there for you guys to focus your attention slightly more towards what we are really trying to figure out in this ECG. So coming back to this, ignore the neonatal bradycardia. The options actually are also wrong. So let's move on. Anyways, move on. So yeah, so what this ECG is showing is short PR interval along with delta wave. And this is a classical feature of WPW syndrome. So you could see that this person who was possibly going into intermittent SVT appears to be at the moment not in SVT. So a baseline ECG done in a person who has recurrent SVT helps a lot to understand really what kind of pathway or aberrancy of pathway we are dealing with. Here you could see that there is very short PR, and then there is delta wave. So that tells us about the pre-excitation, which means the delta waves tell that the ventricles have started to contract well before the time. And only to bring this slide here at this juncture to show how these different forms of supraventricular tachycardia with aberrant pathways work. And you could see that there is a pre-excitation going on, which makes the PR interval very short, and you have this upslurring QRS complex going there. And you can have different types in which direction is the current flowing, and there are primarily two types, orthodromic and antidromic, and they have slightly different characteristic within the ECG. Perhaps for an electrophysiologist, it's quite important because this will help them to understand really how the pathway is working and really what do they do about it. And you have two very specific subtypes within the tachycardias, which is atrioventricular tachycardia versus atrioventricular nodal, so AV nodal reentrant tachycardia. So again, slight minor variations in that, but they all will eventually present with to us with intermittent SVTs. Now, some of these bigger children actually have learned the art that whenever they have palpitation, which is SVT, they would do some form of Valsalva maneuver to actually revert their SVT. So they get used to doing that. Now coming to this neonatal bradycardia, which is much awaited. I think neonatal bradycardia is an interesting concept, and that's the ECG. A neonate coming with bradycardia. So you see these babies, somebody has come, this is a neonate, and fairly this is bradycardia. This is perhaps a rate sitting at around less than 60, in fact, at this point of time. So it's a bit worrying, but yeah, so neonatal bradycardia, what do we make out of that? So coming to the Menti. In the interest of time, I will click the answer. So it's hanging between congenital heart block and QTC. Let's go back to the ECG and see where we are. So every QRS complex is preceded by a P wave. So this is not a heart block situation. Now, the only time that happens is if you have, first degree heart block where there is prolongation of PR, but not even this. So this is not a heart block situation. This is actually a long QT situation. So you could see how the T wave actually is so vague and it is slow, flattened, and it just goes on and on. You don't even know where it starts and where it ends. It creates a technical difficulty in measuring it, but it also indicates that the T wave is quite long. And in these patients where you have a long QT and you have bradycardia, the problem is whenever they will become tachycardic, this QT will apparently become more and more longer, and once it reaches the P wave, then you start to have those arrhythmias. So baseline bradycardia in a neonate, always think of a long QT syndrome in them. And so coming to some of these values that may help you, how do you calculate QTC? You do QT upon root of RR to do the corrected QTC. We have some values, averaged values for the ease of understanding, and you have these values, and you eventually land up at a point that in a bigger person, if you have more than 470 for that sake, then you start to worry, or in pediatric age group more than 460. Now, and lower down, you could see how our options of treatment change when we have the length of QT increases. So you could see that at 440, you start to worry, but between 440 to 470, you start to consider what you are supposed to do. Definitely between 470 to 500, you are thinking of options of medication. And once it is beyond 500, indeed, there is a role for medication. And this is very generalized approach. Of course, our patients are very individualized, depends on the symptoms, depends on also on their age. So quite many other factors to be put in. So our role here is to identify, and once we know that they have the longer the QTC, the more worry it is, the more urgent the referral becomes. So 4-year-old child, tachypnea, fatigue, dyspnea on exertion last 2 weeks. I'll just switch on the Menti and we're going to go to the ECGs. That's an ECG. 4-year-old child had come to us Again, a real life patient, tachypneic, fatigued, tired, dyspnea on exertion, couldn't do anything, was at home. And the story was dragging on for some time. And this was the ECG. We are at 19th minute, so we are doing okay with that. Anyone else? Come on, guys. I hope you guys type a bit faster. We'll move on to the results. Thank you. Quite many responses coming. Pericarditis, psychogenic, cardiomyopathy, ST depression, myocarditis. No, definitely not psychogenic. It appears to be very much on the top, but definitely not. You could see that the ECG is quite grossly abnormal. This ECG is nearly heading towards a point where you would think that, oh, are we dealing with a wide complex type of tachycardia, although not just about yet. This is a diffuse myocardial injury, massive ST. You can actually not, you can imagine how depressed the ST could be in the lowest most strip there, that the ST is severely depressed. There's T wave inversion, global myocardial injury. This is myocarditis. So this is a severe form of myocarditis. This child stays at a very high risk of developing arrhythmias at any point of time. So very close monitoring of them, close monitoring of their electrolytes, specifically potassium, magnesium, and calcium. And it is ideal that this person stays in a CCU type of setting, because he appears to indeed have a very high risk of developing arrhythmias. And of course, his heart function is going to be quite poor. So all the tachypnea, fatigue, dyspnea, or exertion adds to the point that he is in severe cardiac failure because of that. So yes, the myocarditis appears to be going up a little bit here. Thank you. 16-year-old, palpitation with fever and had few seizures in sleep. That's his ECG. "16-year-old, palpitation with fever and had few seizures in sleep." Coming back to our answers. Come on, guys. 50 answers. I'm clicking the answer. Spot on, spot on. Yes, this is Brugada. This is a classical ECG of Brugada. I think this is something that we should, once you see it, you would know. Now, Brugada could be considered as physiologically, to some extent, I'm generalizing things, but you could consider that to be an opposite phenomena to long QT syndrome. So you could call it short QT syndrome, or similar type of problem where these patients are they are not bradycardic, and they, like the QTC where exercise causes them to go into arrhythmias, this person goes into arrhythmias when they are sleeping because they are actually having slightly lower heart rate. So it is the low heart rate that causes problem. Although it is well known that it triggers in fever as well. The mechanism is slightly different for that. So opposite mechanisms, rapid repolarization and ventricular fibrillation. And you could see there are different types of Brugada, but really for us, once you have this history of people having seizure-like activity at night time while they are sleeping, or if they have had tachycardias with along with times of stress, specifically fever, then you start to indeed think that you may be dealing with Brugada, and we have different types. And of course, there are some other electrolyte imbalances like hyperkalemia, hypercalcemia, and acidosis that can also mimic or trigger worsening of a patient with Brugada. Collapse at school on sports day. Father also collapsed. He was a keen football player. I think that one is slightly already given. There are arrow marks which will help you to understand really where the focus is. But again, the history, it is always the history that helps you to see the ECG in a slightly better way. Coming to the Menti, wow, 64 responses. See, spot on, yes. This indeed shows features of hypertrophic cardiomyopathy. You could see those deep Q waves in the lateral leads. You could see T wave inversion. So again, the T wave inversion is due to the hypertrophy causing some ischemic effects on the ECG, and the deep Q waves tell about that. So a very typical ECG of HCM, and the history that during the sport somebody collapses, because with hypertrophic cardiomyopathy, the problem is when while you are exercising and the cardiac output has to increase, and if the volume doesn't come in, then you land up having the arrhythmia. So well done. Now, few other ECGs which are not a part of quiz. We need to move on. So you could see a very typical ECG here. This is a hard block ECG. This is a third degree hard block. You could see that there is complete AV dissociation, means the P waves are going at their own happy pace, and the QRS are the rescue ventricular beats which are happening here and there. So they are following their own pattern, and there is no relationship between the P waves and the QRS. Things that we see slightly less often in children, but indeed possible if you were to be dealing with complex cardiac surgeries done with isomerisms of atria, with the univentricular hearts and those kind of things, core triatriatum. That's where you will start to see these atrial flutters and fibrillations. Slightly less common, hence sometimes keeping a bit of revision going on with flutter and fibrillation will help. Flutter is very regular, but the fibrillation is chaotic and all over the place. Children, if they can speak, will say that they might be feeling like butterflies in their chest. Another ECG, interesting one. This child was going into SVT, and you could see he's a bigger child, so the cutoff is 180 beats per minute. He was going into SVT. He was coming off the SVT, and there was a spontaneous recovery to some normal sinus rhythm, back into SVT, back into sinus rhythm. So you could see self-reverting from SVTs to sinus rhythm and back into SVTs. So quite not uncommon to see this. Even sometimes after giving the adenosine, sometimes you see a moment where they revert into sinus rhythm followed by more SVT. You give another one and then they revert. Here there was no adenosine. It's a few seconds worth of trace, which is still showing self recovery and arrhythmia. Even more rarer are ectopics. Are not rare. Isolated ectopics are pretty much present in everybody, but if you have a lot of ectopics, then this is something, and you would see ventricular ectopics within patients. And actually the atrial ectopics are also well known, quite common in neonates, usually has a very good prognosis and settles. But sometimes when you start to see these bigeminous couplets and non-sustained VT, which means at least 3 or 4 ventricular tachycardia, then you do worry, because once you have gone beyond 3, so once you have gone beyond the couplet, which is the middle one, ventricular couplet, which means 2 ventricular tachycardia, you have a very high risk that you will go into a sustained ventricular tachycardia. So if on a 24-hour, if you start to see these couplets or non-sustained type of VTs, then it indeed warrants a referral to tertiary cardiology for further management. So one or two slides, we are 28 minutes, so 1 or 2 slides on how do you actually decide what to do with ECG, when should you do ECG, and how much will it help. And this paper from Glasgow actually says that out of 500 ECGs, only 3 of them finally required long-term follow-up, and 17 of them actually went to the cardiac clinic. So you could see that there is a lot of attrition, that we do a lot of ECG. Nothing wrong, because ECG is non-invasive and cheap, so we should do it. But if you see these red flags, that you have syncope while lying down or sitting, if syncope with swimming, on exercise, or collapse with exercise, family history of epilepsy, unexplained, undiagnosed, or if you clearly see prolonged QTC, then these are the red flags that you're truly dealing with a problem. So the longer the QTC, as we said. So those would be the causes on the side why people on publications do ECGs: syncope, chest pain, seizures, ingestion of foreign some drugs, rhythm concerns, and palpitation. And that brings us to really how do we interpret ECG? You could use within your setup a proforma like that, which will take you systematically from how do you calculate the rate, how do you look at the P waves, how do you look at the P wave axis, then QRS axis, and then looking at STN. So you follow a systematic order to that. And a lot of this is available on internet, so nothing new. You could go on to the form website, or you could go on to ECG on fast track. Some of those websites will give you, and various hospitals may have, or your neighbors might have incorporated such a thing. Or you could go through such a checklist, which will be on the handouts, and you again follow a very logical, systematic order of going through rate, rhythm, P waves axis, PR interval, QRS, and intervals, eventually coming to ST, and then calculating the QTC. So if you have your own system, then you will not forget it. But on that note, I will stop talking and sharing. Happy to take few questions before we move on to the next.
Brilliant. Thank you, Titan. So there's a couple of questions. Just to follow on from what you said, there was a question about cheat sheets for assessing pediatric ECGs. So yes, Trustwide, and I do recommend Life in the Fast Lane. There's a stepwide approach to ECG, and I still use it when I'm still querying like ages and voltages and things like that. And it's a really good learning resource. And there was another thing about ECG sources. I particularly, and have no sponsorship deals, I particularly like REN, Concise Pediatric Arrhythmias, as a book, and I can share the link because it's one that can be kind of read cover to cover if you're not quite as geeky as me, but it's quite good at reading and going through things. So I would suggest that. So looking at, and there's one about AI tools. I'm still a bit dubious, but I don't know how Titan feels about that.
I think the AI is here. Use your AI. Don't go with the computer AI. Is my take. It is the history that is always very important when you see ECG. If you see ECG without knowing the history, you will go wrong.
I think that's the thing. Whenever anyone's interpreting an ECG, it's about why it was done in the first place. So there's a couple of questions. One is about how do you detect an abnormality on ECG done due to a heart murmur in a neonate on a NIPE? What are the common pathologies detected on these ECGs? And I'm sure Chitan has a view on these as I do.
I do have my own opinion on that. In fact, there is no real recommendation that you should do an ECG on a neonate if you are looking for a murmur. Now, classically, if you were to say that, yeah, we are going to pick up a indeterminate axis in the first quadrant and we will make a diagnosis of AVSD. Barring that, I think within neonates, the changes are not there. They are quite generic. The neonates anyway have a very right axis to them. Many babies who are born have gone through stress, so their ECGs may have some abnormalities to a point that biochemically a lot of them might have troponin T positive as well. So I would say ECGs are not very, very helpful when it comes to neonates. Do a good clinical examination, check their femorals, and of course, if it is needed and you are really looking for a structure, then I think we are heading towards an echocardiogram in a neonate. ECGs are honestly not very helpful when it comes to that. But happy to see Kirsty, what you want to say.
So my only caveat is if there is a clinical suspicion and it's about triaging. So say a T21 child, if you do an ECG, there has been a number that I've scanned before they've left the hospital and have shown to have an ADSD. And again, extreme axis deviation out of the normal age. And I think that's really key. The first 7 days, there is all sorts of weird and wonderful changes. So it has to be age specific. But again, every unit will have their own policy dependent on what resources they have. So that's an important thing to say. There are a couple of other ones. Any specific leads better?
Kirsty, I think you are frozen. I am not sure whether we have totally lost you.
So it's any of the leads, Chintan, any specific lead which helps you in ECG diagnosis? Any specific leads better? for
No,
analyzing this?
they all show it's like you are looking at heart from different directions. I think every lead is important. The chest leads versus the limb leads have got slightly different orientation, and it helps us to understand the how the electricity is moving. So if you are just looking for the sinus rhythm, I would say go with lead 2. It is easy. We all understand it a little bit better, but I think you need to look at all the leads. Only then you can understand the axis. Otherwise, no. Every lead is important, and few things are only seen in one particular axis. So we cannot get away by doing one lead, sadly. So we should
Absolutely.
buy Kirsty's book and we should read that.
It's not my book. It's just one that it's my kind of idiot's guide to arrhythmias. And what I would say is for calculating QT, it is really useful to calculate it in lead 2 and V5, and kind of compare and get an average. There's one more question that I was going to ask because you briefly mentioned it. The inheritability of Wolff-Parkinson-White, how do you counsel your patients?
We know that it can be autosomal dominant, but I'm saying it can be, not always it is. So you have penetration. So if there is history that there has been a family history of palpitation, then your suspicions are extremely high. And then you are indeed going towards a detailed assessment first with an exercise test followed by plus or minus EP studies to trigger the pathway. And then so if somebody is very symptomatic and there is his family history, I think I will counsel them that you are possibly heading for a very detailed workup, because we have time. And again, there was a question some time back that you see an asymptomatic child with a slight pre-excitation, what do you do about them? Again, in them, if they are asymptomatic, but if there's family history, I think they will eventually land up having it. So they still there is an indication to keep them under very strict monitoring and perhaps head towards maybe an exercise if not invasive. But yeah, my suspicion goes up when there is family history.
Brilliant, thank you. So we're at just before 1. So I don't know if you want to move on and we can answer the questions afterwards.
Great. Could you see this one, Kirsty?
Yes.
Okay, thank you. So I will just change my hat. This is with me being an honorary pediatric nephrologist and a hypertension consultant at Evelina, moving away from PEC, still close to the heart because it is hypertension, and we talk about pediatric hypertension and its management. Now, clear evidence that hypertension is a problem and hypertension should not be ignored. Big studies done in US, big long-term tracking studies like the Bogulosa heart study clearly shows that if a young person has got high blood pressure, even if it is within normal range, they will be tracking to hypertension later, which means if we are seeing early hypertension or pre-hypertension in young adults, we know that they will become hypertensive at a later age. So there is a problem. And a clear indicator that if you have high blood pressure, then your outcomes are worse, which means if you have any form of CKD, then you have high morbidity and mortality if you are hypertensive and if you have hypertensive changes. And these changes are modifiable, which means if you bring your blood pressure down, then your heart improves as well. So there is a clear tracking that improving blood pressure will improve your outcome, and it will improve your what we call as your cardiac features of hypertension. So biomarkers. Let's start with a poll. Jeremy, if you could help me, what is defined as hypertension in pediatric age group? Blood pressure above 90th centile. Poll has come. So yeah, the questions are written there. Blood pressure more than 95th centile. Blood pressure more than 140/90 in more than 16. And the combination 1 and 2, 2 and 3. So let me know. We go with 5 seconds rule. Thank you, Jeremy. So blood pressure more than 95th centile for age and height centile is a very correct answer. That yes, this is what is well understood in pediatrics. But blood pressure more than 140/90 in more than 16 is also correct. So question answered, the option, fourth option, which is 2 and 3 are correct. The reason for that is we are indeed seeing patients who are more than 16 years. We are seeing a lot of patients between 16 to 18 years these days. Hence, And for them, there is a very straight cutoff line, very much like adults. So this is an adult criteria, 140/90 in outpatient setting. Um, that's for a more than 16, but yes, more than 95th centile for age. Those are the two criteria for hypertension. Coming to, so yeah, so a lot comes from a European consensus for that sake, where a lot of definitions are given, as well as the subsequently I'll talk about normograms. So hypertension is more than 95th centile. You do have stage 1 and stage 2 hypertension, which is beyond 99 centile or beyond 5 millimeters. But really, as long as you know your basic cutoff of 95th centile, it is more than enough. Let's bring poll number 2. True about electronic blood pressure machines. So you all use a lot of electronic machines. I think every ward is full of electronic machines. Every A&E and outpatients are full. They are inaccurate. Electronic machines overestimate. Smaller cuffs overread. Blood pressure more than, Jeremy, if you could bring the poll, please. Blood pressure more than 90 centile. Needs something to be done. All of the above. What do you guys think? The answer is pretty obvious here. Thank you, Jeremy. Absolutely spot on. Yes, all of the above. So electronic machines are not accurate in children. They are actually, most of the machines are not validated. In fact, most of the machines are not validated. In the younger a child, the less likely the machine is validated. Although we all use it just because of the ease of it. But there is really only an occasional machine is validated in people who are more than 14 years and beyond. So nothing validated in babies and children. They all nearly always overestimate the blood pressure, and the smaller cuff will overread. So the smaller the cuff you use, the more will be your blood pressure picked up by the machine. If you would use appropriate size cuff, very likely you will not land up with higher values. And so that is why the safety limit has been set slightly differently, that if you truly have more than 90th centile on an electronic machine, you should check manually, because you expect that blood pressure will be much lesser than that. So all of those answers are correct. How should we know what is the correct cuff? So there is a length to breadth ratio. There is a circumference of 40% that needs to be there. So you need to really go with with what is precisely the cuff size. Now, children come in different sizes. Cuffs only come in fixed sizes, which means nearly never will you be able to fit a precisely correct cuff on a child. So what do? You use the next higher sized cuff, because BP will be overestimated by a smaller cuff more than being underestimated by a larger cuff. So if you are stuck between two cuff sizes, which one to use, go with the slightly larger one. It is always a better option when it comes to electronic blood pressure, or even for manual. However, a sphygmomanometer, which is our manual method, is the most ideal approach to doing blood pressure, and ideally that is what we all should use, at least in the high risk patients. Oscillometric device, which is what the electronic device, they are not really good for anything. And we already talked about rechecking blood pressure by auscultation. Jeremy, if we could have the third poll, please. Normative blood pressure values. It gets higher with age. It gets higher with height. It is more in males than female. It is more in high BMI people. What is going on? So the average normative blood pressure, which means blood pressure within population, so done in schools and everything. So a lot of this data comes from huge big data collection from your schools from Europe, and similarly there is a parallel data collection from American Heart Association, and they also give normative values for American children. So indeed, all of them are correct. As the age goes up, the blood pressure goes up. There is a slight variation between the height. So a shorter child will have slightly low, or allowed blood pressure will be slightly lesser. And there is a bit of variation between male and female. So boys have are okay to have slightly higher blood pressure. And these are the normative values. I've lower down written Lurbe et al. If you go to Lurbe et al, you will easily, it's a free article. It is the European consensus which has come. There are some subsequent milder, some more papers coming out from the same group, but the consensus document is from 2016, so 10 years old, still very valid, still being clinically used, and you use these normative values. And as you reach the 16, these normative values still talk about 16 and 17 slightly differently, just because they had the data for that. However, for clinical practice, once you hit 60, you go with 140/90. Most reliable of diagnosing hypertension, most reliable way to diagnose hypertension: admission and inpatient monitoring, office blood pressure in the clinic, ambulatory blood pressure, home blood pressure monitoring by parents. What would you do if you really want to know, has this child got blood pressure? What is the gold standard for that sake? Anthony's idea of having music is a good one, but we'll think about that. Jeremy, can we have the answers? Okay, ambulatory blood pressure and 3 and 4. Well done, well done. I think yes. Ambulatory blood pressure remains the gold standard. If at all you wish, you have time, and if a patient is clinically stable, then the best option is to have ambulatory blood pressure. However, sadly, the problem again comes that ambulatory blood pressure machines are not validated in young children. Neither will these young children tolerate an ambulatory blood pressure monitor being put onto their arm for 24 hours. So you lose its reliability and validity completely, to a point that less than 6 years of age, we don't even attempt it. And even in slightly bigger children, there is a subset of people who will not tolerate it. So just children with non-tolerance to ABPM, or children who have got, say, complex needs, neuromuscular problems, dystonias, contractures, there the validity of this ABPM goes down. So the next near to ABPM option is that it is still done at home, but it is done by parents. So we have home blood pressure monitoring. Now, in an ideal situation, if parents could do auscultation, that's even better. If a child is bigger, then it might just about be okay to use a validated electronic machine. And for infants and neonates and young children, we have developed a methodology of doing systolic blood pressure using a Doppler device. So you use a Doppler device just to look at systolic blood pressure. So that's the kind of device that we may use. On the left side, you could see this simple Doppler device, and we measure, we give the cuff to them, and parents can they put the Doppler on the radial and just listen to the sound when it appears. So you know the systolic blood pressure versus a straightforward space lab type of ABPM device, which is pretty standard and being used. It indeed depends whether your individual trusts have pediatric cuffs or have service to offer ABPM within the pediatric setup, but a lot of cardiology people do it. So within my working, district hospital working, not at Evelina, but at NorthMed, what we have done is I have just made ties with adult cardiac people so that they could do ABPMs on young children who will be able to tolerate that. And the need for doing this is indeed so important, because you could see that how once we did these home Dopplers and the ABPM, huge number of patients were actually normotensive. So you could see this red bar when we did it using ABPM, or when we did using the home Doppler machine given to parents, 40% on an average. But you could see in babies and children, 70% of children were actually normotensive. So there is a need for them to have multiple checks, and there is a need for them to have checks done by not professionals, but at home where they are very comfortable by their parents. And that is the only way you could know whether they have hypertension or not. And that brings us to this kind of graph or a table which shows us really how could you could put a value of blood pressure into 4 different categories. You could have a blood pressure being normal at home and being normal in clinic, which is true normotension. But if the blood pressure is abnormal in the clinic but normal at home, then you call it white coat hypertension. And you could see half of the patients are white coat because their blood pressure is higher in clinic than at home. You have true hypertensions where they are abnormal at home as well as they are abnormal in the clinic. And you are left with still a very rare subgroup of patients who have sadly got normal blood pressures in the clinic but higher blood pressures at home. And this phenomena is slightly less understood in pediatric population, but there is indeed a 10% chance of that. So knowing that their blood pressure is very normal at in the clinic does not always rules out hypertension. If at all you have a very high suspicion that they have hypertension, say if they have end organ changes, LVH, eye changes, symptoms of hypertension, but clinic blood pressure is normal. Usually this phenomena is seen more in patients with chronic kidney disease who are on dialysis, and also I would not worry you guys with that subgroup too much. What is clinically more important? Systolic hypertension, diastolic hypertension, both are equally important. Nothing is important. Thank you, Jeremy. Okay, both are important. So systolic 25, so it's kind of gone slightly equal split that way. In clinical practice, it is the systolic hypertension which is more important. So and the reason why a lot of you guys have said both are important because that is how adults are being managed. Because within adult subgroup, adults primary hypertension group, it is the diastolic blood pressure that parallelly goes up along with the systolic. So both systolic and diastolic becomes very important. However, in young adults and in pediatric age group, it is the systolic blood pressure because most of them do not have diastolic hypertension. So clinically, if you wish to be guided, as long as you understand systolic blood pressure, you are more or less okay. Which is why our use of this Doppler device to just get the systolic blood pressure works equally well because we are only focusing on their systolic blood pressure primarily. If you have the information, not bad, but it does not help us that much. Systolic hypertension accounts for most childhood hypertension. You could see 80% of children who are hypertensive are isolated systolic hypertension, and the systodiastolic and the isolated diastolic one goes down and down and down. Systolic hypertension accounts for most untreated hypertension. So in adults also, the when you talk about hypertension and if you talk about the risks of cardiac events, cerebral events, it is all associated with systolic hypertension. And currently, the medications that we use based primarily on their systolic blood pressure. Of course, we would also look at the diastolic component, but our decisions are much more guided. So the weightage given to systolic is much. You could go through a lot of history taking, and I think once again, being a clinician at the core of my heart, I think history taking and good examination, there is really no substitute to that, be it ECG, be it hypertension. You wish to know their antenatal scans. If you're talking about a young child, you want to know about perinatal events, umbilical lines. Have they had AKIs? Have they had urinary infections that could cause scarring? And you are heading towards this unhealthy lifestyle, which is much more a primary hypertension type of thing. Unhealthy lifestyle, excess weight gain, salt intake, history of cardiac and endocrine involvement. So cardiac for coarctation and endocrine for various things like hyperthyroidism, Cushing's-like features, drugs being used, long-term steroids. Are you thinking of a tumor, and time and again we land up having a tumor causing hypertension, or you're dealing with syndromes like classically Williams syndrome, neurofibromatosis type 1 who have vascular problems, middle aortic syndrome, renal artery stenosis. So you're going towards rare and cool stuff, but common things commonly. What are the effects of hypertension? Most of the times, nothing. Most of the times, patients don't even know. But you see their unhealthy lifestyle and you start to worry whether do they have hypertension. Some of them can have vague headaches. Some of them can have chest discomfort. Some of them may have epistaxis. But nearly always, they would have attended hospital or healthcare professional like a GP for an unrelated reason, and their blood pressure would have been high. But then if you have accelerated hypertension, malignant hypertension, you can indeed have very a lot of symptoms, right from tremors, vision loss, seizures, cardiac failure. Bell's palsy again is well known that patients that come with Bell's palsy, which is due to hypertension. So if you see any of those, then please do check their blood pressure, and please check it few times, because they have come to A&E, they are having their blood test done. These children are quite anxious at that time. Their blood pressure are always going to be high. So how do you then differentiate whether this is high because of A&E or whether truly they are hypertensive? So you have to eliminate the white coat effect before you start to understand their blood pressure. Jeremy, if we could have the sixth poll, primary versus secondary hypertension. Young children have lower risk of primary hypertension. Young children have more secondary hypertension. Age has got no link to the cause. Age increases the risk of secondary hypertension. 1, 2, 2, 1, all the options. Thank you, Jeremy. Thank you, Kirsty. So yeah, the younger a child, the less likely they have secondary hypertension. And as people start to grow in age, primary hypertension becomes more and more common. In fact, even at 8 or 9 years of age, primary hypertension is fairly high. If you look at US data, then by 8 or 9 years, the main cause of hypertension becomes primary hypertension. So quite saddening, but it's no different in Europe and UK. So look out for hypertension, primary hypertension, even much earlier. So by 8 or 10 years of age, but younger than that, a lot of it is actually secondary hypertension. Only to show you this scary graph that, as you could see, that from 1994 beyond, and this is still only 10 years back, so you can imagine where are we going. Every age group, male, female, the graph is going up when it comes to BMI. So within the UK population, young children, our own kids, the weight appears to be a problem, and huge amount of common population, school going children are actually will be classified as overweight and obese. So up to 40% can be classified as overweight at this point of time. So a massive burden of high BMI within UK population. And clearly, if you have high BMI, then your risk of having hypertension is quite high. You could see that how normal BMI keeps you into normal blood group type of bars, but as you go towards high BMI, then you are into pre-hypertension or hypertension. So you could clearly see that the more BMI you have, the more you likely somebody will have hypertension. And this is our coming back to the primary secondary. This is our own south of England and south of London data. You could see how the secondary hypertension in less than 6 starts to balance itself by about 12 years of age, and beyond that, secondary and primary hypertensions are pretty much similar. However, the white coat hypertension still remains somewhere around 20 to 30%. So we talk about various secondary hypertension as causes, and there are renal causes, infection, glomerulonephritis, and vascular, renovascular causes. But do not forget coarctation, and you can see coarctation even at a later age. Every few months we'll end up picking one. Pain is an important cause, which is quite an interesting one, that children with appendicitis, fracture of their arms while playing basketball, come to A&E, their blood pressure is extremely high. But do think of malignancy, do think of whether they are on medications, and do think if there is an association with obstructive sleep apnea. So if you have hypertension, you have OSI, and OSA can actually trigger more hypertension. So think about those things as well. But so what do we do? There are 1,000 causes, but what do? You go with a pragmatic approach. Think of renal function first. Think of electrolytes, urine protein creat ratio, or albumin creat ratio. Think of early ultrasound of abdomen and kidneys to look if you are dealing with a renal problem. Thyroid is commonly done, and it is not very pricey. And also consider, in a young baby, consider echocardiogram. And you could do those other high risk factors in somebody who has high BMI. So looking at their lipid profile, their glucose tolerance, and all those could be done. And the second line investigations, right from complements to MIBG scan to Dopplers or angiography can be done in a very much more selective group. In fact, we would do Dopplers only after we have reached second antihypertensive. So we try to reserve even the Dopplers. We start with antihypertensive one. Once we reach maximum dose, then we do the Doppler and start them on the second dose. So we know that renovascular hypertension usually will not get better with one medication. So very quickly, cola colored urine coming, treatment of hypertension. What would you use if somebody has post-streptococcal glomerulonephritis? An ACE, CCB, diuretics, beta blocker. So not uncommon that we all see within our district hospitals and level 2 type of care, children coming with post-streptococcal glomerulonephritis or some form of glomerulonephritis, and they have. So what are our choices of antihypertensive? Thank you, Jeremy. So ACE inhibitors, CCB, diuretics, beta blocker. ACE inhibitor is not a very wrong answer because the driver is renin. However, in reality, if you have post-streptococcal glomerulonephritis, you need to consider all the options, because if somebody is having oliguria and they are edematous, then ACE is not the option, then diuretic is an option. And after that, you could think that, oh, they are in a phase where you have done a lot of diuresis, you need vasodilation, so you can use calcium channel blocker. So my initial options are diuretics and calcium channel blocker. And only when you find persistent hypertension in a child who previously had PSGN and they are in recovery phase, but they continue to have hypertension, you could indeed think of ACE. Whenever you think of ACE, even if there is any other obvious reason like PSGN, I think making sure that you're not dealing with a renovascular or renal artery stenosis is an important one, because if you use ACE in a very unilateral renal artery stenosis situation, then you run the risk of you rapidly bringing that function down of that kidney. You may lose that kidney. So I would always avoid an ACE, but start with a rather slightly more antihypertensive, which is slightly more safer. But in a PSGN fluid overloaded situation, even diuretics will work. So think about the etiology of hypertension before choosing the antihypertensive. I know we are touching time. I am Kirsty. Treatment of an incidentally found hypertension. In a high BMI situation, weight, salt, exercise, calcium channel, beta blocker, ACE inhibitors comes again. Now, I think ACE also comes because within adults, it's quite common to use ramipril as your first line antihypertensive. So quite commonly used. But then these days, combination of diuretics and beta blocker also is working. So it keeps coming in fashion and going. But what do we do in pediatric age group? Hypertension, primary hypertension, high BMI situation. Jeremy. Weight, salt reduction, absolutely spot on. 3 months to 6 months of a very dedicated salt moderation, I would call it. Weight and lot of exercise, healthy lifestyle, cutting down screen time, wearing your trainers, getting out of the house, that is what will help. And if that doesn't work, then you have option. The bigger age, in much more bigger young people, even a slow acting beta blocker like bisoprolol may be a good idea. But calcium channel blocker to begin with is perfectly fine equally. So coming to the last few slides, non-pharmacological methods, very, very important. I think that is where we are missing the trick, that 40% of our children are sitting at overweight category and we are trying to use pharmacology to control their blood pressure. The problem is overweight. That needs to be tackled. So 3 to 6 months of very dedicated lifestyle modification, aiming to bring the BMI down to 85 percentile of whatever age they are or below that. Salt moderation, exercise 40 minutes 5 times a week, which means daily for 40 minutes. That's what we are aspiring for. And reducing this sedentary life. And only when you go to this hypertensive crisis where you immediately need medications, and that is always titrated once you spoken to your PIC team and all, and you can be thinking about IV infusions, labetalol, nitropicide, but really those are very, very small subset of population, and we really once in many years you will land up it. But SNP, labetalol, and hydrazine becomes your, and long term you could leave with your tertiary deciding calcium channel versus beta blockers versus ACE. Those are the options. ACE and ARBs work pretty similarly, but if somebody has more cough, then you use ARB. But and then you are heading towards alpha and diuretics. if they are uncontrolled on your initial. So take home messages: hypertension, obesity, unhealthy lifestyle, excess salt, everything is on a high, guys. Come on, let's do something about it. Hypertension is associated with long-term morbidity, so let's not ignore it. Control of blood pressure improves outcomes in every aspect of health, so please let's focus on it. Out of office blood pressure monitoring is very crucial in not just diagnosing but also treatment of. So ABPM is quite important and helpful, staying to be the gold standard. But if not, home blood pressure. Secondary hypertension has a very wide, but don't go wild testing too many things. You can take your history and then decide on what you do first and then subsequent. So just make your first line, second line. Avoid unnecessary investigation in these little kids. More bloods means more pain means more hypertension. Lifestyle modification once again is paramount in management of primary hypertension. And pharmacotherapy, I would just leave it at it. Just needs some careful consideration because the cause is salt and excess weight. Let's focus on that and avoid ACE. That's my bottom line. Avoid ACE and ARB till you have ruled out renovascular hypertension. Some of the references, and that's my email. I'm going to stop sharing my slide.
Thank you, Tejan. That was brilliant. We've run a little bit over, so I think maybe one question, and I think this probably is quite a good way to summarize it all. Somebody's written, when should we start treating with medications in pediatrics?
If you're talking about acute hypertension, then it needs to be treated because you got acute severe hypertension or malignant hypertension. There is really no time. However, if you're talking about a cold situation, then you try non-pharmacological methods in a primary hypertension. If it doesn't work for about 3 to 6 months, and if you have end organ features, so if you have LVH, if you have vascular changes within eyes, then you do want to treat it while you are instituting all your unhealthy lifestyle and trying to improve that. So you have a two-pronged approach. And in between patients who have got renal scarring and secondary hypertension, again, you need careful consideration, and you perhaps need to start antihypertensive while you figure out what is the cause and how do you. So two parallel things you are doing. You're managing blood pressure, you're trying to find the etiology. If you find the etiology and if you can cure the etiology, focus on that while you're managing the blood pressure. If the etiology is gone, very likely the blood pressure will get better.
Perfect. Thank you very much. So Akshay, over to you. Thanks.
Kasi, Chintan, thank you. Thanks a lot. We will come back at 1:30. Chintan, if you could just answer the remaining questions. I've also sent the feedback form to all of you, the emails which you've used to register. So please, in the lunchtime, start filling the feedback. It's just giving points marks. So it's very important for us. And then for the next talks, as the talks go, you can start filling the feedback. And let's come back at 1:30. Thank you, everyone.
Welcome back to our afternoon session after lunch. It's my great pleasure to introduce Dr. Jinpei to you all. Dr. Jinpei is a pediatrician at Royal London Hospital, and actually he's the one who started and manages the Q Clinic at Royal London. So he'll be talking to us about obesity. Over to Jin.
Hi, thank you very much for that introduction, Chintan. So let me just get my slides up. Can everyone see that?
Yes, I can see
it. Okay. So right. So let's make a start. So I'm, as Chintan's kindly introduced, I'm Dr. Jinpei. I'm a consultant pediatrician with an interest in disordered eating. And I'm also the clinical lead for the Northeast London Q service. Today, I'm going to talk about childhood obesity with an update on medical and surgical treatment options. So we'll start with this slide that gives the clinical definitions used to interpret BMI centiles in children, which allows us to use BMI in children over 2 years of age as a screening tool for under or overweight. The scope of the problem is immense, with over 2.5 million children in England being affected by this issue. And we've already seen from some of the other talks earlier today, talk about how obesity impacts on so many different aspects of our health. And this slide illustrates the NCMP data from 2024 and 2025, with over 1 in 10 children in reception being obese And this rises to more than 1 in 5 children by the time to get to year 6. That's really, really worrying. Now, we're going to have a few interactive slides, so please use this QR code to join from your mobile phones. You can also join on your browser using the web address on screen. I'll give people a couple of seconds to do that, and then we'll move on ahead. Okay, so oops, let me just redo that. Okay, so what's the trend of childhood obesity compared to before the pandemic? I might just open that a little bit to give people, that's quite short, sorry. In case anyone wonders. Yep. So absolutely, as practically everyone, well, everyone has said basically that it's on an increasing trend. So if we look at this slide, which now gives you the comparison between 24-25 and 23-24, you can see that there's been a little bit of stability in the year 6 group, but worryingly, the rate of obesity in the reception group has started increasing quite rapidly again. As you can see, the obesity group in reception has increased by almost 1%. And compared to when just after the pandemic, actually it had dropped a little bit, and we can see these trends in the next few slides. So this slide shows the reception year. So you can see basically that it had a high in which was probably slightly artificial during COVID. It had come back down to around the same, but slightly more than where we was before COVID. Dropped quite significantly after that, but then in the last couple of years has started climbing again, and it's actually climbing quite quickly, which is really, really scary. Looking at the year 6 group, you can see a similar trend where it was really high in COVID, started coming down, and it's actually sort of stabilizing a little bit. And the last couple of years, it's been similar. So now the next slide, I like us to think together about the challenges we face when we're trying to manage childhood obesity. Sorry about the timer, it's quite short. I'll just keep opening it again so that people can continue. So we can see quite a lot of different things and there's a huge number of different challenges, isn't it? Basically, we've got poverty up there, we've got processed food, resources, diet, compliance or non-compliance, family breakdown. And I mean, I think I'm really pleased to see that people are thinking really widely. There's a huge range of different things that makes it challenging in managing childhood obesity. So this slide illustrates the myriad of factors that cause and perpetuate obesity, which helps us understand the underlying factors that cause the challenges we already identified. This is essential so that we're able to manage obesity in a way that produces sustainable improvements. One more slide here. So what are the management options that you know for managing childhood obesity? Open for a little bit longer. So we can see there basically things like exercise, dietetics. We've got some people mentioning medications, support. So motivation, try to see family healthy courses. Yeah, so basically there's obviously quite a lot of different options. And actually, none of you are wrong, basically. It's actually going to be a combination of all of things. There's not one thing that works, but it comes across from all the different things that you've all put out. So to be effective in the longer term and for it to be sustainable, we need to tackle childhood obesity through a whole systems approach, starting with education, lifestyle modifications, and getting patients and their families the support that's often required from services in their local community. In more severe or complicated cases, medical management, as in with medications, may be considered. So let's talk a little bit about medications. So the latest NICE guidelines that was updated last year advises that drug therapy is still not really generally recommended, especially for those under 12 years of age, apart from for patients with obesity that's already complicated by comorbidities, who are managed under a specialist MDT that can provide holistic interventions, as drugs should always be used as an adjunct to sustainable lifestyle modifications. In the past, drugs have shown poor efficacy, often due to poor compliance, but the newer GLP-1 agonists are showing better outcomes in patients who do respond. We'll look at a few options available these days in the next few slides. So most of you will already have heard of Orlistat. We don't really use it very much, but it's been around for quite a long time, and it is licensed in over 12s for weight management. However, steatorrhea and abdominal pain caused by the lipase inhibiting effects often cause patients to stop taking it, especially those who have not reduced the fat content in their diet. Those who are able to persevere will need to be monitored for fat-soluble vitamin deficiencies. Metformin is another drug that's been used for a while in obesity, particularly where there is insulin resistance. And it can be particularly effective in those with dysglycemia as well as fatty liver disease. Unfortunately, like Orlistat, compliance is often poor due to the common initial GI side effects, and vitamin B12 deficiency can be another side effect due to malabsorption. Rare but severe complications include lactic acidosis and hepatitis, and it should be used cautiously in those with renal impairment. Now, everyone will by now have heard of the GLP-1 receptor agonists, liraglutide and semaglutide, or more commonly known as Saxenda and Wegovy, respectively. They act by increasing satiety and reducing central hunger signals. This is important to bear in mind, as it may not work as effectively in those where eating is driven by other factors. Examples of this would be things like Prader-Willi syndrome, emotional or binge eating, or autism. Both are now licensed for weight management in over 12s with severe obesity, but only in conjunction with specialist MDT support to facilitate lifestyle modifications. This is because studies show gradual regain of weight once GLP-1 agonists are discontinued, hence the need for sustainable lifestyle modifications to maintain and build on the weight loss that was achieved on medications. This is probably true for any weight loss intervention anyway, but in the case of GLP-1s, adequate physical activity is also crucial to mitigate one of the risks, which is muscle loss during the weight loss period. Side effects are more common while the dose is being titrated up, but symptoms usually improve if you persevere. A rare side effect is pancreatitis, which may necessitate stopping treatment. As mentioned, this graph illustrates the efficacy of Wegovy, but also the trend towards regaining some of the lost weight once it's stopped. However, within the Q services, we have seen patients with resolution of their complications, such as diabetes, obstructive sleep apnea, fatty liver disease, and other things like idiopathic intracranial hypertension as a result of the significant reduction in BMI that was achieved on GLP-1s. There's therefore little doubt that they can be effective in reducing BMI and improving health outcomes. The main question now is at what long-term cost, because basically, actually, we are seeing that a lot of patients do regain their weight. So do they have to be on them for the rest of their lives? And if we do stop the GLP-1s, are those outcomes sustainable? Not just the weight loss, but also the improvement in their complications. I think that's still something that we don't have enough evidence, particularly in children and young people yet. Now, most of you will also have heard of tirzepatide, which is more commonly known as Mounjaro or Zepbound. This is a combined GIP and GLP-1 receptor agonist that acts to increase satiety and reduce central hunger signals, as well as increase insulin release. Adult studies have shown an even better efficacy for weight loss compared to Wegovy, but is currently still in the trial phase for children, so unfortunately not available as yet. And if our experience with liraglutide and semaglutide is anything to go with, it may be a while before it's readily available for prescribing in the pediatric population, on top of the other risks and unknowns already mentioned earlier. Other medications on the horizons are the oral versions of GLP-1s to make them more easily used, as well as other multi-receptor agonists like tirzepatide that are being touted to have even more efficacy in terms of weight loss. Next, we'll talk about surgical options, which have started becoming more popular in the pediatric population, with increasing cases of children who go overseas to get this done. However, in the UK, a comprehensive specialist MDT assessment is always required before bariatric surgery takes place. Bariatric surgery may be considered only in patients with severe obesity, especially if they've got significant complications that are likely to respond to weight loss. Patients should have already achieved physiological maturity, as the rapid weight loss from surgery, which can range from 13 to 16 kilograms per meter squared of BMI, is likely to impact on growth and pubertal progression if this is not already complete. Surgery obviously has its own risks, including anesthetic and perioperative complications, gallstones, and loose skin from rapid weight loss, as well as vitamin and nutritional deficiencies. It's also important to be aware that up to 10% may still fail to lose weight or regain weight despite successful surgery. Finally, all patients who have undergone surgery need to be followed up in the longer term. So, gastric banding used to be very popular, as it is a reversible procedure that places an adjustable band around the upper half of the stomach, which creates a smaller stomach pouch that causes fullness with a smaller volume of intake. The tightness of the band can be adjusted by injecting saline into a subcutaneous port. It was initially popular due to the fact that it could be done laparoscopically and was reversible. Complications include slippage, deflation of the band, which could also cause erosion, and reflux, dysphagia, and nutritional deficiencies. More rarely, the pouch could become dilated or necrosed. Additionally, gastric banding proved to result in lower BMI losses compared to the other more popular procedures. And along with the relatively high rates of complications mentioned earlier, this has caused it to be rarely used in the UK now. Roux-en-Y gastric bypass surgery is where the upper portion of the stomach is separated and joined up to the jejunum. This not only creates a smaller stomach pouch, but also bypasses some of the small bowel, reducing absorption of nutrients. This often results in a higher amount of weight loss, but also a higher risk of nutritional deficiencies. As you can imagine from the way the surgery is carried out, this is completely irreversible and will require lifelong monitoring and often supplementation to avoid chronic deficiencies. Other complications include dumping syndrome and anastomotic complications, and this procedure is now less often used as well due to significantly higher risk of complications compared to other procedures. Finally, we have sleeve gastrectomy or gastric sleeve surgery, where the majority of the stomach is resected, leaving a sleeve approximately the size of a banana. This limits the volume of intake, but also induces hormonal changes that reduces hunger signals that can help reduce appetite and cravings due to loss of significant amount of gastric tissue. As all other structures of the stomach are preserved, particularly the pylorus, the other functions of the stomach are unaltered. Like gastric bypass, this is an irreversible procedure and can also result in nutritional deficiencies and dumping syndrome, apart from the anesthetic and perioperative complications. However, gastric sleeve surgery is now becoming the most commonly performed procedure in pediatrics due to the fact that it is simpler, faster, and safer compared to the other procedures. So, although as pediatricians, most of us may not be initiating drugs or surgical procedures for obesity, a crucial role we play involves identifying the patients who meet criteria, including finding the ones who do have significant complications and who may benefit from these interventions, allowing helpful discussions to take place and referral to specialist services such as the Q clinics or bariatric surgery. I've included the general referral criteria on this slide for your convenience. In summary, childhood obesity is still a significant issue despite returning to normality after COVID. There are new pharmacological options to help manage obesity, but these are currently only available to some specialist services, and there's significant risk of relapse once medication is stopped. Bariatric surgery is becoming more accepted and can result in significant weight loss, but the safest procedures are irreversible and require comprehensive assessment as well as long-term follow-up and monitoring. That's the end of my talk. Thank you very much.
Amazing, Jin. Spot on time, well on time. There are a couple of questions. Let's take them. So there's a question from Ian about centers in London where we can access GLP-1. And another very similar line question from Alexandros. Who really prescribes these GLP-1? Can I prescribe?
Yeah. So, well, if you can get permission from whoever funds your prescribing, then you're obviously welcome because it's licensed. However, certainly at the moment, even within the Q clinics in London, none of us have managed to get basically permission, if you'd like, from either our trust or from the ICBs to be able to prescribe GLP-1s. Unfortunately, it is still a bit of a postcode lottery. There are select Q clinics across the country, for example, Southampton and Bristol, who have managed to get funding for this, and the funding comes from the trust and or their ICBs. But at the moment, it's still a bit of an uphill battle. So that's what I was hinting at during the talk, that it's not still easily available.
Okay. Maybe, Jin, no more questions here. So lovely talk, very informative. Maybe a question from my side. Knowing the volume of the problem, and we have always had these difficulties in getting a patient across to the Q clinic because of the set criteria. Really, is there a leverage there? Are we looking in future to have more clinics across various hospitals? Are we going to decentralize the system? Because clearly the demand is much, much, much more than the supply at this stage.
No, you're absolutely right. And I mean, I can't obviously speak for other regions. Within London, we are exploring with the ICBs about basically a more sustainable approach, because basically, obviously, the Q clinics were initially started out as a pilot, and hopefully we can demonstrate that they are effective, and we can hopefully then cascade some of the learning to then enable actually other clinicians within the area to start practicing in a similar way. But we obviously it will take a little while to get all these things set up, particularly from the funding perspective. But it is certainly something that we are wanting to explore.
Perfect. Thank you. Thank you, Jin. Thanks a lot for a lovely talk.
Thank you.
Thank you. I will see you later. And this actually brings me to introduce Evelyn. Evelyn is an endocrine consultant at Royal London Hospital, and Evelyn is going to talk about type 2 diabetes to us. And please, Evelyn, enlighten. Evelyn's talks are always power packed, so let's crack on.
Thank you very much, Chintan. So let me share my presentation. Oh, oops, sorry.
Yep, coming through nicely.
Yeah. There we are. So yeah, my name is Evelyn Gievers. I'm a consultant pediatric endocrinologist, and I see children with endocrine disorders, but also with diabetes and type 2 diabetes. So I think my talk follows on very nicely from Jin's talk, who has set out the real problem with increasing obesity rates. And we look after the fortunately still small sub-cohort of those patients that have type 2 diabetes as a complication of their obesity. So I'm going to talk about epidemiology and outcomes of type 2 diabetes in young people, how the presentation usually is, how we manage type 2 diabetes, talk about old drugs and indeed new drugs, including the GLP-1 receptor agonist, and talk a little bit about complications, all on the background of the NICE guideline for type 2 diabetes that came out in May 2023. So indeed, unfortunately, the incidence and prevalence of type 2 diabetes in young people is increasing. So the number of children with type 2 diabetes in England and Wales has increased from 810 in, sorry, let me just, yeah, from oh, hang on. Sorry, I'm not sure. there we go, has increased from 810 in 2019-2020 to 1,500 in 2023-2024. And we know that quite accurately because there's been a spotlight audit from the National Pediatric Diabetes audit, which is run by the Royal College of Pediatrics. So we can compare those two cohorts, and that has shown that the prevalence has increased from 4.5 per 100,000 to 7.7, and incidence has increased from 1.7 to 2.5 per 100,000. So in total, that's an increase of 80% in about 5 years. So that's enormous indeed. So for comparison, the incidence of type 1 diabetes is about 25 to 30 per 100,000. So type 2 diabetes is still a rare condition, fortunately. So this on the left shows the total number of patients over the years, and you can see that there unfortunately is not an indication that it's slowing down. Also, if you look at the number of new patients per year, you can see that there was a spike indeed around the COVID time, and then it reduced a tiny bit, but then after that it increased again. So no evidence that it's slowing down. Here on the right, you can see the age of the patients that we're looking after in 2023, 2024. So the median age is 15, and type 2 diabetes is more common in girls compared to boys. You can see that the number of young people over the age of 15 is slowly reducing, and that is because of transition. There's no set age for transition to adult teams. Some teams transition at 16, other teams at 19. So this is an important slide. 85% of people with type 2 diabetes have a family member that has type 2 diabetes. 60% of them have a mother who has type 2 diabetes, and 35% have a father who has type 2 diabetes. And that's very important to keep in mind, because very often families are already used to a diagnosis of type 2 diabetes in the family. They very often think that it's not that important. They just take metformin or are on a diet, and that's all that's needed. However, what's often forgotten is that parents may live with type 2 diabetes for 15, 20 years, but that young people, if they're diagnosed at the age of 15, 16, may live with type 2 diabetes for a much longer time. And also we know that type 2 diabetes in children and young people is much more severe than in adults. Treatments are also different for children compared to adults. So therefore it's important to emphasize that to the families, because otherwise they will underestimate the importance of the diagnosis. So this slide is also really important and shows why we are trying to treat type 2 diabetes aggressively. So this slide shows on the left for females and on the right for males what the reduction in lifespan is after diagnosis of type 2 diabetes. The different colors indicate what age you were at when at the diagnosis of type 2 diabetes. So the highest blue line is at the age of 30. And then on the horizontal axis, you can see the age at risk, and the vertical axis, the number of years lost. So if you look at the left, the highest line, so if you are diagnosed with type 2 diabetes at the age of 30, when you are then 40 years old, so 10 years later, you have a life expectancy that is 16 years less compared to population without type 2 diabetes. So that's enormous. And so and for males, it's very, very similar. It's a little bit better. It's 14.5 years. But that is when you're diagnosed with type 2 diabetes at the age of 30. So let alone what your reduction in lifespan is when you're diagnosed at the age of 15. This shows how soon complications occur in young people with diabetes. So this is a study of 500 young people with type 2 diabetes that were diagnosed before the age of 18 and were previously in the Today study, which ran a long time ago, and the 500 patients have been followed up until a median age of 26, when they had type 2 diabetes for a mean time of 13 and a half years. And what you can see here at the top left is that after 10 years, 50% of those patients have hypertension. After 15 years, 50% have nephropathy. After 13 years, 50% have dyslipidemia. And after 15 years, about 30% have nerve disease. So if you're diagnosed at the age of 15, by the age of 30, 50% will have at least hypertension, nephropathy, and dyslipidemia. So at a very young age, you'll have multiple comorbidities. So then going on to the diagnosis of diabetes. So diagnosis of diabetes is not different for type 1 diabetes or type 2 diabetes. It is a fasting plasma glucose of 7 or more, an oral glucose tolerance test that shows a plasma glucose of more than 11.1 after 2 hours, or an HbA1c that is more than 48 millimole per mole. If you have symptoms, then that is sufficient for a diagnosis. If you don't have symptoms, then you need to show one of these again on a different day. What's really important that if there are concerns with diabetes, you need to do, the healthcare professional needs to organize a finger prick test, point of care test on the same day to assess the blood glucose. If you don't do that, then you run the risk, both in type 1 and type 2 diabetes, for diabetic ketoacidosis or hyperglycemic hyperosmolar state in type 2 diabetes. Once there is a diagnosis, then you need to differentiate between type 1 diabetes and type 2 diabetes, and that is based on signs and symptoms, biochemical investigations, family history, and clinical progression. So looking for acanthosis nigricans, which is an indication of insulin resistance, is important, and also assessing of antibodies and C-peptide to an extent. Current guidelines still say that C-peptide diagnosis should not be used to differentiate between type 1 and type 2. So this is a case presentation, call from GP in 2024, 11-year-old girl who had increased urinary frequency, increased thirst, BMI of 41, and 7 days ago had an HbA1c of 80, a fasting glucose of 13, and 14 days ago had a random blood glucose of 13. So that shows that there is diabetes. It also shows a delay. So ideally the GP had done a finger prick and had referred on the day that it was a random blood glucose of 13. Past medical history is typical pregnancy with gestational diabetes. Obesity from early age, premature adrenal from age 6, which is more common in obesity, was referred by the dental hospital to the obesity clinic at the age of 10 when she weighed 85 kilos, but she didn't turn up twice and was discharged. At the age of 9, the GP did an HbA1c, which was already high, although still in the normal range, and therefore was not referred at that stage. There's a family history of type 2 diabetes, mother, maternal grandfather, and maternal aunt. So that's typical. Mom is a single mom. There are financial difficulties. She's in year 7 in school, was bullied. Mom took her out of school 2 days before we saw her. In A&E, she then had a blood glucose of 15, a pH of 7.36, no ketones, and normal sodium and creatinine. She had a BMI of 42. She had high blood pressures in A&E, normal heart rate, normal respiratory rate, and there was acanthosis nigricans. So we made a diagnosis of diabetes, most likely type 2 diabetes, on the basis of history and physical examination. There was no evidence of DKA or HHS, and she potentially has hypertension. So what we admit, every patient that has diabetes, and we assess history, examine, of course, do investigations for new diabetes, which are the same really for type 1 and type 2 diabetes. But for type 2 diabetes, you also include the liver function test to assess whether there are signs of metabolic associated liver disease. If there is a history of obesity before the age of 5 years, then we would also do an obesity gene panel. If there's evidence of diabetes in multiple generations, then we may also consider genetic testing for monogenic causes of diabetes. The main reason that we admit is that we use the admission for education by nurses and dietitians, for psychological assessment, and for consultant discussion with both parents to explain the severity of a diagnosis of type 2 diabetes at young age, to also emphasize that remission is possible with weight loss and exercise, and that's what we aim for, and that really change of lifestyle for the whole family is required, and that we will help the family to achieve that. And we have leaflets for inpatient education, for patients that are started on metformin and for patients that are started on insulin, because that are the two options at diagnosis. Then really important at diagnosis, you also want to assess complications of obesity and diabetes. So assess hypertension, which we can do very easily in hospital. Assess for hyperlipidemia, for a fatty liver, which we don't call fatty liver anymore, but we know called metabolism associated liver disease or steatohepatosis. And we assess for nephropathy with a urine albumin creatinine ratio spot urine, which is often forgotten at diagnosis, but it's important to assess whether already at that stage there is evidence of nephropathy, which is often the case. And also an assessment for sleep apnea, either a sleep study at that time or at a later stage. And also then after assessment, assess whether treatment is already required. So at diagnosis of diabetes and most likely type 2 diabetes, if the blood glucose is more than 33 and there are no ketones and the pH is more than 7.3 and osmolarity is more than 320, then you need to consider, and then there likely is hyperglycemic hyperosmolar state. It's important to recognize that because it has a different type of treatment and is severe and has a high rate of mortality. If there is no HSS and there's no ketosis and HbA1c is below 8.5, then we start on metformin. You start on 500 milligrams once daily. You aim to increase at least by 500 milligrams once a week, but if possible, we often increase a little bit faster to avoid treatment with insulin. If there's ketosis or HbA1c is more than 8.5 or blood glucoses are often above 11, then we do start on insulin. We would start with most commonly with long-acting insulin, but if blood glucose is above 14, we would correct with short-acting insulin. And long-acting insulin is usually started at a dose of 0.2 units per kilo, but really you need to adjust on the basis of the glucose levels. So in our girl with likely type 2 diabetes, who had an HbA1c of 80, no ketones, and a random blood glucose of 15.6, we started on metformin with the aim to increase to 2000 milligram. The advantage of admitting children is that you then actually can observe what the blood glucoses are, and you can potentially avoid long-acting insulin and initially correct with short-acting insulin. And if blood glucoses then improve with improvement of diet with starting of metformin, then you can maybe avoid insulin treatment. We aim to avoid insulin treatment because that makes weight loss harder. And we start everybody on sugar-free drinks, and indeed we start straight away with support and education from dietitian, nurse, psychologist, and family support worker. So what are we aiming for in type 2 diabetes? We aim for an HbA1c below 48, which is the same as in type 1 diabetes. And at the same time, we aim for a glucose before the meal between 3 and 7, or 3.9 and 7 if you're on insulin, and after the meal of 4 to 9. So that's exactly the same as in type 1 diabetes. We also aim for weight loss of 5 to 10% in 3 to 12 months' time, and a reduction of BMI in the long term to below the 85th centile. And we aim for screening for comorbidities and treatment of comorbidities, and that's actually harder than it seems. And the really important thing is to escalate treatment if HbA1c is not below 48. And there's a tendency to try and stay on current treatment and wait until the next time and see whether HbA1c has improved. But experience learns that that HbA1c's often increase and that we need to take action rapidly to get the HbA1c below 48. And so that's also what the NICE guidelines say. So what about glucose and ketone testing? Everybody who is so everybody needs to assess blood glucoses. If the type 2 diabetes is stable and patients are not on multiple daily insulin treatment, then we don't need to test so frequently. When the blood glucose is mostly below 9, then you can test once a week a fasting blood glucose and once a day post meal. And you can choose a meal every day. So very often you would do the lunchtime meal and dinner during the week, because then you do your blood glucose testing at home, and you can do lunchtime in the weekend, which also gives or breakfast at weekend, when you can then also do the blood glucose testing at home, and then once a week fasting blood glucose. If the blood glucose is still often above 9, then you need to test more frequently, and 2 hours after each meal and pre-meals if needed. If you are on multiple daily insulin, so both long-acting and short-acting, then you need to test as frequently as in type 1 diabetes. Continuous glucose monitoring is available now, and we use it in most of our patients. Unfortunately, we have an opportunity to do that, but the NICE guidelines say that CGM is only indicated in all patients on insulin treatment, or those who are unable to do finger prick testing, or those that have severe or frequent hypoglycemia, or those that need to do blood glucose testing more than 8 times per day. In practice, that is actually quite a lot of the cohort, because it also includes all the people that have autism, learning difficulties, and we do see that more often in our cohort of patients with type 2 diabetes. So fortunately, many people can be on CGM. Everybody also needs to get a ketone meter, because if the blood glucose is 14, they're still at risk of developing DKA or hyperglycemic hyperosmolar state. Also, some of the drugs make that more likely, and therefore they need to have a ketone meter. They also need to get hypoglycemia treatment. If they are on insulin, blood glucose is below 3.9, need treating in the same way as in type 1 diabetes. If they're not on insulin, then only blood glucose is below 3, need treating, but that is much less frequently expected if there's no insulin treatment. Hypoglycemia on metformin is very rare, and hypoglycemia on the other drugs is also rare, but not completely impossible. So this is the algorithm from the NICE guidelines for children and young people with type 2 diabetes. So we are able to use GLP-1 receptor agonists, and we use them very, very frequently. But the options that we have are still limited, and indeed the options that are different in different regions. So there certainly is inequity. So everybody starts on metformin with or without insulin here in the box on the left. And what's important as well is that that can be any form of metformin. So either normal tablets, 2 tablets in the morning, 2 tablets in the evening, or slow release, which you only need to take once a day, or liquid metformin. And then there are 2 types of liquid metformin as well. There's the powder that you dissolve yourself, and there's also actual liquid metformin. The taste is different. So sometimes you want to see what suits your patient best. Because of the difficulties with adherence for some people, it is really important that we find a type of metformin that suits the patient. So start on insulin if required, but then reduce insulin as quickly as possible. If after 3 months the HbA1c then is not below 48, then we start liraglutide as the GLP-1 receptor agonist, or dulaglutide, which is weekly. If after the next 3 months HbA1c is still 48, or you still have not been able to wean the insulin completely, then you start on an SGLT2 inhibitor, which is an sodium glucose transport inhibitor, on which I have a slide later. The type of SGLT2 inhibitor in the NICE guidelines is empagliflozin, but we can now also use dapagliflozin, which is the drug that's more commonly used in adults.
We got 3 to 4 minutes, Evelyn. Yeah.
Yeah, exactly. Yeah. So I have discussed that already. So this tells you something about liraglutide, which Jin has mentioned already as well. What is really important to know is that unfortunately the GLP-1 receptor agonists do not give much weight loss in patients with type 2 diabetes. And the trials show that, but not many people are actually aware. There is a reduction in HbA1c, but there is not a reduction in BMI. Only the newest GLP-1 receptor tirzepatide has shown a reduction in BMI, and unfortunately tirzepatide is not yet licensed in the UK for either type 2 diabetes or obesity. So this slide you can read yourself in your pack. That are the other GLP-1 receptor agonists that are available and that are hopefully in the future also available for our patients. SGLT2 inhibitors are drugs that work on the proximal renal tubule on the sodium glucose transporter, and therefore lead to glucosuria and therefore reduce blood glucose in the circulation. They're extremely effective, and they are the first choice for treatment of type 2 diabetes in adults now. The 2 most commonly used are dapagliflozin and empagliflozin. Side effects that you need to be aware of are genital infections. In adults, gangrene has been described of genitals, so you certainly need to warn for that. If there's redness or pain, that patients need to come to A&E, and hypoglycemia can occur. DKA has been described in severe illness and trauma, again in adults and actually not in children, but therefore we give everybody a ketone meter, and parents need to call us if ketones are increasing, and we need to stop if there is severe illness. So this is the pathway that we use for a review of our patients. So patients get seen in the first 4 weeks by nurse dietitian, and then in an MDT clinic, and then are being seen every 3 months by the MDT clinic, and in between ideally by the dietitian. So very, very close follow-up of these patients is required to keep them on track. These are just leaflets that we give to patients to indicate how they are feeling that things are going and to set goals. And this is my last slide, which also ties in with Jin's talk is that bariatric surgery certainly is something that we need to offer and keep in the back of on the forefront of our mind. Unfortunately, many young people don't like the idea of surgery, but indications indeed are BMI over 35 kilo per square meter with complications, and type 2 is a complication, and no effective treatment for the last 12 to 18 months. It leads to remission in many people, many young people with type 2 diabetes. It's actually more effective than in adults. So in these three graphs, you can see adults displayed with the orange line, and children and young people displayed with the blue line. So the weight loss is a little bit less, well, it's similar really. Remission of type 2 diabetes is better in young people, and also remission of hypertension is better in young people. So certainly there is a role for bariatric surgery. And this was a program that came out from Diabetes UK to highlight the fact that type 2 diabetes in young people is severe, and that we should aim for remission and reduction of people that have type 2 diabetes. Thank you very much.
Thank you, Evelyn. Thank you so much to cover in such short time. Well done. Amazing talk. I'm sure people will wish to read a few of the slides with the drugs and all, but excellent talk. I will leave the questions. There are a couple of questions. I'll leave the questions in interest of time. And let's move to Dr. Davison. Thank you. So yes, I would like to invite Dr. Davison James. He will be talking to us about dyslipidemia, quite still a very burning topic these days. So please.
Thank you very much. Can you see my title slide?
Yes.
I'm just checking to put the right thing up. Perfect, good. So, thank you, Jeanton, for the introduction. I'm one of the metabolic consultants at Great Ormond Street, and the topic for the next 20 minutes or so is pediatric dyslipidemia, thinking about diagnosis and management. It's a huge topic. We're not going to cover everything, and we've already heard from the two previous talks a lot of the context for the common causes for abnormal lipid profiles in pediatrics. What I am going to drill down into in this talk is perhaps some of the rarer causes of lipid problems, some of the genetic causes. So what we'll do, we'll have a bit of an overview, first of all, of lipid metabolism, just to set the scene, to refresh again why it is that having abnormal lipid profiles is a problem, what are the issues that causes, think about the diagnostic approach, and then some comments about the primary genetic dyslipidemias. I'm going to talk much less about the secondary dyslipidemias. We've heard a lot about that already from Dr. Pei and Dr. Givers. And as we go through, we'll talk about some of the management approaches that we would consider. So lipid metabolism, what are we talking about when we're talking about lipids? There are different classes of lipids involved in our normal in the normal metabolism. We have the triglycerides, which are the main storage form of fat, so glycerol backbone and 3 fatty acids attached onto that. There are then the cholesterol group of lipids. So the cholesterol, a complex ring structure that's synthesized and then is the basis for a lot of different hormones. And then the phospholipids that have important roles in membrane function, signaling, and many other pathways. Those have 2 fatty acids joined onto a hydrophilic head group with a phosphate in it that's linked onto many other different components. So the biochemistry of the lipids is complex. When lipids are being moved around the body, as they are, from moving them from the gut to the liver to the adipose tissues, as we'll see, they have to have transport mechanisms to be able to move them around. And it is the lipoproteins that are the transport vehicles that help move the lipids around. And there are different lipoproteins. We talk about LDL, low density lipoprotein, VLDL, very low density lipoprotein. The classifications, the different lipoproteins have different densities and different chemical compositions. The structure they have in general is that they have a core that is made up of triglycerides and cholesterol esters. And then around that, you have a layer of phospholipids studied with some free cholesterol, and all of it is held together by the apolipoprotein. So an important proteins that help the function and the structure. The apolipoproteins act as a structural component, but they also act as enzymes in releasing some of the different components and in signaling and receptor functions so that the vehicles can then be trafficked into the right place. The different types, as we've said, there are the chylomicrons, which are the main transport mechanism for moving dietary fat from the intestine to the muscles and to the liver and to the adipose tissues. We have very low density lipoprotein, VLDL, which are secreted from the hepatocytes in the liver, delivering free fatty acids out to the muscle and the adipose tissue. The LDL, which we often refer to as the bad cholesterol, transports cholesterol from the liver to the muscle and vice versa, as we'll see, and high density lipoprotein functioning as well in that transport mechanism. And when we're thinking about the metabolic pathways of where lipids are being moved around, there are three main pathways that are classically described. There's the exogenous pathway, which is moving lipids, the triglycerides and the free cholesterol from the intestines, from the food that is being consumed. It crosses over, is packaged into chylomicrons, which then are delivering some of the free fatty acids into the adipose tissue. And there's an important enzyme, the lipoprotein lipase, that liberates the free fatty acids from triglycerides to be packaged into the adipose tissue. And the chylomicron remnant is taken up into the liver. So that's the exogenous pathway, moving fats from the diet into liver and the adipose tissues. And you'll notice that the different lipoproteins have the different apolipoproteins attached onto them that have those different both enzyme functions and signaling mechanisms. So that's the exogenous pathway. The endogenous pathway describes the process by which the liver takes triglycerides and cholesterol esters, packages them via the MTP protein into VLDL, which then delivers free fatty acids out into the adipose tissue, generating an intermediate density lipoprotein. There is more of the content squeezed out by hepatic lipase, and that forms the LDL cholesterol. And this is a really important one when we're thinking about the dyslipidemias, as we'll see, because many of the defects result in a high level of LDL. LDL can be taken up again into the liver by the LDL receptor and processed, but importantly, LDL also delivers its load into macrophages, and you get an increasing amount of foamy macrophages that are a key part of the coronary artery disease risk that we know has occurred with having a high cholesterol level, and we'll come back to that. And then the third of the main parts of the pathway is the reverse cholesterol transport pathway, which takes fats from the adipose tissue, free cholesterol and phospholipids, which are pumped into the high density lipoprotein, and that then is able to deliver and return cholesterol back to the liver via the SCARB-B1 process and the LDL receptor again. And so this is a helpful pathway in terms of removing cholesterol from our adipose tissue. And as we'll see, a number of the different enzyme steps that are shown here with the red, or the different apolipoproteins, or the different receptors can be faulty in a number of the dyslipidemias. Okay, so why are lipids a problem? Why do we worry about them? Well, high cholesterol, I think everyone knows, is associated with a long-term risk of coronary artery disease and stroke risks. We've seen how LDL cholesterol can load the macrophages with those, which then prompts that inflammatory process causing the arterial disease. Having high triglycerides is slightly different, and the risks associated with having high triglycerides, if they're very high, gives you a risk of developing pancreatitis, and is also associated with the risk of developing hepatic steatosis, so fatty liver. And all of these have an issue or a link in with your fat-soluble vitamins as well. And we'll see some of the lipid problems. You can have a deficiency of the fat-soluble vitamins and can be associated with growth faltering as well. So a number of different clinical problems associated with lipids. We've seen this before, but what tests can you do? What investigations could you do if you're trying to investigate this type conditions? Well, we can do the lipid profile, measuring the total cholesterol, the triglycerides. You can also measure the different lipoproteins. And this is helpful to measure the LDL, the HDL, the VLDL. Sometimes we might measure other slightly more peripheral components of the lipid pathways, such as the sterol profile. And occasionally we'll measure specific enzymes if we think there is a particular defect within those pathways. But then also the general tests that are important to consider would be looking at the liver function, the CK, the thyroid, and as we've just heard from Evelyn, looking at your glucose. HbA1c is critical because of the potential for undiagnosed diabetes to be causing high triglyceride levels. And molecular genetics will be part of the testing process as well for the primary lipids. And then also other investigations we might need to consider would be those looking at the damage that these lipids are causing. So looking at the heart, looking at the liver via ultrasound, for example. All of this, of course, is dictated by our clinical assessment. What is the history? What is the growth patterns? What's the dietary history? What medications the child on? What examination features can we pick up? And importantly, with the dyslipidemias, thinking about the family history. Is there a known dyslipidemia within the family? Is there several generations with high cholesterol levels? Is there a history of early coronary artery disease, a history of strokes? And is there a history of thyroid disease and diabetes? And all of those will be important as we understand what's going on with the child that we're managing. Okay, so thinking about both the primary and then the secondary dyslipidemias, we'll think first about the primary causes once we have excluded the secondary ones, which we've covered already, thinking about dietary factors, obesity, as Dr. Pei was describing, having hypothyroidism, the metabolic syndrome, diabetes are all causes of high lipid levels. In the metabolic clinic, we are also interested in looking for the primary genetic causes, so conditions that impact LDL removal and familial hypercholesterolemia, which we'll talk about more in the next couple of slides, is the commonest primary lipid disorder that we deal with. There can be defects within the triglyceride metabolic pathways like lipoprotein lipase deficiency. And then you can also have disorders which, instead of having very high levels of lipids, can affect causing low levels of the lipoproteins, where the body can't make the correct apolipoproteins. So, for example, A-beta lipoproteinemia, which we'll see. And there are other defects of different parts of the pathway. We don't have time to talk about all of those today. And we'll make a few comments about the polygenic disorders after we've looked at some of those. Okay, so thinking first about the LDL removal defect, think back to our endogenous pathway, the process of LDL being produced and the risk of that loading our macrophages and damaging your coronary arteries. If you have a defect affecting this pathway, you'll have high levels of the LDL and an increased risk of macrophage deposition and coronary artery disease. And the genes that are linked in with this affect the LDL receptor. So the LDLR is the commonest gene associated with familial hypercholesterolemia. And as you can imagine, if you do not have the correct number of LDL receptors, that decreases the amount of LDL that you can remove from the circulation, which will push it into flowing into the macrophages and causing the damage. There are also defects in the ApoB gene, which encodes the apolipoprotein B, and gain of function defects in the PCSK9 gene. PCSK9 has a role in regulating the LDL receptor levels and helps into recycle and turn over the receptor. So if you have a gain of function in that gene, you have an increased turnover of the LDL receptor, which effectively decreases the amount that's available to withdraw LDL from the circulation. In the inherited metabolic diseases clinic, we're used to dealing with very rare, ultra rare disorders, but FH is not a rare disorder. And there are different estimates of prevalence, but between 1 in 250 to 1 in 500 people are thought to have familial hypercholesterolemia. This is an autosomal dominant disorder, so you only need to inherit one faulty copy of the gene to have the condition. And the characteristic profile on blood tests will see a high total cholesterol, a high LDL cholesterol and this risk of early coronary artery disease. And this is a graph that I've taken from the Gene Reviews summary, which illustrates the risk of developing coronary artery disease in association with your lifetime cumulative LDL cholesterol exposure. If you get above this green line, that's the threshold for developing coronary heart disease. If you are someone who doesn't have FH, you have this slow cumulative LDL cholesterol level over a lifetime, and you may get to above that threshold by the age of maybe 55. If you have heterozygous FH, the red line, you can see that you are have a much steeper gradient, so you will get to the risk, the threshold for coronary artery disease in your mid-30s, and that's the classic hallmark that we're seeing early coronary artery disease in untreated patients. We know also that some patients inherit 2 copies of the gene, so a homozygous form, they have a much higher cholesterol level and a much earlier risk of heart disease, even in the early teenage years. What this also illustrates for our heterozygous patients is that if you start statin treatments, you can lower the gradient and so reduce down or push back in time the age at which the coronary artery disease may become a problem. Also important, and we've talked about these other factors already, there are different variables that will also affect your risk for coronary heart disease. So if you're a smoker who's hypertensive with diabetes, who's got poorly controlled triglycerides and other factors, that will lower that threshold, so you will get to it at a younger age. And if you're female, that's protective variable, and that will increase there. So that's the context for familial hypercholesterolemia. There are specific diagnostic criteria. You may be familiar with the Simon-Broom criteria, which help us to make the diagnosis. So you have definite FH if you've got, and we demonstrate a high cholesterol level where your cholesterol is above 6.7 with an LDL greater than 4, and you've got tendon xanthoma, so fatty deposits seen around the elbows, maybe around the eye, the corneal arcus, or the fatty deposits around the eye, either in the patient or a first-degree relative, or we know that you've got a mutation in the gene, one of the genes. There's also possible FH where you have the same lipid profiles and then the history of early cardiac disease with an MI less than 50 years of age in a second-degree relative, or under 60 in a first-degree relative, or if there's a family history of high cholesterol in the relative. So what we do in the clinic when we're making our assessments is to assess these different components of the family history, looking at the lipid profiles, and also looking to see if we can identify the mutation. And then having made that diagnosis, as we've seen, if we can lower the cholesterol, lower the lifetime burden of cholesterol and LDL cholesterol, we can improve the long-term outcome. So treatment is around all of the factors we've already heard in terms of managing and addressing obesity. We need to look at what we can do to optimize the diet, to have a healthy low-fat diet. Lifestyle is really important, maintaining good exercise, limiting alcohol, avoiding smoking and other risk factors for coronary artery disease. But in terms of getting our cholesterol down to where we were aiming to for these patients with a genetic cause, those other factors, diet and lifestyle, are not going to achieve satisfactory cholesterol control. And so we would often need to step in with treatments. First line would be use of a statin, the HMG-CoA reductase inhibitors, to block the cholesterol synthesis pathway. And in a family with familial hypercholesterolemia, we'd be looking to start a statin in a child to control the cholesterol from around the age of 10. And we consider it younger if there's a very early risk of heart disease in the family, or if the levels of the cholesterol are much higher. Statins on their own are often effective, but there are other agents we may consider, such as ezetimibe, which inhibits enterocyte cholesterol uptake, so it blocks the cholesterol absorption from the gut. And there are specific treatments like the PCSK9 targeted treatments. If you remember, PCSK9 gain of function mutations causes an increased turnover of the LDL receptor. If you can do the opposite and block the function of PCSK9, you have a slower turnover of the LDL receptor, and that can improve the removal of LDL. So treatments that do that, including inclisiran, which is a small inhibitor of RNA, or other PCSK9 inhibitors, monoclonal antibodies like ivolocumab, are used in certain contexts. Sometimes if the cholesterol LDL levels are really high, particularly in the homozygous FH, we may need to use apheresis. And in older patients, we may also use other drugs like lamivudine, which inhibits the packaging of triglycerides into the VLDL. And there are nice guidance around the identification and management of FH, which are worth referencing for those who are UK based. Okay, so that's FH, that's the commonest cause. Very briefly, just a few words about some of the other rarer disorders. We've talked about defects of triglyceride metabolism. Lipoprotein lipase is the enzyme responsible for liberating free fatty acids to allow it to go into the adipose tissue. And if you have a defect of this, you can have super high triglyceride levels because you can't break down the triglycerides. And so a blood sample, a venous blood sample, might look very lipemic. You can see in the blood bottle, there is this creamy layer, which is the triglycerides. I had an infant who incidentally was noted to have a lipemic sample whose triglycerides were over 260 at the point of diagnosis. If you remember, the normal range is up to about 2.2, so super high triglyceride levels, and they have high levels of chylomicrons. As we've said before, there's a risk of pancreatitis if you have a high triglyceride level. And the management approach, which is very effective, is to have a very low-fat diet that is based on the use of medium-chain triglycerides that can be very effective at controlling the levels. There are also some other drugs that are used in adult patients with these disorders, such as volanesorone, which is an antisense oligonucleotide that inhibits one of the apolipoproteins, which itself has an inhibitory effect on the enzyme. This is the opposite type of disorder, the hypolipoproteinemias, where you are lacking one of the apolipoproteins. So A-beta lipoproteinemia can be caused by a number of defects, but the MTP gene, this is the gene that encodes the enzyme that packages and processes ApoB to form VLDL, both in the VLDL, but also a role in forming the chylomicrons. These patients have low chylomicrons, low VLDL, low LDL, and have low levels of lipids. The risk here is that you get fat malabsorption, steatorrhea, that has an impact on growth. You're lacking cholesterol, which you need, as we've heard earlier, for the formation of many different hormones. Patients can also get retinitis pigmentosa as a result of the vitamin deficiencies and ataxia. The blood film may show the acanthocytes, but they're also at risk of hepatic steatosis because of the inability to remove the triglycerides from the liver. And again, this is managed with our dietetic colleagues with a specific low long-chain triglyceride diet and vitamin supplementation. I said I'd make just a couple of comments about the polygenic disorders. This again is more within the remit of the adult lipid services, but for many patients who've got a dyslipidemia where there is a familial history, we do not identify a single gene as the cause for that. And often it's a combination of genes or polymorphisms within a number of genes that causes the inheritance pattern. Good. Secondary dyslipidemias, I'm not really going to dwell on at all. We've heard a lot about that in the context of obesity and diabetes. If we're dealing with a secondary dyslipidemia, really the treatment approach is to identify and manage the underlying cause, to manage the complications that are arising, to look at dietary lipid modification, and to consider the use of some of those similar drugs that we've talked about, the statins, older treatments like the bile acid binding resins, ezetimibe that inhibits cholesterol absorption, and others as well. So I think in the interest of time, I will stop there. We've taken a whistle-stop tour through lipid metabolism, thinking about some of the rarer causes and the commoner genetic causes of high cholesterol. And I hope that's been of use. Thank you.
Thank you, James. Thank you so much. Really bringing biochemistry to real life and clinical medicine. So amazing talk. One question has come as to less than 10 year, but high cholesterol levels. Would you start statin? What levels would you look at? And yeah.
Yeah, so we would take a number of factors into account. If it's in a family where we know there is familial hypercholesterolemia, we look at the age at which the cardiovascular disease has occurred. And if we see in a family that there is a very early age of first cardiac event in the 20s, for example, that would lower the threshold and would make us think about treatment. If we're looking at the LDL cholesterol levels, if they are 8 or above, again, we would be thinking about starting treatment younger. It's really about the weighing up the different risks and different approaches to that. Yeah.
And clearly, as a district pediatrician, when it comes to primary type of any form of dyslipidemia, I'll be very scared to start any medication, and I would prefer really a tertiary opinion on that. But slightly different to slightly more common issue of these secondary dyslipidemias. Are we okay to start? Do we talk to endocrinologist always? Do we talk to you, or should we just get on and do it?
Yeah, so I think for the secondary ones, looking at the cholesterol, the triglycerides, it's a long-term risk that we're worried about in terms of the heart and so on. So there is time, if we think that the dyslipidemia is due to secondary causes, if it's possible to address the underlying cause, and I appreciate that's not always the case, but it's important to consider, is there hypothyroidism? Can we do something about the excess weight, and to consider, can we do that? Because if you address those, the dyslipidemia should improve. If you've done those things and you still have the levels that are high, I think it's then reasonable to consider starting a statin, and they are licensed in that situation. However, it may well be reasonable, if you've tried all those first things, to then take an opinion either from endocrine, metabolic. There are some pediatric lipid clinics as well. So I think different specialities that would be important to consider.
Great. I can see Evelyn coming here. Maybe we got 1 minute. Evelyn, what's your thought on that?
Yeah, I would definitely say that if there is hypercholesterolemia or hypertriglyceridemia in diabetes, and you have tried to treat it with lifestyle modification and diet, and it's not successful, that you then need to start medical treatment. And it has been shown that that has long-term effects to lower the lipids. But indeed, if I would email James Davison and say, are you happy if I start treatment? Statins are relatively easy, but I think if the triglycerides are high, that's harder, and you have much fewer options for medical treatment.
Great. I got the idea. I'll also email James then. Thank you so much. Thank you for the talk, and thank you. Let's bring Banu. Hello, Banu. Yeah, I can see you there. Hi, Banu.
Hiya.
So, yeah, let's move from the dysmetabolism to hematology. And great to introduce Banu, who is a pediatric hematologist at Royal London Hospital. And Banu will be talking to begin with. You're talking about neutropenia first?
I'm going to start off with neutropenia, yeah.
Okay, let's kick off with neutropenia, and then we'll take the next one later.
Yeah.
Over to Banu.
Sorry, give me 1 second. Here we go. Brilliant. Thank you, Chetan, and hope everyone's having a lovely afternoon so far. So I've got 2 talks. The first is on neutropenia, investigation and management in the pediatric setting. So neutrophils, as we all know, are an important component of our innate immunity against bacterial infections, and reduced count, sometimes with abnormal function, can lead to significant infection. So I'm not sure if you can see on this side here, it's slightly obscured by the panel coming up, but these are examples of some presentation. So this might be acute, or it might be in the context of chronic neutropenia. So there's a little child here with chronic gingivitis, mouth ulcers, periodontitis. In a neonate, you might see ophthalmitis with a poorly healed umbilical stump, cellulitis, and acute and chronic lung infections. And of course, it can lead to sepsis. So neutropenic sepsis, as we all know, is a pediatric emergency, and it's really important we recognize, make a risk assessment, and treat promptly. So how do we classify neutropenia? Well, the reference ranges do vary depending on age and ethnicity. The other point to be mindful is that most of our neutrophils are actually sitting in the bone marrow, so over 75%. Some are sitting in lymph nodes and the spleen, but only a small percentage, 2 to 5%, are actually circulating round. And this is what we're measuring when we do our automated blood counts. But essentially, a count of less than 1.5, an absolute neutrophil count of less than 1.5 is the formal definition of neutropenia. We can subclassify this into mild, moderate, severe, and very severe. If it's persistent for more than 3 months, it is classed as a chronic neutropenia. So the one thing we have to be mindful of is in neonates less than 2 weeks old, the lower limit is higher, so it should be over 5. But in young children from 2 weeks to 1 year, a limit of 1 is acceptable. We will come to racial norms, but a Duffy null-associated low neutrophil count, and I shouldn't really call that neutropenia because it's not pathological, can range from 0.5 to 1.5. So what might lead to neutropenia? So this table gives an example of the various etiologies that can lead to neutropenia. So decreased production can be a cause in some of the congenital neutropenias. The bone marrow failure disorders don't classically start with an isolated neutropenia, but it is possible and it might progress to a full pancytopenia. Infiltration with malignant cells, cytotoxic drugs like chemotherapy and radiotherapy, and then storage disorders that take up all the room in the bone marrow, so you don't have sufficient room for production. Sometimes nutritional deficiencies can lead to neutropenia as well. So as well as not being able to produce enough neutrophils, the migration process is also important. So we talked about most of the neutrophils sitting in the bone marrow. So if you're not able to move them into the circulation, then you will also have neutropenia. So some of the forms of congenital neutropenia have this etiology. If you've got hypersplenism, you can actually keep your neutrophils in the spleen. Generally, they are able to move out, so you don't tend to have a problem with mobilization, but it can mean that when you do your automated count, it's appearing as if you've got a neutropenia. And then increased destruction. So these are immune-mediated, either alloimmune or autoimmune neutropenias, a bit like ITPUC in platelets, can lead to increased destruction and clearance. And then many other causes are fairly complex. So with some of the congenital neutropenias, it's a combination of different etiologies. Drugs can cause an immune and non-immune basis to the neutropenia. Viral infections can also cause a sort of complex multifactorial etiology to the neutropenia. So let's go on to our first case. This is a 6-year-old who has recently recovered from an upper respiratory tract infection. They have been well previously, no sort of background history. Mum takes the child to the GP. She's just worried he's not been quite right. He's not eating wonderfully well. GP examines, there's nothing really concerning. He organises a full blood count. The hemoglobin is normal, the platelet count is normal, but the neutrophil count is 1.2. So refers to the general paediatrics clinic for advice. So what do we think is going on here? So this is a poll, so hopefully you're all able to choose one of these options. Could this be a congenital neutropenia? Could it be a transient viral-mediated neutropenia? Could this be normal for ethnicity, malignancy, or bone marrow failure? So I think we've got a couple of minutes. Has everyone had an opportunity? Wonderful. Okay, so that is almost certainly the likely diagnosis, but those of you who've put congenital neutropenia and normal variant of ethnicity, it would be fair to certainly consider those options as well. Okay, so when I'm thinking about what might be leading to this neutropenia, this is an algorithm that I find can be quite helpful. So our particular case sort of falls into this middle category here. So this is a child who's been previously well but had a self-limiting acute illness, and this is how the neutropenia was picked up. In this context, I would repeat, and I put here between 2 to 6 weeks. And again, this depends on whether there are any other unusual features, if there was any concern that might suggest some other pathology. And of course, it is sensible to be mindful of the history, examination, and other investigations that you might be considering. The other area where neutropenia is often picked up is an incidental finding when blood tests are done for some other reason. And this is in fact a sort of common referral source into our clinic. And again, depending on the clinical picture, you might want to repeat. If it's persistent, particularly if you've got a well infant, we would think about screening for autoimmune neutropenia, and we'll come to that in the next few slides. And again, ethnicity needs to come into the equation, and we'll talk about how you might approach a possible ethnicity-related reduced count. And then on the other side, you've got here a sick child who might be presenting with recurrent infections, atypical infections, having lots of antibiotics being prescribed, or there's some evolution in other blood counts or other parameters. And you may then be thinking, well, this sounds like it could be something more significant, and I've listed some investigations you could consider. And of course, we're very happy for referrals into the paediatric hematology clinic. So in terms of clinical assessment, and we want to take into account the symptoms, what age did this child present with this neutropenia? What's the pattern of infection? Are there any unusual features? Has the child actually been hospitalized? Have they been given multiple courses of antibiotics by the GP? Are we talking about minor viral infections? The family history is important. Is there an aunt who's had a bone marrow transplant in childhood for neutropenia? Has this child had medications that might cause cytopenias? The vaccination history will be useful. The immune challenge can sometimes cause transient changes to blood counts. And then in terms of your examination, looking for any dysmorphic features that might suggest a bone marrow failure disorder, growth and development, any changes to their nails and nail dystrophy, skeletal abnormalities, and then obviously lymphadenopathy and organomegaly, which might suggest an infiltrative process. And if they're presenting with febrile illness, of course, it's important to examine and screen for bacterial infection. And most importantly, of course, not to delay treatment with broad spectrum antibiotics if they are presenting with febrile illness. So in terms of laboratory investigations, I've spoken about the full blood count and the blood film. When we do blood film microscopy, we're looking at the number of neutrophils. We're also looking to see if there are any abnormal features. And then, of course, screening for all the other cells. So do we have any other worrying features on the film that might suggest a leukemia or some other pathology? Viral screen is sensible, particularly in the case of this child. That might be sensible to consider. And then if we think that there might be an element of an immune dysfunction disorder or something that might suggest a more complex immune deficiency disorder, then starting off with an immunoglobulin profile, particularly if they are presenting young, might be sensible. In young children, granulocyte serology can be helpful. And then I've listed here various other things, lymphocyte subsets, hematinics, a CTG screen, and then we have molecular diagnostics. So there are different panels, which are generic tests looking for congenital neutropenia, but you can also request specific tests that look for things like the Duffy null variant to help make a diagnosis of ethnicity-related reduced neutrophil count. And then sometimes, of course, we do need to do bone marrow aspiration trophine to look at the structure of the bone marrow and see if there are any abnormal features. So in terms of granulocyte serology, this is done in a reference laboratory in Bristol, and this might vary in your area, but this is for the southeast of England. And I've also put here a request form for molecular diagnostics. Again, these are all done in reference laboratories. So let's come to transient viral mediated or infection mediated transient neutropenia. So this is very common. You've probably all come across situations where children present but are very well. These mostly resolve in a few weeks to a few months. And it can be any viral infection. The pathobiology can be variable, but mostly these children will recover their neutrophil count with no long-term sequelae. It may be sensible to ask the GP to repeat to confirm full recovery. And then, of course, most of your paediatric hematology services will have an advice and guidance service set up. So, if there are ongoing abnormalities, then that might be the way to get some advice. So let's move on to our second case. This is an infant who's seen in the prolonged jaundice clinic. They're very well, and the bilirubin is now in the satisfactory range. They're growing and developing well, feeding well. The examination is entirely normal. There's no family history of concern. But whilst having their blood test monitoring for high bilirubin, they also have for blood counts, and the neutrophil count is 0.2. And it seems to be persistent. So I'm just going to, this is actually on the next, let me see. This, I think, is on this one. Right. So what do we think might be the diagnosis here? So could it be a congenital neutropenia? Could this be a transient viral mediated neutropenia, bone marrow failure disorder? Could this be autoimmune neutropenia or alloimmune neutropenia? Right, hopefully I'll be able to see your poll results shortly. Here we go. So some think it could be congenital, some think it could be alloimmune, a smaller proportion autoimmune. So we've got a mixed bag here, haven't we? Okay, so I think it's sensible to think about all of these differentials, but this is autoimmune neutropenia of infancy, which is going to be far more common than all of the others except for transient viral mediated. So the prevalence probably of this is underreported. So typically you've got a well infant. There is usually no atypical features, either in the history, the family history, or the clinical examination. And generally it's an incidental finding. So the median age, it's unlikely to present before the age of 1 month. So this is the sort of the median age, but it is, typically it's not uncommon for us to get referrals from the prolonged jaundice clinics, so slightly earlier timelines. And this is because you've got an autoantibody that is resulting in increased clearance of neutrophils. It's a bit like ITP, except that it's in infants. This is a little bit different to autoimmune neutropenia in older children and adults. And usually the ability to mobilize neutrophils in the context of infection is good. So neutrophil function is not impaired, and usually there is recovery in a few years. But it can be challenging because children do often present with lots of viral infections, and it can disrupt the family routine. Sometimes settling into nursery can be challenging. So the safety netting is important. We do recommend patients come up for clinical review, and an assessment is made to consider intravenous antibiotics, oral antibiotics, potentially admitting, potentially ambulating, depending on the clinical picture. Most children won't need any other specific treatment. Some may benefit from prophylactic antibiotics, and we rarely need to give GCSF. There's no contraindication to live vaccination so long as you've excluded a primary immunodeficiency. So the difference with alloimmune neutropenia is that alloimmune neutropenia causes a very significant neutropenia within 1 month of birth, and it's because the mother is forming antibodies to neutrophil glycoproteins in the fetus or neonate that are shared with the father, and they can usually persist for a few weeks to a few months. So alloimmune neutropenia is not seen beyond 3 months, whereas autoimmune neutropenia is more likely to be seen after that time. So then congenital neutropenia, again, some of you highlighted that could be possible, and of course it's sensible to consider. And having a previous blood count helps. So if you've had a baby and you've got, at delivery that might have had a count and it was normal, and now they have a neutrophil count that's low at the age of 2 months, then it's unlikely to be a congenital neutropenia. However, it's sensible to consider if there are atypical features. So this is some registry data. And then with these panels that we can do, the turnaround time is between 3 to 6 months. But if you have a high index of suspicion, particularly if they're presenting with significant infections, and they have or have other symptoms or signs, then it's certainly worth considering. Most cases of congenital neutropenia, they're not able to mount a neutrophil response to infection. So that can help you to distinguish between autoimmune neutropenia. There may be a family history. Most of these cases are autosomal recessive. There are some autosomal dominant inheritance patterns as well. And most of these children will have really severe significant infections, and a proportion will need to go on to GCSF. There's a risk of transformation to myelodysplasia and leukemia. So what about low neutrophil count in keeping with ethnicity? So the inheritance pattern is polygenic. There is one variant, though, that's associated with this Duffy null phenotype, which basically just alters red cell proteins, and that makes the red cells less susceptible to malaria. So it's found in individuals of sub-Saharan African ancestry predominantly. It's not a medical condition, so it's not pathological, but we can screen for it with a specific genetic test. Sometimes it helps because it helps to relieve anxiety and avoids unnecessary long-term follow-up in the clinic. From a practical perspective, mostly though, it's a diagnosis of exclusion. And obviously, people can have multiple diagnoses as well, so sensible to bear that in mind. So in terms of overall management, if children present with pyrexial illness, we need to screen for neutropenic sepsis and treat as per our local practice, which in most cases will be an assessment and intravenous antibiotics. If you've got patients with known low-risk conditions like autoimmune neutropenia of infancy that we've been discussing, it might help to have individualized care plans. And then those with chronic neutropenia can be really disruptive. So a multidisciplinary approach supporting the child and family care plans at school and nursery, and then long-term surveillance, particularly for the congenital neutropenias. So these are healthcare passports and clerking performers that we're trying to put in place for autoimmune neutropenia. And again, this can be quite helpful to support management in your day-to-day practice. So that is the neutropenia talk. Shall I move on straight on to the platelet one? Yeah? Okay.
Yeah. We'll take the questions at the end.
Okie dokes. That coming up?
Yep, perfect.
Okay, perfect. So the next talk is on abnormal platelet counts, how we might approach investigation and management. So this is going to be focused on how we might approach an abnormal platelet count, so high and low platelet counts. And we're going to be talking about how we might approach trying to make a diagnosis, taking into account the clinical features and the laboratory findings, and we'll sort of have a few cases to discuss. So another blood film here. This is a little platelet. Again, we've got sort of a neutrophil count here and some red blood cells. So the approach to investigation. So it's important to recognize that platelets, as we know, are an important component of our clotting process. They respond to vascular injury and you have a clot formation, but they also respond to inflammation. So when you're assessing a patient, it's really important to put the clinical picture in the context of your blood test results. So the bleeding symptoms, for example, if you've got a low platelet count, if they're not bleeding, that may be relevant. Equally, if they have a high platelet count, they have bleeding symptoms, it may not be a primary platelet problem, but we'll talk about that a little bit later. So one of the most important things to do is to check that you've got a true low platelet count or true thrombocytopenia. So on this blood film, you can see all of these little platelets clumped together, and the automated counter can't separate these out, so it's not going to be able to distinguish all of these little platelets. So there will be a spurious thrombocytopenia. So having a look at the blood film, your friendly hematologist will say, well, it's a true count or we're seeing these clumps, and it's sensible to repeat. So first thing you might want to do is repeat the full blood count. Have a look at the blood film again. And sometimes it helps to take a citrate sample, which sometimes, because most of this clumping is spurious, it's related to the agent we use in the EDTA, and sometimes doing a citrate sample can overcome that. So we've got another case now. This is a 6-year-old, previously fit and well. They're recovering from a viral gastroenteritis 3 weeks ago. They come home from school and they've got some bruising mainly on the lower legs. And they've also got this petechial rash on their limbs. So the child is well, so the mum just takes them to the GP. The GP organises a full blood count. There's an isolated thrombocytopenia, significant severe thrombocytopenia. They also do a clotting screen. The clotting screen is normal. So what would be important to determine in the history and examination? Those of you who are keen, you might want to put something in the chat. So just have a little think about that for a second. So here we go. So history and examination. So firstly, what's the bleeding pattern like? Is this the first episode? Has this happened before? How long has this been going on for? Have they had anything in the history that might suggest some challenge to the immune system? So for example, have they had a recent infection? This child has. Have they had recent vaccinations? Perhaps some medication? What's the family history? Are there any known bleeding disorders, hereditary, or even has a family member previously presented with ITP? And then, have they had any challenges? So, any minor dental challenges, for example, extractions or minor surgery? How did they tolerate that? Was there excessive bleeding? In older girls, maybe a menstrual history. Has that been a concern in the past? And then in the examination, the clinical examination is going to be wanting to focus on any sort of congenital or systemic illness. When you're looking at the bleeding symptoms, what's the pattern? Where are the petechiae? Where's the bruising? Is it in an unusual distribution? Have a look into their mouth. Are there any blood blisters? And then just a systemic examination to determine if there's any organomegaly or lymphadenopathy. And again, it really helps to know if we've got any previous results that we can compare against. So this case, this is another poll. These are the options. Could this be an immune thrombocytopenia? Could it be a bone marrow failure disorder? Could it be an inherited platelet disorder? Or could this be acute leukemia? So if you all could submit your answers, and hopefully we're going to see the results coming up. Yeah, so most of you have gone for immune thrombocytopenia. Okie dokes. Okay, so when I'm thinking about a low platelet count, one of the first things I ask myself is, am I dealing with a well child or is this an unwell child? So with a well child, as this child is, we can maybe think about the history, the examination, but also what the platelets are looking like under the microscope. So, for example, if we've got an immune-mediated thrombocytopenia, so this could be primary or it could be secondary to things like HIV and SLE, or to an immune regulatory or deficiency disorder. But typically what we might see here is a normal hemoglobin and white blood count. Now, having said that, sometimes autoimmune conditions can also lead to an autoimmune hemolytic anemia and also an autoimmune neutropenia. So just to be mindful of that. But usually there's a relatively short history. There may or may not be a family history. When we look under the microscope, the platelets are typically a little bit larger of variable sizes. You can get immune thrombocytopenia in the neonatal setting as well. It could be because mum had ITP and she's passively transferred IgG antibodies across the placenta. Or, like we saw in neutropenia, you can get neonatal allo or autoimmune neutropenia. Alloimmune is more common in this setting. Sometimes we can get abnormally large platelets, and again, the hereditary macrothrombocytopenias, they usually have an autosomal dominant family history. And particularly if there's a sort of a known family history, that might give you a clue. Small platelets are typical of Wiskott-Aldrich syndrome. And then with other acquired conditions, whether it's medication, bone marrow failure, storage disorders, again, they can be of average sized or variably sized, and there may be some other clinical features. So we next have our case 2. This is an 11-year-old child who's previously fit and well, but over the course of a few days rapidly deteriorates with clinical features of sepsis. So you're seeing this child in resus. They have a particular rash. They have a raised white cell count. It's mainly a neutrophilia, and they have a platelet count of 15. The clotting screen is also abnormal, so you've got a prolonged PT, APTT, and the fibrinogen is low. So in this context, what do we think might be going on? Oops, sorry. So could this be malignancy, disseminated intravascular coagulation, or DIC? Could it be thrombotic thrombocytopenic purpura, which is TTP, or could it be ITP, immune thrombocytopenia? So if you could just submit your responses, and that should hopefully come up in a second. Okay, DIC. Yeah. That is the most likely diagnosis. Okay, so now we're dealing with an unwell child. So DIC is one of the causes of a consumptive thrombocytopenia in the context of sepsis. TTP, we'll come back to this, microangiopathic hemolytic anemia with low platelets, again, is a consumptive process. Massive thrombosis will also lead to consumption of all of your platelets. And in neonates, again, an unwell neonate with a history of placental insufficiency or acute prematurity-related complications, for example, might have a significant consumptive thrombocytopenia. And then, of course, malignancy, toxins, chemotherapy, a child on a chemotherapy regimen, these are going to impact symphysis. And then really you might have acute sequestration. Sometimes, for example, we see acute hypersplenism in our sickle cell population, and that can lead to an acute drop in platelet count. So the approach to investigation, we talked about the full blood count. Sometimes it helps to do the mean platelet volume. So this is when I was talking about trying to determine the size of the platelets. And the immature platelet fraction is essentially the platelet equivalent of the reticulocyte count that we use when we're sort of monitoring bone marrow response to anemia. So the blood film can be helpful. Clotting screen. So in a bleeding patient, APTT, PT, thrombin time, and fibrinogen. And then these are sort of additional investigations to consider. Infection screen for acquired or transient causes of thrombocytopenia. Immunological investigations when you're thinking about primary immunodeficiency or dysregulation disorders. Flow cytometry for infiltrative malignant processes, leukemias. And then platelet function sometimes might be necessary. Most platelet function abnormalities have a satisfactory platelet count, but if you've got disproportionate bleeding with a reasonable platelet count, then it's certainly something to consider. And then we have genetic panels to screen for hereditary platelet disorders as well. So in an unwell child, you might be wanting to think about transfusing with platelets. So these are your transfusion thresholds. Usually we try to keep a platelet count of 10, 20 if they're septic, and then if you're doing a lumbar puncture, there's moderate bleeding, 50, and then 100 for CNS bleeds or complex surgery. And generally, if you've got a child over 15 kilos, you just transfuse a unit of platelets and calculate out in mils per kilogram if they're less than 15 kilos. So let's move quickly on to immune thrombocytopenia. So this is an autoimmune condition. It's actually got a complex etiology, but primarily there is antibody production in B cells, and these the antibody binds to platelets and they are removed by macrophage-mediated mechanisms in the spleen. So the spleen is the primary site generally where that destruction happens, so this premature clearing of platelets. But we also think that that process, that immune-mediated process, targets the bone marrow. So megakaryocytes are the mother cells where little platelets bud off from, but they don't move appropriately through the bone marrow, so their function is impaired. And again, that's thought to be immune mediated. So some of the therapies we use for chronic ITP target production in the bone marrow as well as the abnormal immune response. Usually we're talking about, certainly for primary ITP, a well child, and maybe an infection trigger, which has confused the immune system. Most children recover uneventfully. A small proportion we need to be thinking about treatment, and platelet function is normal. So despite having very low platelet counts, Generally, the risk of bleeding is low, but sometimes children can present with significant bleeding, including intracranial hemorrhage. So when we see a child who presents with acute ITP, we need to make a judgment about monitoring, observing versus treatment. So if they're presenting with bleeding symptoms, is it mild, is it moderate, is it severe? What I tend to do is I admit overnight, really to determine and make a judgment about that risk. And specifically, I want to make sure that there isn't significant mucosal bleeding, so epistaxis, bleeding from the gums, GI bleeding, anything that might be significant, I want to think about treating. But it also gives you an opportunity for education and safety netting, and organising additional investigations should you need to do that. So in terms of management, if you need to treat, so there's moderate or severe bleeding, in the acute setting, generally we'd go for IVIG. But if you're managing in the outpatient setting, then sometimes we also give steroids. Certainly if there's moderate bleeding, that would be very acceptable. So we're sort of targeting the immune system. If they are very well, it's just some minor petechiae, then you could admit, monitor this discharge, and if they've got platelet count under 10, we usually see weekly in the outpatient setting until we see a recovery. And then it's supporting the family and child, ensuring there's appropriate support at school. So there's a school or nursery care plan. We avoid non-steroidals, avoid IM vaccinations or injections, otherwise you get very large hematoma in the muscle. And then for children, we recommend they avoid contact sports, which doesn't always go down very well, and it can impact on quality of life. So some supportive medicines like tranexamic acid, hormonal therapy for girls with heavy menstruation, and they do often get iron deficient, so replacing iron as needed. So let's move on to immune thrombocytopenia in neonates. So if you've got a healthy term infant who presents with a particular rash and you find that they have a severe thrombocytopenia, the risk of bleeding can be significant. You should always consider neonatal alloimmune thrombocytopenia. So this occurs because in the fetal and neonatal period, and usually this is happening in utero, the mother, there is sensitization, so the mother has formed antibodies against antigens on platelet glycoproteins, which the fetus or neonate shares with father. So that causes a rapid drop in platelets, and there's usually some specificity to those platelets, and there's some degree of ethnicity specificity as well. And we can essentially screen for those antibodies. So this is important to recognize because of the risk of bleeding. The thresholds you'll see are a little bit different here. We transfuse the platelets are under 25. We want to try and select platelets that are negative for those most common of those antigens where the antibody response is being made. But sometimes, if there's a significant bleeding risk and you can't get these matched platelets in time, then you give just standard platelets. And because this is immune mediated, if you're needing to give repeated platelet transfusions, then IVIG can be useful. Cranial ultrasound scan is sensible to screen for intracranial hemorrhage. And because this antibody can float around for a good few weeks, they need to be kept under surveillance. So this is just basically showing that the thresholds are a little bit different, so 25 rather than 10, as we were discussing in older children. And just very briefly, TTP. So this is rare, but just to be mindful, because this can be congenital or idiopathic, and the idiopathic forms usually have an immune basis to them. But this is important to recognize, because although the child or adult might present with purpura and petechiae, actually this is a prothrombotic condition. So essentially what you have is microthrombi in small blood vessels and all organ systems. So there's a risk of renal failure, neurological deficits, and untreated, there's a high mortality attached to it. So classically, there's a microangiopathic hemolytic anemia. So when we look under the microscope, we see schistocytes, which are basically little fragmented red blood cells. And then your biochemistry is in keeping with a hemolytic picture. The platelet count is usually low, and that's because you're consuming all of your platelets. And what happens is you have a deficiency of Adams 13, and this is basically an enzyme that cleaves von Willebrand factor. So because you have a deficiency, you have these larger forms which lead to platelet aggregation. So you have over activation of your platelet clotting process. And this is a reason why we avoid platelet transfusion. So this is one scenario where you have to think, could it be this condition? I want to avoid platelets because it's just going to make the situation worse. Hemolytic uremic syndrome, which you probably see more of, the renal impairment might be more pronounced, neurologically fewer symptoms, and usually the thrombocytopenia is less severe. And as you know, it's generally managed with supportive care. For congenital TTP and acquired TTP, usually we're trying to replace the enzyme deficiency, so plasma exchange or FFP infusion in the first instance. So we'll quickly move on to thrombocytosis. So this is a high platelet count now. So again, this is classified into mild, moderate, severe, or extreme if it's over 1,000. Yeah. So primary thrombocytosis is really rare in childhood. So you can get these hereditary rare forms, and myeloproliferative disorders are really, really rare in children. So secondary reactive forms are very, very common. So this is a little survey we did a few years ago, and this is looking at extreme thrombocytosis. And as you can see, it sort of affects all age groups, but particularly in very young children and adolescents. So empyemas, effusions are really at top of the list. In our hemoglobinopathy cohort, we see a lot of extreme thrombocytosis because they're also hypersplenic and usually post-splenectomy. But iron deficiency is a common one, and trauma. So reactive, infective, inflammatory causes. So screen for iron deficiency, screen for infection, inflammation. Rarely will you need to be thinking about hereditary or congenital causes, but you might want to think about family studies. And there are molecular diagnostics that are possible. We really generally don't need to consider bone marrow biopsy. So firstly, common things are common, but we do sometimes get these referrals coming to clinic as well. So mostly with very high platelet counts, you're really just treating the underlying cause and monitoring. The risk of VTE, arterial or venous thrombosis, is pretty rare. All of the cases we saw were related to central venous catheters in the context of an unwell child, so taking into account all the other risk factors. So that's the end of the talk. Hope I was on time.
Absolutely, you are spot on. You are not just on time, but 1 minute ahead of time. So well done.
Hooray!
Great. But it brings with questions. So there are quite a bit of interest. So amazing talks, Banu. Really enjoyed. There are few questions theming around neutropenia and prophylactic antibiotics. If you could just elaborate once, when would you always use? What are the numbers where would you use? So just, they are all revolving around that.
Yeah. So again, it depends on the underlying cause and whether you're dealing with a neutrophil count that is low, whether you're able to mount a good neutrophil response to infection, and whether you've got abnormal neutrophil function. So the cause, the etiology is important. So for congenital neutropenias, there is a significant risk of infection. And it does depend on which type of congenital neutropenia and their baseline neutrophil count. But most of those cases will be on prophylactic antibiotics. On the other end of the spectrum, with autoimmune neutropenia, for example, in infants, the vast majority won't need to be on antibiotics. I would say in that cohort, where you think they are presenting with lots of febrile episodes, and albeit most of these will be viral, I do sometimes try and see if a trial over 6 months of usually prophylactic azithromycin on a Monday, Wednesday, Friday schedule makes a difference. And then you have to obviously be sensible and unnecessary use of antibiotics, or the issues with compliance. And obviously being mindful that it's important that parents recognise that they still need to present. It's important that we treat febrile episode, that they're not sort of relaxed at home thinking that they've got prophylactic antibiotics. And again, GCSF is often used for congenital neutropenia. Some congenital neutropenias don't respond to GCSF and they need sort of good surveillance, but it's rarely, very rarely necessary in autoimmune neutropenia. With sort of with leukemias and chemotherapy for solid tumors, again there will be different protocols for and the risk assessments for each of those conditions in terms of recovery and whether prophylactic antibiotics and GCSF are appropriate or not.
Absolutely. Well, my take is if you are giving antibiotics because you are such a high risk, then you are really a red flag and parents should understand. You might give them passport and all in that case.
Yeah, healthcare passports, and again, we're still in the process of setting these up for our autoimmune neutropenia patients, but I think it will help. Again, it's important to individualize and assess each clinical situation for what it is. But sometimes having some guidance, one of these three options, are you going to ambulate? Are you going to admit? Are you going to send home with oral antibiotics? Again, that can be helpful. But yeah, I think it's always about a risk assessment.
Maybe we'll take one question from platelet group as well. I think there are quite many questions coming on a theme of platelet transfusion in ITP situation.
Okay, so platelet transfusions are rarely required in ITP because the moment you pour them in, they just get removed out of the circulation. So it's sort of generally unnecessary platelet or transfusion exposure. Now, there might be a scenario where you've got a catastrophic bleed, an intracranial hemorrhage, and in that context, these are rare events, but in that context, you're just going to throw what you can. So you'd go for IVIG, steroids, platelet transfusions. We've even sometimes needed to go for sort of Nova 7, so activated factor 7. So sometimes you just throw what you can, but most cases of ITP, platelet transfusion is ineffective. And there are all sorts of risks associated with transfusion.
Thank you so much. Thank you. This was
I'll have a look at the chat and I'll answer any more
Yes.
in the chat if there's anything else.
Hello, welcome back from your break, and you come to the last part of this Power Pack Day. And we've got about 3 talks. A couple of them will be delivered by Dr. Abigail Whitehouse, who's a senior clinical lecturer and honorary consultant at respiratory consultant at Royal London. And we'll do questions after each speaker's talk. So over to you, Abby.
Lovely. Thank you very much for the introduction. So, yeah, I'm going to take you on a whistle-stop tour of plasma and wheeze. And in particular, I'm going to give you an update on the new BTS sign guidance from 2024, so NG245, talk around diagnosis and who to refer and when to refer, and a bit of a crib sheet on who to worry about. And then also talk through the newer treatment pathways with the shift towards different inhalers. And then the second talk I'll do, which I'll go straight into, is the lung function interpretation. I do have some AHA slides in there, so get it ready and I'll give you the code when we get to those slides, but that's not until the second talk. So I'm going to start with a good asthma consultation. And I always like to think about why the patient's there in the first place. Sometimes they've been referred for a recurrent cough. Sometimes noisy breathing, sometimes wheeze. And the wheeze aspect is interesting as to whether it's actually wheeze or something else. And my good old favourite, which is that they don't really have any clue why they're there, probably because they've got better in the meantime before they've arrived for their secondary care or tertiary care consultation. You need to think about the age of the patient, and I've put toddlers in there even though we're talking about asthma, because viral induced wheeze invariably is a variation of asthma. And then we've got child and then adolescent, all of which need a different type of consultation. And so from the patient factors, what noise do they make? Is it actually wheeze? So thinking about whether it's an inspiratory or expiratory noise. Quite often parents will report that they can hear the wheeze all the time, which always makes me kind of think, actually, is this really wheeze? Because classical expiratory wheeze shouldn't really be audible. And I always wonder about whether there's some inspiratory or upper airway noises contributing to that. Or is there an associated cough? And the typical one would be a nighttime dry cough. And then thinking about the symptom pattern, does it respond to salbutamol? And how quickly does it respond to salbutamol? Salbutamol time to action takes kind of 10 to 15 minutes. So if someone's telling me that they take their inhaler and they feel better straight away, I wonder whether or not that it's actually the salbutamol that's having the effect there. Do they have any interval symptoms? So do they have pollen or seasonality type symptoms, or do they have exercise symptoms, or is it just viral related wheezing episodes? And then obviously their background, so family history, eczema, allergies, and allergic rhinitis. And then home factors. So for anyone that's heard me talk before, you'll know that I talk a lot about the environmental exposures and their impacts on children with asthma. So where do they live and who do they live with? In particular, is there any smokers in the household, or are there any vapors in the household? Also thinking about pets and what kind of pets they are, and then what kind of property do they live in? So is there any mold, damp? Is there any exposure to air pollution, such as living next to a big main road? And often you'll find, if you ask some of these questions, that yes, you then do get asked for a mold referral or a support letter for the housing authority. But actually, it's really helpful to have that conversation, because it helps to pinpoint the triggers of that particular patient and not just focus on the more traditional triggers as well. I'm not going to go too deep into your examination, but you're looking for the key bits and pieces. So eczema, rhinitis, and wheeze. Are they wheezing on the day? Is there are they thriving, or do they have failure to thrive, which always makes me worried that it's not just asthma. If they've got a Harrison sulcus, that we don't see many anymore, but just look out for it. And then they do usually have this dry cough, particularly at night. A lot of what we see in the asthma clinics are that there's a lot of allergic rhinitis treatment symptoms that mimic asthma. So they cause the cough, they cause the difficulty in breathing, they cause this kind of tight chestedness because of postnasal drip. So actually making sure we're treating the patient holistically and not just focusing just on the lungs. And then thinking through their medication history. So what have they tried so far? And thinking not just the asthma medications, but again, thinking about those other medications. So from an asthma management perspective, how often are they using salbutamol? Are they using it more than 2 or 3 times a week? You can use the asthma control test to support you kind of asking those questions. Are they on an inhaled steroid? I prefer to ask how many times do they forget it a week, because they're normally more truthful and remember how many times they forget it, rather than if you ask them if they take it all the time. And also, what dose of steroid is it, and is it appropriate to their age and size, and actually do they need to have a higher dose of steroid, and what other asthma management might they be on. And then other medications, thinking about things like rhinitis treatment, anti-reflux treatment, and also thinking about whether or not they've been seen by any of the wider MDT, such as speech and language, the community asthma nurses, ENT, if they've got clear snoring at night as well. So thinking about all those bits around them. And these are some of the alternative diagnoses that kind of always sit at the back of my head when I'm having a consultation with someone who's got wheeze. But almost always, there are very clear signs that this is something not just asthma or wheeze. So particularly thinking about symptoms present from birth, really unlikely to be just bronchoconstriction. So thinking about if they're getting recurrent infections, whether it's PCD or CF, although in the UK we do have newborn screening, which would pick up most of our CF patients, or a family history of unusual chest disease. And the PCD one's interesting because we see quite a lot come through with recurrent ear infections and recurrent nose infections. But actually, if you question about the wheeze isn't there all the time, and it doesn't really respond as well to inhalers. So actually, the PCD picture can come alongside it. If they've got a persistent moist cough, a wet cough, or they got something like bronchiectasis on a background of aspiration, we see a lot of reflux, and that's not always with aspiration, but even simple reflux can exacerbate asthma symptoms. Breathlessness with lightheaded and peripheral tingling is always one I wonder about, particularly with the teenagers, but I've seen dysfunctional breathing and the almost anxiety related breathing issues, even down to kind of age 6, age 7. So it's always one to think about. If they've got inspiratory stridor, you need your ENT colleagues. And if they've got persistent wheeze that doesn't seem to settle or is there all the time, then actually have they got some kind of malaysic airway disease going on? And if they've got failure to thrive, thinking about whether they've got something like reflux that's stopping them eating as well. So previously, if you would have asked me about diagnostic pathways, I would have sent you in 3 different directions. I would have talked about the European Respiratory Society algorithm, the GINA algorithm, which is updated yearly, and then the NICE and BTS sign. But actually, we've had some really nice, clear guidance come through from NICE and BTS in the NG245 guidance that has been adopted across the UK and is being fed into most of our prescribing guidelines formularies as well. But the key essentials of all of those guidelines are that you need objective tests to diagnose asthma and wheeze. And this is really difficult in primary care. So I'm sure that many people might be getting more referrals at the moment because there is a push towards primary care having an objective test on patients' records if they've got a diagnosis of asthma. So they might be sending in more patients and questioning that diagnosis. But we know that no single symptom or test is diagnostic. Spirometry is gold standard, and it would be great if we had diagnostic hubs all over the country. If you live or work in Northwest London, there is a very good setup that they've just got started for paediatrics, but the majority of the country doesn't have access to paediatric spirometry in the community. A key bit is that if the diagnosis is suspected but not clear, then you should initiate treatment, which is what has always tended to be done, but making sure you've got that clear review and that you're documenting each point. And that the process used to reach that outcome must be recorded in the patient record because it's really helpful for when you then pass that patient on to somebody else. So this is the new objective test algorithm for NICE for age 5+. So the order of the tests that they put through is that you would start with FeNO if available. The reasoning behind that is because it is more accessible. I'll come back to some more details about FeNO and then I'll also talk about bronchodilator reversibility as well. Peak expiratory flow rate, and then the one on the right hand side, which I'll put there, so skin prick testing or total IgE and blood eosinophils. These are really useful tests, but they come from research studies that were looking at steroid responsiveness. So they don't necessarily make your diagnosis for you, but with the history of suggestive asthma, they might be a useful corroborating a piece of information. So objective testing. FeNO, so it's fractional exhaled nitric oxide. It's a tidal breathing test. It's really quite easy to do. but you do have to focus on what you're doing. It's a marker of eosinophilic inflammation. So that means that if you put eosinophils anywhere, then it might be up, particularly if they're in the nose, so allergic rhinitis, or if they're in the esophagus, so eosinophilic esophagitis, then you might get it there as well. It's not just reflective of eosinophils in the lungs. It does predict steroid responsiveness and it reflects compliance, so you will see it come down if you do it regularly. And a normal reading for children is less than 35. It's really difficult under age 5 just because of the coordination with the breathing with the machine. But it's not been shown to guide treatment. It just reduces exacerbations. But it does predict if you're going to respond to steroids because you've got the eosinophils there. And I put needed in primary care at the bottom because if it's going to be at the front of a nice guideline, then that's where we should put it. Peak flow is really helpful. It's really basic. It's relatively cheap, although each one of those peak flow monitors costs about £10, and they're not to be used between lots of people. So it's not the cheapest thing, but it's cheaper than setting up a spirometry hub. It is effort dependent, so they do need to be trained how to do it, but actually it can be really effective. And you get this peak flow diary like what you've got at the bottom and on the right hand side there, which shows the diurnal variation. If you do it twice daily for 2 weeks, then you'll see variability. And if it's more than 20%, then you can use it as a diagnostic for asthma. This is an asthma control test on the right hand side. There are two. There's one for older children, there's one for under 11s as well, which is done by the parents, and it's really good and reflective of the last 4 weeks of asthma treatment. But the question is, what do you do when there's no access to treatment or testing, or they're too young, so they're under 5, or they're unable to perform the test, which is not an insignificant number of people. So as I said, the NICE guideline has brought together what we've all been doing for a while, but basically if they're under 5, give them a trial of treatment, and when they get to 5 and they can do an objective test, do it then. And you keep trying it if you've got availability to it. There is a point at the bottom in 1.33 where it says refer to a specialist if they've had an admission to hospital. So through your normal wheeze and asthma pathways through into general pediatrics, and then on afterwards if needed, if they're getting multiple presentations with wheeze. So treatment. I think hopefully pretty much everywhere now has removed Selby small weaning plans from their discharges. And this is to move to a way so that we've got an easier to explain and a better and a safer way of using salbutamol. And it also can be stepped up or stepped down. So you can use it before you come into hospital and after discharge. And that's that you give 2 puffs, and then after about 5 minutes, you listen again, or you hear again, or you look at your child and you say, actually, they're still not doing everything quite right. I'm going to give 2 more puffs, and you keep going up to 10 puffs. This then means that you can do this after discharge, but also when you're worried about your child before you bring them into hospital. So it's a really good way to have that shared decision making with parents. It's helpful because it tries to avoid that 10 puffs hourly that some patients ended up getting at home because that's what they'd had at hospital, or that's what they thought was okay. So it's really helpful to do that, but it's really about being clear that it's about reassessing your child frequently. And then the pharmacological management generally of chronic asthma. So if we're under 5, as we've always done, so they've got suspected symptoms, they've had probably 2 episodes of wheeze. This could be either GP treated or through A&E or admissions. But if they've had 2 good going viral induced wheeze and they've got any other symptoms, I would start them on a trial of a low dose pediatric ICS, so beclomethazine 50 or 100 depending on age, 2 puffs twice a day. Give it for 8 to 12 weeks. If the symptoms resolve, then you could try a trial of treatment depending on the child. But if the symptoms at that point, then restart it. Step up from ICS would be starting something like Montelukast on top. And then the next step after Montelukast would be adding in Seretide or changing to Seretide. If it hasn't made any difference initially, stepping up and adding in Montelukast early on would be fine. But if they really haven't had any response to a low dose steroid and the symptoms aren't quite fitting, then referral in at that point would work. 5 to 11-year-olds, I would still encourage everybody to stick to the right-hand side, which is your conventional pathway for pediatric low-dose ICS. So you start them again, beclomethazine. If that doesn't work, add in your montelukast. If that doesn't work, switch them to Seretide. However, there is one MDI inhaler of Symbicort, and I'll talk about MART in a second, that can be used in the 5 to 11-year-olds. My only reason for not, two reasons for not pushing it at the moment is one is that it's still not licensed. And it was chosen as a kind of a backward step from the older cohort. But also there is a UK-wide research study ongoing at the moment, which is trialing it in all children aged 5 to 11 that are eligible. So if you do have access to that research study, please get people recruited to that, because we know that then we can follow up and we can make sure that this is the best way to do it. I will say that MART works really well in the next age cohort. So MART in the over 12. So if you've got an over 12-year-old that you're starting new treatment for, or you're reviewing and they're still getting symptoms on traditional treatment, then switch them over to Symbicort. The main thing that you need to be aware of with Symbicort is that it's a dry powder inhaler. And so the technique of taking it is a little bit more difficult. So you need to make sure that they're able to actuate it. But low dose MART is fantastic, particularly for adolescents. It works in all different types of asthma. You still need to review it as you go forwards, but it's definitely a move, and the teenagers really do like it because they don't have to carry around their spacer with them. Green prescribing, so it's really important that the key bit that we think about when we're doing green prescribing when it comes to inhalers is that the best inhaler for a child and the environment is the one that keeps the child's asthma the most well controlled. Because if your asthma is uncontrolled, then you have all the climate related impacts from multiple hospital admissions and using lots of salbutamol. So actually switching away from the inhaler that works onto one that is better, which is the dry powder ones, doesn't always work. So just thinking about that, but definitely thinking about switching away from the higher polluting salbutamols in particular. Making sure all our patients have asthma action plans. So this is a standard one, and then we've also got our MART asthma action plan. And you can see that it particularly talks about the maintenance reliever aspect of it. Fab. So whistle stop tour of asthma. Crib sheet. So review the diagnosis when you see them. Yes, they probably have been through tests before and they probably do have wheeze, but be reassured and reassure yourselves that that's definitely what they've got. Make sure you're treating allergic rhinitis as well alongside it. If you've got access to lung function, then do it. And hopefully we'll go through how to interpret that. Review whether they're controlled or uncontrolled, and if they're needing those salbutamol more than 3 times a week, then they need to be stepped up and they need to be reviewed. We should not be accepting children that wheeze on a regular basis. If they're wheezing on a regular basis, that means they've got ongoing inflammation. So we should be stepping up their treatment until that wheeze is pretty much gone. Review their treatment and action plan, but always think about if there's another diagnosis. What happens next if they don't get better? This is our problematic severe asthma pathway. So one of the key bits of problematic severe asthma is we go right back to basics and we go through everything again. We then do a lot of adherence, and we look to make sure that we've addressed all the modifiable factors that we can do. And if they are still having asthma attacks on that, despite us escalating treatment, then we get to go to the fancy medications that cost lots of money. And depending on whether you've got eosinophils or not, or high IgE or not, chooses which of the fancy medications you get. But ideally, we should be able to manage everybody before we get to biologics. I'll just bring you back to the CYP asthma capability tiers. So everybody who is managing children with asthma should be doing at least level 3, which is the e-learning for health. And if you're making decisions or you're starting to deal with more severe asthma, then you should be thinking about doing, so the tier 3 is through e-learning for health, and then tier 4 is through Rodman respiratory, or you can do the RCPCH how to manage asthma course. Thank you. Okay, fab. I'm going to breathe for a second.
I'll let you do that, Abby, whilst you're pulling up the next talk. And I know that there are some questions that are coming up, but we've decided that we'll do them in the end. It's about Mart and everything. So we'll come back to that in a moment.
Lovely. 2 seconds. Let me share again. Okay, fab.
We're keeping with good time, so you're okay, Abby.
I have got the clock in front of me, but it's I thought I did quite well there. Okay, so I'm going to talk briefly through lung functional interpretation. It sounds like there might be a few questions as well about everything else, so we'll be able to go through that as well. So one of the key things that you will see is that there is this real push to doing lung function on many more patients, and they will be coming through secondary care services. And I think if you've not got lung function available on site, then it's always really good to be able to review it, particularly if the diagnostic hubs come in, because you're going to be able to interpret the results that you get. So let me just have a look. No, there we go. So I'm going to talk about when to do it, who to do it on, how to interpret the reports briefly. And again, as I said, it's right in the middle of the objective testing for the NICE guidelines, but it's still gold standard. It's the one that we want to see. There are some caveats to when it may or may not work, but it is definitely the gold standard of testing. So I'm going to see if I can get this to work. So while we're watching this, I've got the code for the next slide, WTM9 from my HAR slides. So if you can pull that up, you can see the next question, and we're just going to have a quick listen to this. I'm going to move it to the right place. This is American, I apologize.
A spirometry test may be done at a hospital or doctor's office. Here's what happens. Spirometers have a tube or mouthpiece that you blow into. To help you do your best, a soft plastic clip will be placed on your nose so no air leaks out while you're blowing. It doesn't hurt. You'll be shown how to blow into the mouthpiece. It's kind of like blowing into a party horn for a long time. When you're told to, take a deep breath in and blow out as hard and as long as you can. That's all there is to it. Now your doctor knows how much air your lungs can hold and how fast the air moves when you blow out.
See, simple. So if I now get this up, not break it. What do you want to know about spirometry? And I'm putting this up here so you can add things in. I know you're going to have some chat as well, but it's really helpful for me to kind of know what people might want to know about it. I'm going to see if anybody manages to pop anything in before I move to the next slide.
You can join by that code if you've not managed to get
I think it's me. I think it's me. There we go. There we go. Oh no, maybe not. I might come back to it. Everyone can do some writing, and I'll come back to this slide.
Abby, it says they have a different question on the website.
Oh, okay. That's unfortunate. We'll come back to it. It's fine. So some definitions. So you saw briefly that video from the American hospital about lung function. So the things that you're going to see and the things that you need to know about are your different bits and pieces of lung capacity. So you've got your total lung capacity, your vital capacity, and then the difference between that is the bit that's left is your residual volume, because you can't blow out absolutely everything from your lungs. And the most important bit to know is that we can't only measure certain bits of it. So the main bits that we can measure are the ones above, apart, and then we can work out what the residual volume is. So this is what your spirometry loop will look like. I do that one. Laser pointer. There we go. So this is your, can you see my laser pointer? Maybe.
Yes, we can. Yes, yeah.
Perfect. Okay. So this is your breath in on the bottom, and you can see that this is your forced vital capacity. You've got your residual volume here and your total lung capacity. So this is your breath in, and then this is your breath out. The first peak that you take out is your peak flow. So that's the one that you can test yourself at home. And then you can see that you've got your exhalation loop coming down. Your FEV1, which is the one that everybody talks about, which is your forced expiratory volume in 1 second, is the bit that comes out of your lungs within the first second. And then you've also got your forced vital capacity, which is the amount that you can blow out across that whole exhalation. So there's 3 easy tips to interpreting lung function when you get it. So you're going to look at your flow volume loop and decide if it's normal or abnormal. You're going to look at your FEV1 to FVC ratio, and if you've got a Z-score of less than minus 1.64 or less than 80% predicted, then that's suggestive of asthma. And then you're also going to look at your FEV1 values as well. So this is your quality. This is how you look to see whether your loops look great. So that first one there is a great loop. You can see it's got a nice sharp peak and then a clear exhalation loop. You've got submaximal effort where there's a bit of coughing. There's this wiggly line. It's not quite working great. They're not the total lung capacity here, so they're not taking a big enough breath in. And equally, you've got submaximal inspiration here. This one here, where it's got this complete drop-off, is where the glottic early. And then if you look on the right-hand side, you've got a nice clear cough. And you can see that that disturbs the amount that you get. And my absolute favourite is the tongue occlusion, which is where basically they've managed to get the tongue in the mouthpiece, and therefore they haven't managed to blow out quite so effectively. So flow routes that I'd expect to see. So the top one is normal on the left, a restrictive pattern. And then you've got your obstructive pattern, and in particular, you're looking for that scooping that you see on the exhalation loop. And then you've got variable and extrathoracic and intrathoracic obstruction. The results that you're looking for in terms of, you'll either see percent predicted or you'll see a Z-score. And the Z-score basically brings you into a normal Bell loop. And these are based on where you'd expect to be for that population. The FEV1 predicted, we use the GLI calculator to do that. So the GLI calculator brings in results from multiple different ethnicities. They did have a long period of time where they had whole missing ethnicities, particularly South Asian, but they have improved that now, and they've got much more accurate results for those. But certainly for Caucasian results, it's much more accurate. We then want to look for bronchodilator response. So we'd look for an increase in FEV1 of 12%. So you do your first set of lung function, and then you take 4 puffs of salbutamol, and then you do it again. And you can see in this, you've got the red loop before the bronchodilator use, and then you've got your green loop afterwards. And you can see that there is a significant jump. And that's how you can, that's your bronchodilator response. I wouldn't expect to see that if you're on good treatment from your ICS or you're on MART, a good dose. But it does show us A, whether or not they're taking their inhalers, or B, if they've got asthma in the first place. Okay, so I have a feeling that this isn't going to work because I've done this as a case, but I've got an 8-year-old with recurrent episodes of acute severe wheeze, and they've got daily salbutamol use at home, and previously admitted to hospital, no salbutamol use in hospital, and then, which is a key thing, and then they've got wheeze when you're seeing them in clinic. And this is their lung function. So you can see that they had significant bronchodilator reversibility, and they had 36% reversibility, and their FEV1 was less than 60% when they came. They had a raised FeNO of 100. But when you talk to them, they've improved their compliance, they're taking their inhalers every day, they've taken on board everything that happened when they're in the hospital, but they still have significant bronchodilator reversibility. So
I'll see if I have any chats to say it's a different question, but
yeah.
we can find.
Okay.
People will let me know in chat.
This, yeah, here we go. Okay, this one's working. I think we were on this one last time.
Same question, so yeah.
Okay, in which case, did anybody manage to work out what the result was going to be? And we have got 14 seconds left. So I think when you're thinking about the lung function, it's really good at telling you when they've been having their inhalers or when they haven't been, but it's also really good at giving you something to discuss and explain the asthma diagnosis to them as well. Okay, let's show the results. So 11 of you were didn't think they were taking their inhalers, despite the fact that they told us that they were regularly taking them. 6 of you said they were unwell at present, so that's a really good call. So actually doing lung function when they're not well will always give you poor results, and it's important that you work really well with your physiologist to make sure that they are telling you what's going on as to whether or not they are coughing or whether they're wheezing. We shouldn't be going ahead if they're wheezing actively. And 10 of you have said there is a cat at home. Okay, so that is correct. So they had a significant allergy to cats. And that's why when that brief mention that I made of the fact that they took absolutely no salbutamol when they were admitted to hospital was because actually the main driver of their lung function issues and their asthma was the cat that lived at home. The advice that was given, unfortunately, was to remove the cat from the home. They went to live with Auntie. Asthma got better, apart from once or twice a week when they went to visit Auntie to see the cat. And I think we have to be really clear that actually, if it is a cat or a dog or it's an allergy that's driving it, that we need to be really supportive to them. But unfortunately, they need to remove the trigger if they can. But I agree that everybody is quite attached to their cats. Fab. Okay, so that was a real whistle-stop tour of lung function, and I'm happy to answer some more questions. But basically, the crib sheet I have when I'm looking at my lung function reports is I'm going to look at the quality, and in particular, I'm going to ask for the note from the physiologist to see what they thought, because they're the ones that have done the test, and they've also watched the technique. They'll be able to give you a really good readout of that. When they're doing the test with them, particularly if there are learning disabilities, and I'm thinking like neurodiversity or autism in particular, that coordination with doing the test can be really difficult. And one of the things we got quite often come up against is whether or not they've tired while they're doing it. So they do one really good one, but the fact that you have to do 3 to get a true result means that you don't always get great results. And then also the bronchodilator response reversibility, again, if they've got tired from the first time round, sometimes they won't manage it. Check the medications and see whether they had a bronchodilator near to the test. This is particularly important if they're on a MART regime, because they're getting their long-acting beta agonist within that inhaler. The same if they're on seratides. So think about that if they've had to take it near to the time of the test. Is that affected it on the day? Is it obstructive or restrictive? And I would expect to primarily, the majority of lung function that we see in pediatrics is going to be an obstructive picture, unless it's something like a scoliosis or someone with a chest deformity, and then you see a restrictive picture. If it's obstructive, what's their score? So the lower limit of normal is less than 1.64, or percent predicted being less than 80%, diagnostic of asthma. And also if there is a BDR, if it's more than 12% of a change or 200 mils absolute value. Great. And that is me for questions.
Super. Thank you very much, Abby. There are quite a lot of questions on the SMART or the MART, but I'm going to come to that in a second. But before that, there's a very interesting question regarding vaping from Suzanne Dowling. So is vaping so bad as smoking for children with wheeze? And how do you counsel the family?
So we've had a few kids through where the main secondhand exposure, so who's the one vaping, but from a parental secondhand exposure for vape, we've seen significant wheeze related to that. We've had a couple of little children come in, and actually on questioning, the parents have given up smoking and taken up vaping because that's what they were advised to do. But there's still quite a lot of chemicals in the air. And I also think that the tendency with vaping is to not think about it quite the same way as you did with smoking. So there's a tendency to vape inside the house. So you're more likely to be exposed there. The other thing is that if you've got adolescents that are vaping, there are definitely hypersensitivity reactions that you get, but I've had teenagers with significant drops in their lung function from vaping. So my counselling is that unfortunately, even though the NHS suggests that you give up smoking by starting vaping, that actually you shouldn't start vaping at all. And that conversation can be quite difficult, but when you explain it, and particularly with the chemicals aspect of vaping, that seems to work. and seems to be quite a good way to get into that conversation.
Brilliant. So now with MART, so maintenance and reliever therapy, and there was a SMART. So the S is for what? Because I think there was one of the slide which said SMART.
It's Symbicort. That's the name, Symbicort.
Okay.
Yeah, so that's the licensed one.
Sure. And so I think there's a lot of questions regarding whether there's variability in what people are advising on the MART therapy. Someone's mentioned in the Northwest, we say 6 puffs. And if it's not lasting for more than 4 hours, and then that needs sort of escalation. And then there's question about if you can emphasize more or go back onto those slides in terms of how do you advise on the MART therapy and up and down process.
So the MART rescue doses are dependent on which dose you're on. So which inhaler it is, whether it's 100 or a 200. So off the top of my head, the 100/6 inhaler, you can have up to an extra 6 doses, so a total of 8 in the day. And then the 200/6, you can go up to a total of 12, but it's quite clear on that one. And I think it's about, again, it's the rescue treatment is if you get symptoms, you take 1. 5 to 10 minutes, you take another, and you go up to your maximum, which is between the 6 to 8, depending on which inhaler it is.
Sure. I hope the queries have been answered. If not, please do write back on the Qs and As because we've got some time. So I'm going to go to the other questions in that case. And they say, which FENO or spirometry would you recommend in a clinic?
So ideally, I do spirometry on all of them as they come in on each clinic appointment. It's not always time-wise available, and so I think you need to limit when you do it if you've not got access to it regularly, and then use FeNO as a regular test. FeNO, just be aware that it can be changed by if they've got eosinophils anywhere else, but also it can be changed if you've had spinach or beetroot for breakfast. Not that many people have that for breakfast, but it can be affected by other things. So you don't just rely on the FeNO, but if you've got one spirometry that's good, then you could potentially use FeNO at the following tests.
Thank you. And then the other question is there any guidance or support on what works for lifestyle changes / additional support for families as they can be resistant sometimes to find or make it hard to implement changes with treatment?
Yeah, so when they come through the difficult asthma services around the country, one of the big parts of it is compliance with the medication, but it's also all the holistic side of all the lifestyle bits and pieces that we need to change as well. So education around the inhalers, absolutely paramount, but also making sure that they know what their triggers are and how to treat them and how to remove the triggers. So if it's pollen, then remove your exposure to pollen or treat the pollen. But if your exposure is to cats or dogs, then you're going to have to give really good advice on please remove them. And if it's smoking, I know we all know how difficult it is to give up smoking. But that's the thing that we need to address. One thing we haven't really touched on is housing and housing quality, which can have significant impacts on asthma as well. And I can talk for hours on that, but I won't do now. But thinking about adding those additional questions into your history are really important.
So as an add-on question, which is quite provoking, is, well, what if we prove that parents continue to smoke, for example, and whether this needs to be escalated to social services?
I think you need to balance it with how sick the child is. So if the child is having repeated admissions to hospital and their parents are still smoking despite advice, and when they go home they get symptoms and you've shown that actually it probably is still cigarette smoke, then that's a safeguarding concern. They are not providing the safe environment at home for their child to not get sick. The same as if they were going back to that house and it was mouldy, we would really push for social services and housing providers to get rid of the mold. It's the same concept. If they're getting sick regularly, then it is a safeguarding concern.
Fabulous. So a little bit on spirometry question. So do you use FEF 25-75 in clinical practice? And if so, which cases are they particularly used or relevant to your clinical practice?
We don't. We look at it. We don't use it regularly. We focus on, and I would suggest everyone focus on FEV1. It's a useful test to do in terms of monitoring lung development over years. And certainly I use it within our research studies as well.
Okay, thank you. And so to clarify, even with normal FEV1 and FVC and ratio, you still test for reversibility, or is it more than 12% improvement that is indicative of obstructive airways?
I would still test for reversibility in those that have got definite symptoms, because on more than one occasion I've got a kid with an FEV1 within normal limits that then reverses by 30% on top. So actually their normal is 130%. So it's always worth doing.
Okay, and the last question, because I know the rest you'll answer
Mm.
on the chat, particularly somebody's asking for which brand of spirometry and all that. But the last question is, can a viral infection give false positive pheno test result? And if yes, what is the ideal duration of a viral infection to repeat a pheno? In other words, how long does it take for baseline normality?
It doesn't. It's the inflammation in the nose at the time that will trigger your pheno to be higher. So 2 weeks later, I would do the pheno again when they're well, just like you would if they were actively wheezing. It's going to affect your pheno as well.
Sure, wonderful. I'm going to leave Abby for you to respond to all the other questions that are on the chat.
Lovely.
Thank you.
Thank you very much. Thank you. Thanks. Bye-bye.
So without further ado, I'm going to call upon Susie Minson. She is one of the pediatric consultants with interest in nephrology and does joint clinics with the Great Ormond Street Hospital. And her talk is raised creatinine. So I'll be very curious to know what you do when the GP asks for advice and guidance on this one.
Oh, thank you so much. Yes, absolutely. So let me just go ahead and share this. So this, everyone will be pleased to know, is quite a short talk about raised creatinine in childhood. So let me just get started. So yes, absolutely. So I mainly am a general pediatrician, but I do a clinic with Great Ormond Street, and lots of patients that I see are right on that kind of cusp of secondary care and tertiary care. So let's try to sort of think about some of these things. So we're going to cover like what really counts as a raised creatinine and why we worry about that. We'll talk a little bit about the eGFR and how to sort of calculate that and interpret that in children. And we'll think a little bit about what sort of really is renal failure in childhood and how we think about that. A workup for raised creatinine, and then we'll think a little bit about like which children need monitoring in secondary care and what that should look like, and then which children really need to be referred on for more specialist care. So I think the first thing to say is that chronic renal failure, certainly to the point that you're talking about renal replacement therapy in childhood, is really uncommon. But it's also true that children in the UK don't really tend to have like routine bloods taken. So when you get a creatinine result, often you have kind of very little context in which to like interpret that. And it can also be quite tricky just because we know the normal ranges of creatinine will vary both between different labs, but also will be dependent on the height and the muscle mass of the child. So they're always kind of changing throughout childhood. And for any given like creatinine result, it may be physiologically normal for that child, or it might be a reflection of either acute or chronic renal pathology. So we've got to think about kind of untangling all of that. And when I think about like our role as pediatricians, I think what we need to bear in mind is that although end-stage renal failure is rare in childhood, it is really important that we pick up children who have an element of renal impairment or chronic kidney disease, and that for those children, we can kind of optimize their renal care and their health as much as possible. When we look at cohorts of adults that are on renal replacement therapy, so dialysis or transplant, we know that although they may have only needed dialysis and transplant in like middle adult life, actually, for most of them, their renal pathology probably did start in childhood. And I think our job as pediatricians is just to really try to hold off that point that you need renal replacement as long as possible. So for an individual, the difference between, you know, maybe either never needing dialysis or transplant or not needing it till you're in your 60s or 70s is so different from, you know, reaching that point in your 30s or 40s, and makes a massive difference to your health and your life. So I think that's where we really have a key role to play. So as we said, creatinine is going to rise throughout childhood, and you only reach your adult creatinine once you've kind of post-pubertal and finished growing. So especially for boys, it's often only like their late teens, when they've kind of finished growing and bulking up, that you really see them reach a normal adult stable creatinine. And it will also vary, of course, with like hydration status, illness, health. So one of the ways that we can use their height is by calculating the eGFR. So when you get your blood results back with creatinine, the normal range will just be determined by the child's age. So you've put the date of birth in when you've corrected the blood test. But most systems won't actually do a correction for height as well. So this way you can use this calculation, which I've given you, but there's also loads of online calculators. So I tend to use nephron.com in clinic. And this will allow you to account for the height, because usually the normal range is given in bands of ages. So where I work at the Royal London, we have everybody between 4 and 7 years of age will have the same range of creatinine. But if you think of a child that's, 7 and quite tall for their age, they may be actually having a normal creatinine, but it's going to flag up as high. But if you can do this calculation, if the EGFR comes out as greater than 90, you can be reassured that it's normal for their height. So as well as the creatinine, which we've talked a little bit about, when we think about, is this a child with renal pathology, the creatinine's only part of the picture. So first of all, children don't have often a lot of muscle mass, especially if they're little. And so you might not actually see a high creatinine until they've knocked off really quite a lot of renal function. But children who have renal impairment will usually have other features of their pathology, such as hypertension, proteinuria, hematuria. And so you can always interpret the creatinine in the context of all of those other things. And the other thing to bear in mind is that the rise in creatinine through childhood doesn't tend to be linear. You often see quite a big jump at puberty, partly because you have the growth spurt in height, so they are getting a lot taller, but also because you have quite a significant increase in muscle mass. So if children have got 2 readings done, often not very far apart in time, but if that's kind of either side of a big growth spurt, often it will flag as being an AKI often, just because it's such a big jump. But it might also be that that's physiologically normal. So in terms of how to approach a raised creatinine, I think in the history, we need to be asking about whether there's been a significant history of urinary tract infections, either recently or maybe more in early childhood, and also about other periods of significant illness in childhood. So especially if the child has spent, time in the neonatal unit or had an admission to intensive care or an admission with sepsis or something like that, where their kidneys might have taken a hit. So that's really important. Also trying to find out a little bit about what the clinical status of this child was like when those bloods were done. Because as we've touched on, lots of times children only really have bloods if they're acutely unwell. So maybe they just weren't drinking. Antenatal imaging, family history of renal pathology is really important. We know lots of renal pathology is genetic. And then the presence of urinary symptoms. So whether they're having problems with like flow or whether they're seeing hematuria. And then in terms of the clinical examination, as we've said, blood pressure and urine dip are really important. We also want to make sure we've accurately recorded height as well as weight and a sort of global assessment of muscle mass. Pubertal status as well is really important, and then a calculated EGFR like we talked about. In terms of what is normal, I think if the child is well and you've calculated their EGFR and it's normal, even if the creatinine looks high on the results, and they've got a normal blood pressure and they don't have proteinuria, I think that is normal, and those children don't need further investigation and they don't need to have their bloods repeated. If the creatinine's not too much high, but it is high, I would just repeat it when the child is well and that you've made sure they're drinking, and you're interpreting it in the context of the rest of the urine dip. If the creatinine is persistently raised when you repeat it, then those children should have further workup, because these are the ones that, even if it's not that much raised, we want to be kind of getting to the bottom of what is actually happening, so that those are the children we don't want to ignore it and have them progress over time. So I think it's helpful to do a renal ultrasound. That's going to give you a good outline of anatomy and will show you if there's any kind of obvious evidence of sort of one kidney being small and shrunken or there being cysts or something like that. Then blood tests to include a sort of full nephritis screen with complement immunoglobulins. And then, of course, the urine dip and the blood pressure, which we talked about. And then kind of depending on the results and what you've found, as well as kind of what's in the history, think about whether they would be any benefit in doing either a DMSA to look for scarring. So that would be particularly if you thought there was a history of recurrent infections or UTIs, or if on the ultrasound there was kind of real asymmetry. And then the other thing that you might think about doing is a MAG3. So a MAG3 or an MCUG is going to show you how the urine flows through the system, and that might help if you think, again, if there's been infections, if there's significant asymmetry, or if they're having kind of urinary symptoms with like poor flow or incontinence, anything like that. And then in terms of those children that we kind of find that have a sort of element of CKD, sometimes we know why, sometimes we don't, but those children should have ongoing monitoring. So depending on how elevated their creatinine is, I would generally repeat their bloods every 6 to 12 months while they're growing, alongside a urine dip and a blood pressure. And then I would aim to do the ultrasound not too often, but maybe every couple of years, because you just want to check that the kidneys are growing and that they're not developing any problems. And then lifestyle advice for this cohort is really important. And this is like also about like establishing good habits in childhood, which we hope that they're going to take into adult life as well. So really making sure that they know the symptoms to look out for a urinary tract infection, and that if they do think they've got symptoms of a UTI, really low threshold to get their urine dipped and low threshold to initiate antibiotics as well. Because we know that children whose kidneys are already not working at 100% are much more vulnerable to like damage from recurrent UTI or even a mild UTI, even if it only knocks off a modest amount of renal function. They don't have that reserve that maybe another child would have. Maintaining good hydration, regular voiding, and then again, avoiding nephrotoxic drugs is also really important. So making sure that they're not having ibuprofen, certain antibiotics, things like that. And then I think for this group, it's also really important to be vigilant, especially at the time of puberty, because we know that the pubertal growth spurt is going to put additional pressure on the kidneys. So it's not uncommon that we'll have children who, in early childhood when they're quite little, although they might have an elevated creatinine, it's really not that bad. But then actually suddenly when they have their pubertal growth spurt, their EGFR can drop quite significantly just with that increased demand on the kidneys. So I put this slide in because these are things that I get asked about all the time in clinic. So in young people who have a renal impairment, one of the things they always ask me about is protein shakes. So, I mean, probably slightly more common in boys, but definitely not only boys. It's very fashionable at the moment, or it's very popular to have additional protein and to be very conscious of protein in your diet. And it's always tricky for young people with kidney disease. So unless you're properly in end stage, so EGFR right down in the kind of 30s and 40s, it's absolutely fine to have protein. You don't need to restrict protein in your diet. And actually, we know that protein is really important for growth and health. So they should absolutely be having dietary protein, and that's fine. But protein that's in the form of a protein shake, they need to be careful. So if you think about the content of a protein shake, if you've made it up, a typical protein shake would have maybe 20 to 30 grams of protein in one shake, which is similar to like a chicken breast. So it's not it's not necessarily excessive compared to what you could eat. But if you ate a chicken breast, you would have to chew it and then it would have to be broken down and you would absorb that protein relatively slowly. Whereas if you had a shake, you could drink that protein really fast and it's much more rapidly absorbed. And if you have a renal impairment, that can be too much for the kidneys and that can cause sort of more like hyperfiltration of protein, which is quite damaging at the tubular level. So I always tell my patients with CKD not to have protein shakes, and I would encourage them to have dietary protein is fine. They can eat like chicken, eggs, salmon, all those kind of high protein foods. They're good for them, but they shouldn't really be drinking like concentrated protein. It's not good for them and their kidneys can't handle it. So that is important. And then another major issue is dysmenorrhea. So we always say to patients to be really cautious with non-steroidal anti-inflammatories. And in little children, I find that isn't really an issue because they can have, Calpol or other medicines and it's okay. But we know that for dysmenorrhea, non-steroidals are one of the most, they're one of the best groups of drugs. They're really highly effective for dysmenorrhea, probably much more effective than things like paracetamol. And so that is a challenge for girls with CKD, and they've often been really good their whole life at avoiding non-steroidals, and then they suddenly having dysmenorrhea, and it's a real problem. And we also know that dysmenorrhea is something that, for girls who are having a hard time with it, it really impacts like their ability to do things like sport, and it really contributes to girls not doing sport and also to things like school attendance. So we have to balance it. So I would generally recommend girls to try, if they're really struggling, they can't manage without non-steroidals, mefenamic acid is a good option. It's not as harsh on the kidneys as ibuprofen. And also kind of having a conversation with them so that you're not saying, well, you just can't take it, because that's maybe not helpful, but trying to find a strategy with them where they're able to take like mefenamic acid or another non-steroidal just for the shortest time possible. So maybe not for all of the days or all of the time that they have dysmenorrhea, but maybe for the worst time, and that they're also using other options like paracetamol, maybe when they don't need something quite as strong. And then UTIs is another key thing. So if patients are having UTIs, it's really important, as we discussed, to kind of treat them quickly. We don't want them to be having recurrent UTIs. And I think if young people or children with known CKD are having UTIs, first thing I would say is I would have a lower threshold to treat with IV antibiotics if they're at all unwell, because we know that that will help them probably help them clear the kidney, the infection more quickly. But I would also have a low threshold to also give them IV fluids if they had a UTI, because we know that kind of maintaining hydration also helps to protect renal health. So if they're known to have renal impairment, think about kind of how you would manage a UTI. But also if they are having, certainly if they're having recurrent UTIs, again, in this group, I would have a really low threshold to use prophylactic antibiotics, because we really do want to protect their renal function. And this is exactly the kind of thing that, really probably will make a difference in their long-term renal health in their middle adult life. So really important as well. And then the last thing I was going to touch on is which of the children that we're seeing with chronic renal impairment would really need to go to a tertiary nephrology clinic. So the vast majority of children that, if I think about my cohort, most of them don't need to go to a tertiary centre. Most of them just need monitoring and have got a kind of EGFR in the kind of, I don't know, like the maybe between 50 and 70, that kind of range, or even better than 70. But some children do need tertiary care. And the ones that are going to benefit from tertiary referral are the ones where we want to pick up what underlying pathology is driving their renal impairment. So for children who have a mild renal impairment or a relatively fixed renal impairment, where their investigations are normal, it's likely that this is a congenital thing that they were born with, or it's from a hit to their kidneys in relatively early childhood that is essentially stable, and you are just trying to avoid it getting worse and help them cope with it as they grow. But if they've got a very rapidly deteriorating creatinine, it's more likely that they may have something underlying this that's a kind of progressive pathology. So something like a nephritis or focal segmental glomerulosclerosis, or some sort of process where there might be a benefit from giving them really aggressive immunosuppression. And for that group of children, they would need to have a biopsy to look at what's going on in more detail in terms of the pathology and the histology of their kidney. And that would normally be at a tertiary centre. So any child who's kind of going off quickly, I would always want to refer them. And then the other groups are really children who where their renal impairment is getting worse quite rapidly, or getting worse over time, and you think that they're heading towards end-stage renal failure. So certainly children whose, once their GFR is kind of down below 40, we know that maybe they don't need dialysis or transplant this year, or maybe even not next year, but it's not going to be that long, and they will probably benefit from a referral, just so we can start working them up. But we know that it takes a bit of time, and children are much more likely to have a good outcome if they've had a sort of organized, slow workup of their kidney and time to think about these things. So I would always think about those children, and then also if they would benefit from a kind of specialist MDT. So we know that in a tertiary centre there's going to be like a renal dietitian and psychology and like the specialist nurses that we wouldn't necessarily expect to have access to in secondary care. So for that group as well, if they would benefit from the MDT, I would think about referring them. So generally, the kids I'm going to refer: rapidly deteriorating renal function, those who have significant albuminuria that is out of keeping with what you'd expect for renal impairment, because again, we know that those children will be likely to benefit from potentially like a renal biopsy to look for their pathology. Children, as we said, the EGFR is getting below 40 to 50, because again, that's starting to get towards thinking about renal replacement therapy, or starting to have those conversations, or if they've got deranged biochemistry, so really significant like renal osteodystrophy, just because again, they're the ones that are going to benefit from like the MDT support with the dietitian advising them. But generally speaking, in my experience anyway, the number of children that actually need to go to tertiary nephrology is quite small. Okay, so in summary, we have talked about raised creatinine, and that actually it's quite a common finding and maybe physiologically normal for any children that you see, but also that a significantly raised creatinine, or one that's rising quickly or is associated with other findings that are worrying, are much more likely to have underlying pathology. Most children, as we said, can be monitored in secondary care, but there will be some that will benefit from tertiary referral. Thank you.
Brilliant. It's a whistle-stop tour on raised creatinine. Thank you so much, Susie. There are a few questions, and because you're quite on time, I'm just going to quickly ask them. There's an interesting one. How would you manage a teenager with eating disorder with raised creatinine and urea, but normal electrolytes? Is this because their intake is so poor?
Yeah, I mean, I think that's a really it's always really tricky with children who have a kind of another pathology. So in eating disorders, I think the creatinine can honestly go either way in my experience. So often young people with eating disorders, they often don't have a lot of muscle mass. So the creatinine is, in my experience, more typically low. And actually, if the creatinine's high and they look like they don't have very much muscle mass, that's probably a little bit more worrying because it might mean that you're underestimating their GFR. But again, it may also be like hydration status, especially if they're quite fluid restricted. And generally speaking, I guess you'd be worried about whether they are maintaining hydration. I think again, it would be like this would be a case where I would really want to interpret it in the context of the rest of their picture. So if they have proteinuria, if they have any signs of hematuria, if their blood pressure is high, that would be worrying. But I think it's more typical in eating disorders to see the very low urea and creatinine reflecting kind of low muscle mass and poor nutrition.
Thank you. There are a couple of questions on cystatin C and what are your thoughts about them with persistently raised creatinine, especially where the levels are influenced by age, sex, diet, etc., before the radiological investigations?
Yeah, so I mean, cystatin C is a blood test that you can do. So it's not available everywhere. We don't actually have it at the Royal London. I know they have it at Great Ormond Street. So cystatin C is often used if you think exactly that your kind of creatinine is being excessively influenced by muscle mass or lack of muscle mass or a child that's kind of nutritional status is off. So cystatin C is an option. It very much depends if it's available to you, but yeah, that would also be an option. It's probably slightly more accurate than the eGFR in giving you a assessment of whether the creatinine is off or not. And it's certainly something that, if you were referring to a tertiary center and for a child that you were wondering if they needed a biopsy, for example, they may well offer that before proceeding to invasive tests.
Brilliant, thank you. And the last one I'm going to ask, and the rest you can answer eventually later. So this is an important one. What about protein shakes in healthy teenagers? Quite common today. And what are the renal risks?
So, I mean, it's such a good question. So I think protein shakes are so popular that I think so many of the young people are having them. And I think that the risk for a healthy teenager, so somebody with normal renal function, of drinking a protein shake is probably minimal because, as we said, that a protein shake made up correctly does not contain a massive, massive amount of protein. I think what I would be worried about with teenagers, and I say this as a mum of teenagers as well, is that whether they're gonna make it up correctly and whether they're gonna stick to one, because we know teenagers can be quite all or nothing. So like, although one protein shake is probably gonna be fine, like 3 protein shakes in a day is a lot of protein, probably more protein than you could realistically eat, especially if they've had dietary protein as well. So I would say to be cautious. I haven't actually seen young people who've had I don't think I've seen any young people who've kind of given themselves a renal impairment from excessive protein shakes, but I do think it is something that the intake of protein from those shakes is more than young people have historically had, and I think it will be interesting to see over time if we do see any evidence that there has been damage from protein shakes. But generally speaking, I would say that if a young person who has normal renal function wants to have protein shakes, I think that's okay. I think it's probably overall more healthy to have dietary protein as part of a mixed healthy diet. But if they want to have protein shakes, I think it's okay. But I would tell them to go easy, not to have like more than one a day and to make it up following the instructions on the pack.
Yeah, I agree. I know that there was a case about a metabolic problem in a child, and then they were taking protein shakes, and it was quite untoward incident. So yeah, always with caution. So that was wonderful, Susie, and I'm going to hand over to Akshay again because we have come to the end of the presentations. So thank you so much for logging in and joining in. Thank you.
Thank you, Anshu. Thank you, Susie.